चेक माइक टेस्ट चेक नेपाल स्वास्थ्य अनुसन्धान परिषदको 7औं राष्ट्रिय स्वास्थ्य तथा जनसङ्ख्या वैज्ञानिक नमस्कार। आज मिति 2078 साल असार 17 गते तदनुसार जुलाई 1, 2021 बिहिबारका दिन यस नेपाल स्वास्थ्य अनुसन्धान परिषदद्वारा आयोजित स्वास्थ्य तथा जनसङ्ख्या वैज्ञानिकहरूको 7औं राष्ट्रिय शिखर सम्मेलनमा सहभागी तपाईँ सम्पूर्ण महानुभावहरूलाई हार्दिक स्वागत गर्न चाहन्छु। म कार्यक्रम उद्घोषिका शोभिता गौतम। समादरणीय दर्शक महानुभावहरू, नेपाल स्वास्थ्य अनुसन्धान परिषदले सन् 2015 देखि नै आफ्नो स्थापना दिनको अवसर पारेर यस स्वास्थ्य तथा जनसङ्ख्या वैज्ञानिकहरूको राष्ट्रिय सम्मेलन आयोजना गर्दै आइरहेको छ। तर कोभिड महामारीको कारण विगतको वर्षमा चाहिँ हामीले यस वर्ष पनि कार्यक्रमलाई केही ढिला सारेका छौँ। अर्थात् अप्रिल 11 र 12 मा हुने यस सम्मेलन जुलाईको 1 र 2 तारिकमा आयोजना गरिरहेको छ। रिसर्च इन पब्लिक हेल्थ इमर्जेन्सिज एभिडेन्स टु पोलिसी एन्ड एक्सन अर्थात् जनस्वास्थ्य सङ्कटको बेला अनुसन्धान नीति तथा कार्यान्वयनको लागि प्रमाण भन्ने नाराका सहित यस कार्यक्रम सञ्चालन गरिरहेको छ। यस कार्यक्रममा हामीसँग जम्मा स्वास्थ्य तथा जनसङ्ख्यासँग सम्बन्धित विषयमा स्वदेशी तथा विदेशी अनुसन्धानकर्ताहरूले आफ्नो खोज तथा अनुसन्धानका बारेमा 47 वटा अनुसन्धानमूलक कार्यहरूको मौखिक प्रस्तुति र 19 वटा पोस्टर प्रस्तुति र 24 वटा आमन्त्रित प्रस्तुतिकरण रहनेछन्। अब कार्यक्रमलाई औपचारिक सुरुवात गर्नको निम्ति म सर्वप्रथम नेपाल स्वास्थ्य अनुसन्धान परिषदका अध्यक्ष प्राध्यापक डाक्टर गेहनाथ बरालज्यूलाई सभापतिको आसन ग्रहण गरिदिनु हुनको निम्ति हार्दिक अनुरोध गर्न चाहन्छु।
नमस्ते। म उद्घोषकज्यूलाई कार्यक्रम सञ्चालन गर्न अनुमति दिन्छु।
मैले अनुमति पाइसकेको छु। अब त्यसै गरी अब अतिथिहरूको आसन ग्रहण गर्ने कार्यक्रम रहेको छ। सर्वप्रथम अतिथिको आसन ग्रहण गरिदिनु हुनको निम्ति आजको यस सम्मेलनमा प्रमुख अतिथिको आसन ग्रहण गरिदिनु हुनको निम्ति स्वास्थ्य तथा जनसङ्ख्या मन्त्रालयका माननीय मन्त्री श्री गोपाल कृष्ण श्रेष्ठज्यूलाई हार्दिक अनुरोध गर्न चाहन्छु। माफ गर्नुहोला, स्वास्थ्य तथा जनसङ्ख्या मन्त्रालयका माननीय मन्त्री श्री कृष्ण गोपाल श्रेष्ठज्यूलाई हार्दिक अनुरोध गर्न चाहन्छु। साथै उहाँलाई फूल तथा खादाले स्वागत गरिदिनु हुनको निम्ति पनि अनुरोध गर्न चाहन्छु। हामीले यो कार्यक्रम जुम मार्फत आयोजना गरिरहेका छौँ। त्यसैले यस कार्यक्रममा 7 प्रदेशका मुख्यमन्त्रीज्यूहरू पाल्नु भएको छ। उहाँहरूलाई पनि यथास्थानमा आसन ग्रहण गरिदिनु हुनको निम्ति अनुरोध गर्न चाहन्छु। साथै 7 प्रदेशका सामाजिक तथा स्वास्थ्य मन्त्रीज्यूहरूलाई पनि आसन ग्रहणको निम्ति अनुरोध गर्न चाहन्छु। त्यसैगरी आजका यस कार्यक्रमका कीनोट स्पिकर डाक्टर पूनम क्षेत्रपाल सिंह विश्व स्वास्थ्य सङ्गठनका साउथ इस्ट एसिया रिजन अफिसका रिजनल डिरेक्टर हुनुहुन्छ। उहाँलाई पनि आसन ग्रहणको निम्ति हार्दिक अनुरोध गर्न चाहन्छु। त्यसैगरी 7 प्रदेशबाट पाल्नुभएका सामाजिक तथा स्वास्थ्य 7 प्रदेशबाट पाल्नुभएका मन्त्रालयका सचिवज्यूहरूलाई पनि आसन ग्रहणको निम्ति हार्दिक अनुरोध गर्न चाहन्छु। त्यसैगरी आसन ग्रहणकै निम्ति नेपाल स्वास्थ्य अनुसन्धान परिषदका उपाध्यक्ष प्राध्यापक डाक्टर गौरवराज ढकालज्यूलाई पनि ड्यासमा आएर आसन ग्रहण गरिदिनु हुनको निम्ति अनुरोध गर्न चाहन्छु। त्यसैगरी हामीसँग हुनुहुन्छ विश्व स्वास्थ्य सङ्गठनका नेपालका कन्ट्री डिरेक्टर राजेश सम्बाजीराव पाण्डवज्यूलाई पनि ड्यासमा आएर आसन ग्रहण गरिदिनु हुनको निम्ति अनुरोध गर्न चाहन्छु। त्यसैगरी यस नेपाल स्वास्थ्य अनुसन्धान परिषदका कार्य समितिका सम्पूर्ण पदाधिकारीज्यूहरूलाई पनि यथास्थानमा आसन ग्रहण गरिदिनु हुनको निम्ति अनुरोध गर्न चाहन्छु। त्यसैगरी ड्यासमा आएर आसन ग्रहण गरिदिनु हुनको निम्ति नेपाल स्वास्थ्य अनुसन्धान परिषदका सदस्य सचिव कार्यकारी प्रमुख डाक्टर प्रदीप ग्यावलीज्यूलाई पनि हार्दिक अनुरोध गर्न चाहन्छु। त्यसैगरी पूर्व पदाधिकारीज्यूहरू तथा स्वास्थ्य मन्त्रालय एवं विभागका पदाधिकारीज्यूहरूलाई पनि यथास्थानमा आसन ग्रहण गरिदिनु हुनको निम्ति हार्दिक अनुरोध गर्न चाहन्छु। हाम्रो यस कार्यक्रममा जुम मार्फत इजरायलका लागि नेपालका राजदूत डाक्टर अन्जान साक्य पनि उपस्थित हुनुहुन्छ। उहाँलाई पनि यथास्थानमा आसन ग्रहण गरिदिनु हुनको निम्ति अनुरोध गर्न चाहन्छु। त्यसैगरी यस कार्यक्रममा उपस्थित हुनुभएका सम्पूर्ण पत्रकार मित्रज्यूहरू, आमन्त्रित सम्पूर्ण व्यक्तित्वहरू तथा यस कार्यक्रममा हुनुभएका सम्पूर्ण महानुभावहरूलाई हार्दिक स्वागत गर्न चाहन्छु। साथै हाम्रा सम्पूर्ण अतिथिज्यूहरूलाई खादा तथा मालाले सम्मान गरिदिनु हुनको निम्ति हार्दिक अनुरोध गर्न चाहन्छु। हाम्रो यस कार्यक्रममा इडिसिटीका डिरेक्टर डाक्टर कृष्ण पौडेल पनि उपस्थित हुनुहुन्छ। त्यसैगरी हामीसँग मन्त्रालयका स्वकीय सचिव, माफ गर्नुहोला, स्वास्थ्य तथा जनसङ्ख्या मन्त्रालयका प्रवक्ता डाक्टर कृष्ण पौडेल पनि उपस्थित हुनुहुन्छ। त्यसैगरी मन्त्रालयका स्वकीय सचिव मोहिनी झाज्यू पनि उपस्थित हुनुहुन्छ। माफ गर्नुहोला, स्वास्थ्य तथा जनसङ्ख्या मन्त्रालयका स्वकीय सचिव मेदिनी काफ्लेज्यू पनि उपस्थित हुनुहुन्छ। अब यस कार्यक्रमलाई उद्घाटन गर्नको निम्ति म सर्वप्रथम प्रमुख अतिथिज्यूलाई स्विच थिचेर कार्यक्रमको उद्घाटन गरिदिनु हुनको निम्ति हार्दिक अनुरोध गर्न चाहन्छु। धन्यवाद। अब हामीसँग यस नेपाल स्वास्थ्य अनुसन्धान परिषदको 30 वर्षलाई समेटेर बनाएको एउटा पुस्तक रहेको छ। त्यो पुस्तकको विमोचन गरिदिनु हुनको निम्ति माननीय मन्त्री कृष्ण गोपाल श्रेष्ठज्यूलाई हार्दिक अनुरोध गर्न चाहन्छु। धन्यवाद। अब कार्यक्रमलाई अगाडि बढाउने क्रममा म सर्वप्रथम स्वागत मन्तव्य राखिदिनु हुनको निम्ति म नेपाल स्वास्थ्य अनुसन्धान परिषदका सदस्य सचिव कार्यकारी प्रमुख डाक्टर प्रदीप ग्यावलीज्यूलाई हार्दिक अनुरोध गर्न चाहन्छु।
धन्यवाद सविताजी। आजको यस 7औं स्वास्थ्य जनसङ्ख्या वैज्ञानिकहरूको राष्ट्रिय शिखर सम्मेलन का सभापति, नेपाल स्वास्थ्य अनुसन्धान परिषदका अध्यक्ष प्राध्यापक डाक्टर गेनाथ बरालज्यू, स्वतन्त्र जनसङ्ख्या मन्त्री माननीय श्री कृष्ण गोपाल श्रेष्ठज्यू, लुम्बिनी प्रदेशका मुख्यमन्त्री माननीय शङ्कर पोखरेलज्यू, अन्य मन्त्रीज्यूहरू, श्री स्वास्थ्य जनसङ्ख्या मन्त्रालयका सचिव लक्ष्मण अरालज्यू, उहाँ अहिले केही समय ढिला हुन्छ भन्नुभएको छ, आउँदै हुनुहुन्छ। एन्ड कीनोट स्पिकर अफ दि सेरेमनी रिजनल डाइरेक्टर अफ WHO डाक्टर पुनम क्षेत्रपाल सिंहजी, नेपाल स्वास्थ्य अनुसन्धान परिषदका उपाध्यक्ष प्राध्यापक डाक्टर गौरराज ढकालज्यू, साथै प्रदेश मन्त्रालयका सचिवज्यूहरू, WHO रिप्रेजेन्टेटिभ टु नेपाल डाक्टर राजेश एस पाण्डवज्यू, नेपाल स्वास्थ्य अनुसन्धान परिषदका कर्मचारी कार्यकारी समितिका सदस्यज्यूहरू, पूर्व पदाधिकारीज्यूहरू, स्वास्थ्य जनसङ्ख्या मन्त्रालय एवं विभागहरूका पदाधिकारीज्यूहरू, पत्रकारज्यूहरू, सम्पूर्ण आमन्त्रित अनलाइन इन पर्सन अतिथिज्यूहरू, त्यस्तै गरी स्वास्थ्य जनसङ्ख्या मन्त्रालयका प्रवक्ता तथा EDCका डाइरेक्टर डाक्टर कृष्ण पौडेलज्यू, हामीसँग मेदिनी काफ्लेजी पनि यहाँ उपलब्ध हुनुहुन्छ, उहाँलाई पनि स्वागत गर्न चाहन्छु। त्यस्तै गरी स्वास्थ्य जनसङ्ख्या मन्त्रालयका चाहिँ स्वकीय प्रकाश अधिकारीज्यू लगायत सम्पूर्ण उपस्थित कर्मचारी साथीहरू र अन्य उपस्थित मित्रहरू, पत्रकार मित्रहरू, हाम्रो निमन्त्रणालाई स्वीकार गरी पाल्नुभएका पाहुनाहरू तथा भर्चुअली सहभागी हुनुभएका सम्पूर्ण सहभागीज्यूहरूलाई नेपाल स्वास्थ्य अनुसन्धान परिषदद्वारा आयोजित 7औं राष्ट्रिय स्वास्थ्य जनसङ्ख्या वैज्ञानिकहरूको शिखर सम्मेलनमा हार्दिक स्वागत गर्न चाहन्छु। यस शिखर सम्मेलनले अन्तर्राष्ट्रिय अनुसन्धानबाट उदीयमान जनस्वास्थ्यका मुद्दाहरूलाई सम्बोधन गर्नेछ। नेपाल स्वास्थ्य अनुसन्धान परिषदले सन् 2015 देखि प्रत्येक वर्ष आफ्नो स्थापना दिवसको अवसर पारेर अप्रिल 11 र 12 तारिकमा राष्ट्रिय शिखर सम्मेलन आयोजना गर्दै गइरहेको छ। कोभिड-19 को महामारीको कारण गत वर्ष पनि हामीले 6औं राष्ट्रिय शिखर सम्मेलन भर्चुअली नै आयोजना गरेका थियौँ। साथै यस वर्ष पनि परिषदको वार्षिक उत्सवमा स्थगन गरिएको 7औं राष्ट्रिय शिखर सम्मेलन आज भर्चुअली आयोजना गरी तपाईहरुलाई स्वागत गर्न पाउँदा म अत्यन्त हर्षित छु। यहाँहरूलाई अवगत नै छ, नेपाल स्वास्थ्य अनुसन्धान परिषदले स्थापना कालदेखि नै नेपालमा स्वास्थ्यसँग सम्बन्धित अनुसन्धान प्रवर्धन तथा नियमन गर्नुका साथै प्रमाणका आधारमा नीति निर्माण तर्जुमा गर्न अनुसन्धान तथ्याङ्क र प्रतिवेदनहरू सार्वजनिक गर्दै आइरहेको छ। यसका अतिरिक्त परिषदले युवा अनुसन्धानकर्ता र अनुसन्धानमा चासो राख्ने विद्यार्थीहरूका लागि तालिम, कार्यशाला, गोष्ठी तथा क्षमता अभिवृद्धिका लागि विविध गतिविधिहरू सञ्चालन गर्दै अनुसन्धान संस्कृतिको विकास र प्रवर्धन गर्दै आइरहेको छ। नेपालमा हुने गरेको अनुसन्धानहरूलाई अन्तर्राष्ट्रिय मापदण्ड अनुसार बनाउनको लागि नेपाल स्वास्थ्य अनुसन्धान परिषदले धेरै उपलब्धि हासिल गरिसकेको छ। नेपाल स्वास्थ्य अनुसन्धान परिषद अन्तर्गत रहेको इथिकल रिभ्यू बोर्ड ERB ले सन् 2019 मा दि फोरम फर इथिकल रिभ्यू कमिटिज इन द एसियन एन्ड वेस्टर्न पेसिफिक रिजन फर्क्याप भन्ने संस्थाद्वारा अन्तर्राष्ट्रिय मान्यता प्राप्त गरिसकेको छ। त्यसै गरी परिषदको जर्नल अफ नेपाल हेल्थ रिसर्च काउन्सिल JNHRC पनि इन्टरनेसनल डाटा सेन्टरमा इन्डेक्सिङ भइसकेको छ। JNHRC को नेपालभरिका मेडिसिनसँग सम्बन्धित र स्वास्थ्यसँग सम्बन्धित जर्नलहरू नेपमेड मार्फत एकै ठाउँमा एकीकृत गरी जर्नलको गुणस्तर तथा प्रकाशनमा एकरूपता ल्याई बौद्धिक चोरी, जसलाई प्लेगियरिज्म भनिन्छ, न्यून पार्ने योजनामा परिषद रहेको छ। परिषदलाई अनुसन्धानको क्षेत्रमा उत्कृष्ट केन्द्रको रूपमा विकास गर्ने र मुलुकमा अनुसन्धानको वातावरण प्रदान गर्ने उद्देश्यले परिषदले अनुसन्धानसँग सम्बन्धित धेरै राष्ट्रिय तथा अन्तर्राष्ट्रिय सङ्घ संस्था तथा विश्वविद्यालयहरूसँग सम्झौता पनि गरेको छ। नसर्ने रोगहरूको राष्ट्रिय सर्वेक्षण 2013 र 19, राष्ट्रिय मानसिक स्वास्थ्य सर्वेक्षण, नेपालमा जनसङ्ख्यामा आधारित नसर्ने रोगहरूको सर्वेक्षण, जनसङ्ख्यामा आधारित क्यान्सर रजिस्ट्री, क्लिनिकल ट्रायल रजिस्ट्री लगायतका परिषदद्वारा सञ्चालित महत्त्वपूर्ण अनुसन्धानहरूले नेपालको स्वास्थ्य नीति र योजनाहरू तर्जुमा गर्ने महत्त्वपूर्ण भूमिका खेलेको सर्वविदित छ। कोभिड-19 को महामारीले स्वास्थ्यमा विशेष गरी सङ्क्रामक रोगको क्षेत्रमा अनुसन्धानको महत्त्व र आवश्यकतालाई उजागर गरिदिएको छ। त्यसै कारणले सरकारले गत आर्थिक वर्षको बजेट भाषणमा परिषदलाई सङ्क्रामक रोग अनुसन्धान केन्द्रको रूपमा विकास गर्ने कुरा उल्लेख पनि गरिएको थियो, जुन हामी सबैको लागि गौरवको विषय हो। आजको युग प्रविधिको भएकोले परिषद अनुसन्धानसँग सम्बन्धित सम्पूर्ण कार्यहरू प्रविधि मैत्री बनाउने योजनामा अगाडि बढिसकेको छ। नेपाल स्वास्थ्य अनुसन्धान परिषद स्वास्थ्यसँग सम्बन्धित विविध विषयमा अध्ययन अनुसन्धान गराउने तथा नियमन गर्ने निकाय समेत भएकाले छरिएर रहेका राष्ट्रिय तथा अन्तर्राष्ट्रिय सङ्घ संस्था, सरकारी गैर सरकारी सङ्घ संस्था, विश्वविद्यालय तथा त्यस अन्तर्गतका निकायहरूलाई स्वास्थ्य अनुसन्धानका क्षेत्रहरूमा एकीकृत गर्दै नियमन गर्ने कार्यमा परिषद निरन्तर लागि क्रियाशील छ। साथै परिषदले अनुसन्धानकर्ता र अनुसन्धानसँग सम्बन्धित संस्थाहरू बीचको समन्वय र सहकार्यलाई समेत उच्च प्राथमिकता दिँदै अगाडि बढिरहेको छ। राष्ट्रिय स्वास्थ्य नीति 2076 र नेपाल स्वास्थ्य अनुसन्धान रणनीति 2076ले 7वटा प्रदेशमा प्रदेश सरकार सरकार तथा सम्बन्धित सरकारवालाहरूको समन्वयमा परिषदको इकाइ कार्यालयहरू स्थापना गर्ने कुरा उल्लेख भए अनुरूप यसको प्रक्रिया अन्तिम चरणमा पुगिसकेको छ। नयाँ आर्थिक वर्षको प्रारम्भसँगै 7 प्रदेशमा नेपाल स्वास्थ्य अनुसन्धान परिषदको इकाइ कार्यालय विस्तार हुने बेहोरा पनि अवगत गराउन चाहन्छु। नेपाल स्वास्थ्य अनुसन्धान परिषदले कोभिड-19 महामारी देखा परे पश्चात कोभिड-19सँग सम्बन्धित विविध विषयहरूमा अध्ययन अनुसन्धान गराउने अनुसन्धानकर्ताहरूको क्षमता वृद्धि गराउने हेतुले भर्चुअल विधिबाट तालिमहरू प्रदान गर्ने, अनुसन्धानका प्रतिवेदनहरू विज्ञहरूको उपस्थितिमा प्रबोधीकरण गर्ने लगायतका कार्यहरू गर्दै आइरहेको छ। अनुसन्धानकर्ताको सहजताको लागि पनि परिषदले कोभिड महामारी सुरु भए पश्चात लाइब्रेरी मार्फत अनलाइन सेवाहरू प्रदान गरिरहेको छ। विगत 30 वर्षको तुलनामा गएको 1 वर्षभित्र तालिम लिनेहरूको सङ्ख्या हेर्दा हालसम्म केही तालिम लाभकर्ताभन्दा दोब्बर रहेको तथ्याङ्कले देखाएको छ। कोभिड-19ले विश्वभर सङ्कट सिर्जना गरेको बेला परिषद नेपालमा कोभिड-19को खोप ट्रायल मार्फत जनतालाई खोप सुनिश्चित गर्ने दिशातर्फ अग्रसर रहेको कुरा यहाँ जानकारी गराउन चाहन्छु। नेपाल स्वास्थ्य अनुसन्धान परिषद भविष्यमा अध्ययन अनुसन्धानहरूलाई औपचारिक शिक्षासँग जोड्ने उद्देश्यले 1 वर्षीय रिसर्च कोर्स सञ्चालन गर्ने तयारीमा रहेको छ। राष्ट्रिय अन्तर्राष्ट्रिय शैक्षिक संस्थासँग आबद्ध रहेर नेपाल मेडिकल काउन्सिल तथा चिकित्सा आयोगको निर्देशिका अनुसार फेलोसिप, मास्टर्स तथा PhD प्रोग्रामहरू लगायतका कोर्सहरू परिषदले निकट भविष्यमा सञ्चालन गर्ने तयारी गरेको छ। साथै सोही निर्देशिका बमोजिम नै ब्याचलर तथा मास्टर्समा अनिवार्य रूपमा रिसर्चका पाठ्यक्रम सिलेबसहरूलाई समावेश गर्न पहल गर्ने योजना रहेको छ। क्लिनिकल रिसर्च तथा क्लिनिकल ड्रग डेभलपमेन्ट गर्ने हेतुले क्लिनिकल रिसर्च युनिट, बायोमेडिकल रिसर्च ल्याब स्थापना तथा अस्पताल अन्तर्गतको अनुसन्धान, ड्रग तथा भ्याक्सिन ट्रायल जसलाई RCT भनिन्छ लगायतका स्तरीय अध्ययन अनुसन्धान गठित गरी नेपाल अनुसन्धान मार्फत समृद्ध, समुन्नत तथा अन्तर्राष्ट्रियकरण गर्ने जमर्कमा परिषद अहोरात्र खटिरहेको छ। त्यसै गरी परिषद नेपालको क्लिनिकल ट्रायल रजिस्ट्रीलाई विश्व स्वास्थ्य सङ्गठन ICTRPसँग मान्यता प्राप्त गर्ने प्रक्रियामा रहेको छ। त्यसै गरी अनुसन्धानसँग सम्बन्धित इथिकल इस्युहरू सुदृढ गर्नलाई इन्स्टिट्युसन रिभ्यू कमिटीलाई थप सशक्त बनाउने क्रम जारी रहेको छ। अन्त्यमा परिषद मार्फत हुने वैज्ञानिक अध्ययन अनुसन्धानहरूलाई स्वतन्त्र, निष्पक्ष र पारदर्शी बनाई अनुसन्धानकर्ताको उच्च मनोबल कायम राखी नेपालमा अनुसन्धान संस्कृतिको प्रवर्धन गर्न सकेको खण्डमा राष्ट्रलाई अनुसन्धान मार्फत अगाडि बढाउन कुनै पनि बाधाको सामना गर्नुपर्ने छैन। यस शिखर सम्मेलनमा फेरि पनि सबैलाई स्वागत गर्दै कार्यक्रमको सफलताको कामना गर्छु। धन्यवाद।
धन्यवाद डाक्टर ग्यावली। हामी अब कार्यक्रमलाई औपचारिक रूपमा सुरु गर्नको निम्ति सर्वप्रथम राष्ट्रिय गानबाट सुरु गर्न गइरहेका छौँ। सबैजनालाई यथास्थानमा उठिएर राष्ट्रिय गानको निम्ति अनुरोध गर्न चाहन्छु।
ढुङ्गा फुलका हामी एउटै माला नेपाली सार्वभौमै फैलिएका मेची महाकाली। सायो ढुङ्गा फुलका हामी एउटै माला नेपाली सार्वभौमै फैलिएका मेची महाकाली। प्रकृतिका कोटि कोटि सम्पदाको आचल वीरहरूका राजकार्य स्वतन्त्र अचल। ज्ञान भूमि शान्ति भूमि तराई पहाड हिमाल अखण्ड यो प्यारो हाम्रो मातृभूमि नेपाल। बहु जाति भाषा धर्म संस्कृति सन्देशाला अग्रगामी राष्ट्र हाम्रो जय जय नेपाल।
धन्यवाद। समादरणीय दर्शक महानुभावहरू, हाम्रो यस 7औं राष्ट्रिय स्वास्थ्य तथा जनसङ्ख्या वैज्ञानिकहरूको सम्मेलनमा सम्माननीय प्रधानमन्त्री केपी शर्मा ओलीज्यू उपस्थित हुने कुरा थियो, तर कार्यव्यस्तताको कारणले गर्दा उहाँ उपस्थित हुन सक्नु भएको छैन। तर उहाँले हामीलाई सन्देश पठाउनु भएको छ र सो सन्देश वाचन गरिदिनु हुनको निम्ति म परिषदका सदस्य सचिव डाक्टर ग्यावलीलाई हार्दिक अनुरोध गर्न चाहन्छु।
पुनः स्वागत गर्न चाहन्छु। माननीय मन्त्रीज्यू, अध्यक्ष लगायत सम्पूर्ण उपस्थित चाहिँ सर म्याडमहरू, मैले अघि चाहिँ सम्बोधन गर्न बिर्सेछु। हाम्रो इजरायलको मामिम राजदूत हुनुहुन्छ डाक्टर अन्जान साके, उहाँलाई पनि म स्वागत गर्न चाहन्छु। र म सम्माननीय प्रधानज्यूबाट हामीलाई शुभकामना सन्देश प्राप्त भएको छ, यो म वाचन गर्न चाहन्छु। प्रधानमन्त्री, शुभकामना। नेपालको स्वास्थ्य क्षेत्रलाई प्रभावकारी, सक्षम र सशक्त बनाउने उद्देश्यले लामो समयदेखि अध्ययन तथा अनुसन्धानमा क्रियाशील नेपाल स्वास्थ्य अनुसन्धान परिषदको 30औं वार्षिकोत्सवका अवसरमा आज स्वास्थ्य तथा जनसङ्ख्या वैज्ञानिकहरूको 7औं राष्ट्रिय शिखर सम्मेलन सफलताको हार्दिक शुभकामना व्यक्त गर्दछु। नवप्रवर्तनमा संलग्न सबै वैज्ञानिक अनुसन्धानदाताहरूलाई यस दिवसको अवसरमा हार्दिक बधाई समेत दिन चाहन्छु। नेपालको संविधानले प्रत्येक नागरिकलाई राज्यबाट आधारभूत स्वास्थ्य सेवा निःशुल्क प्राप्त गर्ने र स्वास्थ्य सेवामा समान पहुँचको हकको व्यवस्था गरेको छ। यसका साथै बालबालिका, महिला तथा अन्य समुदायलाई स्वास्थ्य क्षेत्रमा विशेष व्यवस्थाहरू गरेको छ। जनताको आधारभूत अवस्थाको रूपमा रहेको स्वास्थ्य सम्बन्धी अधिकारलाई प्रभावकारी रूपमा प्रत्याभूत गर्न यस क्षेत्रमा निरन्तर अध्ययन, अनुसन्धान र विकास हुनु जरुरी छ। अहिले विश्वव्यापी महामारीको रूपमा फैलिएको कोभिड-19ले वैज्ञानिक अध्ययन अनुसन्धानको महत्त्वलाई झनै उजागर गरेको छ। साथै कोभिड-19को दोस्रो लहरले यस तथ्यलाई समेत पुष्टि गरेको छ। स्वास्थ्य क्षेत्रको सामर्थ्य विस्तार, अध्ययन, अनुसन्धान र विकासका लागि यस सम्मेलनले महत्त्वपूर्ण भूमिका खेल्नेछ भन्ने मैले विश्वास लिएको छु। आफ्नो स्थापना कालदेखि नेपाल स्वास्थ्य अनुसन्धान परिषदले स्वास्थ्य क्षेत्रमा भएका अनुसन्धानका लागि नियमन गर्ने, गुणस्तरीय अनुसन्धानको प्रोत्साहनको वातावरण तयार पार्ने र त्यसबाट प्राप्त तथ्याङ्कहरूका आधारमा स्वास्थ्य सम्बन्धी नीति, योजना तथा कार्यक्रम तर्जुमा र कार्यान्वयन गर्ने खेलेको भूमिका प्रशंसनीय छ। विश्वव्यापी महामारीको रूपमा फैलिएको कोभिड-19 नियन्त्रणमा यस संस्थाले गर्ने अध्ययन अनुसन्धान, भ्याक्सिन, ड्रग ट्रायल लगायतका अन्य क्लिनिकल अनुसन्धानहरूले महत्त्वपूर्ण भूमिका खेलोस् भन्ने शुभकामना व्यक्त गर्न चाहन्छु। हामीले अहिले देशमा खोपको संस्थागत विकास गर्ने उद्देश्यले खोपको क्लिनिकल ट्रायल सम्बन्धी प्रक्रियालाई स्वीकृत गरेका छौँ। यस पश्चात भ्याक्सिन रिसर्च अथवा भ्याक्सिन ट्रायल मार्फत समेत जनताले भ्याक्सिनको मात्रा प्राप्त गर्ने सुनिश्चित हुनेको मैले विश्वास लिएको छु। भविष्यमा नेपालमा उत्पादित औषधिजन्य वस्तुहरूको खोज अनुसन्धान गर्ने र आवश्यकताअनुसार मुलुकमा प्रविधि हस्तान्तरण तथा विस्तारको वातावरण बनाई अनुसन्धान संस्कृति विकास गर्ने र अनुसन्धान मार्फत औषधि तथा भ्याक्सिन उत्पादन गर्ने दिशामा समेत मुलुक उन्मुख हुनेछ। हामी निरोगी नेपाल निर्माण गर्ने अभियानमा छौँ। यसका लागि हामीले आधुनिक उपचार पद्धतिको विकास गर्नुपर्नेछ। वैकल्पिक उपचार पद्धति, स्थानीय साधन स्रोतहरूको प्रयोग र जनताले विकास गरेका परम्परागत तथा वनस्पतिजन्य औषधिहरूको प्रयोगतर्फ ध्यान दिँदै यसका वैज्ञानिक आधारहरूको थप अध्ययन गरी त्यस्ता पद्धतिलाई समयानुकूल विकास र आधुनिकीकरण गर्नेतर्फ यस परिषदले ध्यान दिनु आवश्यक छ। स्वास्थ्य र जनसङ्ख्या क्षेत्रमा देशभित्रै अधिकतम ज्ञान र सिपको अभिवृद्धि गर्न, यथेष्ट अध्ययन र अनुसन्धानको वातावरण तयार गर्न, प्रतिभा पलायन रोक्न तथा सार्वजनिक स्वास्थ्यलाई आम जनताको पहुँचभित्र पुर्याउन सरकारले चाल्नुपर्ने कदमबारे यस शिखर सम्मेलनले उपयुक्त सुझाव दिनेछ भन्ने मैले आशा लिएको छु। समृद्ध नेपाल, सुखी नेपालीको हाम्रो राष्ट्रिय आकाङ्क्षा पूरा गर्न यस सम्मेलनबाट प्राप्त निचोड र सुझावहरूले सहयोगी भूमिका खेल्ने अपेक्षा मैले गरेको छु। अन्त्यमा खोज र अनुसन्धानबाट प्राप्त उपलब्धिहरू मार्फत देशको समग्र स्वास्थ्य क्षेत्रको सुधार गरी स्वास्थ्य, जनसङ्ख्या र विकासको सकारात्मक सम्बन्ध सुदृढ गर्न यस सम्मेलनले महत्त्वपूर्ण निर्णय लिन सकोस्। सफलताको हार्दिक शुभकामना। 17 असार 2078, केपी शर्मा ओली। धन्यवाद।
धन्यवाद डाक्टर ग्यावली। अबको क्रममा हामीसँग लुम्बिनी प्रदेशका मुख्यमन्त्री माननीय शङ्कर पोखरेलज्यू जुम मार्फत जोडिनु भएको छ। शुभकामना मन्तव्यको लागि माननीय मन्त्रीज्यूलाई हार्दिक अनुरोध गर्न चाहन्छु।
कार्यक्रमका अध्यक्षज्यू, माननीय स्वास्थ्य तथा जनसङ्ख्या मन्त्रीज्यू, नेपाल स्वास्थ्य अनुसन्धान परिषदका पदाधिकारीज्यूहरू र यस अन्तर्राष्ट्रिय कार्यक्रममा सहभागी हुनुभएका सम्पूर्ण विशिष्ट महानुभावहरू, सबभन्दा पहिले त म तपाईँहरू सबैलाई लुम्बिनी प्रदेश सरकारको तर्फबाट हार्दिक स्वागत अभिवादन व्यक्त गर्न चाहन्छु। आज सिङ्गो विश्व नै कोभिड-19 महामारीका कारणले आक्रान्त भएका बेला नेपाल स्वास्थ्य अनुसन्धान परिषदको आयोजनामा स्वास्थ्य अनुसन्धानकर्ताहरूको यस प्रकारको कार्यक्रम आयोजना हुनु आफैमा महत्त्वपूर्ण पक्ष हो। मानव जाति विकास र समृद्धिको बाटोमा जति अगाडि बढ्दै जान्छ, मानव जातिले स्वास्थ्यका क्षेत्रमा अनेकन प्रकारका चुनौतीहरू सामना गर्नुपर्ने हुन्छ र नयाँ नयाँ रोगहरूको प्रकोपबाट मानव जाति आक्रान्त हुने गर्छ। पछिल्लो समय हामीले कोभिड-19 का कारणले त्यस्तै चुनौतीको सामना गर्यौं र खोज र अनुसन्धानका माध्यमबाट भर्खरै मानव जातिले कोभिड-19 का विरुद्धको भ्याक्सिनको प्रयोग गर्न सक्ने अवस्थामा आइपुगेको छ। तर खोज र अनुसन्धानबाट प्राप्त भएका उपलब्धिहरू सबै मानव जातिका लागि समान रूपमा पहुँचमा पुग्ने कुरा चुनौतीको विषय बनिरहेको छ। ठुला र सम्पन्न राष्ट्रहरूले अनुसन्धानका प्रतिफलहरू समयमै प्राप्त गर्ने र साना र निर्धन मुलुकहरू त्यसबाट वञ्चित हुने र मानव जातिकै बीचमा विभेद रहने जुन प्रकारको परिस्थिति उत्पन्न भएको छ र हामीले स्वास्थ्य क्षेत्रका खोज र अनुसन्धानहरूलाई सिङ्गो मानव जातिका लागि सुलभ ढङ्गले उपलब्ध गराउने कुराको जिम्मेवारी वहन गर्न सक्नुपर्छ भन्ने मलाई लाग्छ। वास्तवमा स्वास्थ्य क्षेत्रमा गरिने खोज र अनुसन्धानहरू कुनै संस्था विशेषका विषय बन्नु हुँदैन, त्यो समग्र मानव जातिको विषय बन्नुपर्छ। यस विषयमा पनि यस कार्यक्रममा छलफल हुनेछ र स्वास्थ्य क्षेत्रका खोज र अनुसन्धानहरू समग्र मानव जातिको हितमा प्रयोग गर्ने कुरामा साझा दृष्टिकोण बन्नेछ भन्ने कुराको अपेक्षा र विश्वास मैले लिएको छु। खास गरी नेपालका सन्दर्भमा स्वास्थ्य क्षेत्रमा खोज र अनुसन्धानको कार्य निकै कमजोर अवस्थामा छ। त्यसलाई सबल र सुदृढ गर्नुपर्ने आवश्यकता रहेको छ। नेपाल स्वास्थ्य अनुसन्धान परिषद पछिल्ला दिनहरूमा स्वास्थ्य क्षेत्रको खोज र अनुसन्धानका क्षेत्रमा कार्य गर्दै आइरहेको छ र यसलाई आगामी दिनहरूमा अझ व्यवस्थित रूपमा अगाडि बढाउनु पर्ने आवश्यकता छ र स्वाभाविक रूपमा परिषदले आफ्नो कार्यक्षेत्रलाई प्रादेशिक स्तरमा अगाडि बढाउने जुन योजना बनाएको छ, म प्रदेश सरकारको तर्फबाट परिषदलाई हृदयदेखि नै धन्यवाद दिन चाहन्छु र हामी लुम्बिनी प्रदेश सरकार स्वास्थ्यका क्षेत्रमा मिलेर काम गर्नका लागि प्रतिबद्ध रहेको कुरा म तपाईहरुलाई जानकारी गराउन चाहन्छु र यो बीचको अवधिमा खास गरी संघीय सरकार, प्रदेश सरकार र स्थानीय सरकारहरू सबैले सामूहिक रूपमा स्वास्थ्य क्षेत्रको पूर्वाधार विकासका सन्दर्भमा केन्द्रित भएर लगानी बढाइरहेका छौं र हाम्रो आवश्यकता अनुसार स्वाभाविक रूपमा लगानीको कमी त छ, तर हामीले आफ्नो प्राथमिकताको क्षेत्रका रूपमा स्वास्थ्य क्षेत्रलाई प्राथमिकताको क्षेत्रका रूपमा अगाडि बढाइरहेको कुरा यस अवसरमा म जानकारी गराउन चाहन्छु र हामी आधारभूत स्वास्थ्यको अधिकारलाई आम जनताका बीचमा स्थापित गर्ने हिसाबले अगाडि बढिरहेका छौं र स्वास्थ्य बीमाका माध्यमबाट आम जनताको स्वास्थ्यमा पहुँच वृद्धि गर्ने कुरामा सरकार अगाडि बढिरहेको छ। स्वास्थ्य पूर्वाधारका माध्यमबाट हामी आधारभूत स्वास्थ्य सुविधा ग्रामीण क्षेत्रसम्म पुर्याउने हिसाबले अगाडि बढिरहेका छौं र त्यति मात्रै होइन, हामी हाम्रो प्रदेशमा विशेषज्ञ सेवा समेत प्रदेशभित्रै उपलब्ध गराउने योजनाका साथ लुम्बिनी प्रदेश सरकार अगाडि बढेको कुरा म तपाईहरुको बीचमा राख्न चाहन्छु। हामीलाई एउटा चुनौतीका रूपमा रहेको विषय भनेको हामी पूर्वाधार त सरकारका तर्फबाट निर्माण गर्न सक्छौं, तर त्यसका लागि आवश्यक जनशक्ति आपूर्ति गर्ने कुरा भनेको स्वाभाविक रूपमा राष्ट्रिय दायित्वको विषय हो भन्ने मलाई लाग्छ और परिषदले स्वाभाविक रूपमा दक्ष जनशक्ति निर्माण गर्ने कुरामा नेतृत्व गरोस् र स्थानीय तहदेखि हामी जुन स्वास्थ्य पूर्वाधारहरू निर्माण गर्छौं त्यसका लागि दक्ष जनशक्ति उपलब्ध गराउने कुरामा सफलता हासिल गर्न सकोस् र यस कार्यक्रमका माध्यमबाट म यो कार्यक्रमको पूर्ण सफलताको कामना गर्न चाहन्छु। तपाईहरुको छलफलका माध्यमबाट स्वाभाविक रूपमा स्वास्थ्य क्षेत्रका चुनौतीहरूलाई सामना गर्ने कुराहरुमा र भोलिका दिनहरुमा चाहिँ स्वास्थ्य सेवालाई जनताको मौलिक अधिकारका रूपमा स्थापित गर्ने नेपाल सरकारको जुन संकल्प छ, अठोट छ, त्यो अठोटलाई पूरा गर्ने दिशातर्फ तपाईहरुको यो कार्यक्रम पूर्ण रूपमा सफल हुनेछ भन्ने विश्वास र अपेक्षाका साथ यो कार्यक्रमको पूर्ण सफलताको कामना गर्न चाहन्छु। हवस्, धन्यवाद, नमस्कार।
धन्यवाद माननीय मन्त्रीज्यू। हामीसँग अतिथिहरू जोडिने क्रम जारी नै रहेको छ। हामीसँग हुनुहुन्छ जुम मार्फत जोडिनु भएको छ बङ्गलादेशका लागि नेपालका राजदूत महामहिम डाक्टर वंशीधर मिश्रज्यू पनि हुनुहुन्छ। उहाँलाई पनि हार्दिक स्वागत गर्न चाहन्छु। त्यसैगरी अबको क्रममा आई वुड लाइक टु रिक्वेस्ट डाक्टर राजेश सम्बाजी राव पाण्डव, WHO representative to Nepal, to deliver this speech.
धन्यवाद। Right Honorable Prime Minister K.P. Sharma Oli, Honorable Mr. Krishna Gopal Shrestha, Minister of Health and Population, Honorable Mr. Shankar Pokharel, Chief Minister Lumbini Province, and other Chief Ministers of other provinces, Professor Dr. Dr. Poonam Khetrapal Singh, Regional Director WHO Sero, Mr. Lakshman Aryal, Secretary Ministry of Health and Population, Professor Dr. Gehenath Baral, Chairperson NHRC, Professor Dr. Gaurav Dakhal, Vice Chair NHRC, Dr. Pradeep Gyanwali, Executive Chief NHRC, all the distinguished delegates from NHRC and Ministry of Health, and honorable delegates joining virtually, and all the experts who are going to speak at this 7th Virtual National Summit of Health and Population Scientists in Nepal. Good morning and namaskar. The theme of the 7th National Summit of Health and Population Scientists in Nepal, Research in Public Health Emergencies, Evidence to Policy and Action, is very relevant to the current context of COVID-19 pandemic. It is undisputed that sound research and evidence is indispensable for resolving public health challenges, whether it be tackling diseases of poverty, responding to the rise of chronic diseases, ensuring that mothers have access to safe delivery practices, or for having an effective emergency preparedness and response. Research and evidence are key elements for improving health outcomes and health equity. Research for health spans 5 generic areas of activity. 1. Measuring the magnitude and distribution of the health problem. 2. Understanding the diverse causes or the determinants of the problem, whether they are due to biological, behavioral, social, or environmental factors. Developing solutions or interventions that will help to prevent or mitigate the problem. Implementing or delivering solutions through policies and programs, and evaluating the impact of these solutions on the level and distribution of the problem. The COVID-19 pandemic has highlighted important aspects of evidence-based policy action. It has put spotlight on the fact that non-scientific factors such as conflicting interest, working in silos, override sound research and evidence. The ongoing public health emergency has exposed weak links between existing evidence and policy. The role of primary health care and a strong public health system in attaining universal health coverage has been long established. WHO has consistently highlighted the need for building a resilient and a strong public health system. The COVID-19 pandemic has again exposed the weakness of private sector and the hazards of over-reliance on dominant private provision. The pandemic has put absence of intention, capacity and integrity of the private sector to offer adequate, affordable, and ethical care for COVID-19 patients on wide display. In many countries with high private sector penetration in health sector, there have been numerous reports of profiteering and gaming. The importance of a strong public health sector has again been forcefully highlighted. COVID-19 has laid bare the inequities that influence health and has underlined the urgency of addressing health inequities. It has disproportionately impacted those who are already vulnerable, such as the poor, the lower paid members of the workforce, elderly, persons with disabilities, migrant laborers, and homeless. It has illustrated how health has social ramifications and social welfare has consequences for public health. It has highlighted that the health equity can only be attained by addressing the structural roots of inequity. Health policies have to be implemented in conjunction with policies that directly address the social determinants of health, including inequitable distribution of resources. It has again highlighted the importance of social approach to health that mandates intersectoral, multisectoral action to improve health by addressing social, economic, environmental, and political factors that shape health. Yet, COVID-19 response in many countries has lacked intersectoral collaboration and coordination. The Solidarity clinical trial for COVID-19 treatments calls for solidarity of all countries to ensure equitable access to COVID-19 health products. Research needs to be coordinated nationally and internationally to avoid wasteful duplication. No country is self-sufficient in its research capacity. So, member states need to be able to share research outputs. Rapidly sharing of information generated during research is very important. Upholding internationally accepted ethical standards and norms, such as maintaining the confidentiality and privacy of personal information. Evidence-based policy and practice is an important step towards improving accountability and policy outcomes. Health research systems should be adequately resourced. It is equally important to revisit existing evidence and review policies. High-quality research is essential to fulfilling WHO's mandate for the attainment of by all peoples of the highest possible level of health. One of the organization's core functions is to set international norms, standards, and guidelines, including setting international standards for research. WHO works to identify research priority and promote and conduct research with the following 4 goals. Capacity. Build capacity to strengthen health research system within member states. Prioritize, that is, support the setting of research priorities that meet health needs, particularly in low and middle income countries. Third, standards. Develop an enabling environment for research through the creation of norms and standards for good research practice. And fourth, translation. Ensure quality evidence is turned into affordable health technologies and evidence-informed policy. WHO will continue to support Nepal in strengthening its national systems for health research and information, identifying priority areas, promoting good practice in research by setting norms and standards, and strengthening links between health research and health policy and practice. I wish this 7th National Summit a good success and look forward to the deliberations. Thank you. Dhanyavad.
Thank you, Dr. Pandab. अबको क्रममा हामीसँग आजका कीनोट स्पिकर अफ द प्रोग्राम डाक्टर पुनम क्षेत्रपाल सिंह हुनुहुन्छ। उहाँ भर्चुअली हामीसँग जोडिनु भएको छ। उहाँको मन्तव्य रहेको छ। त्यसको लागि त्यसभन्दा अगाडि म उहाँको छोटो बायो वाचन गर्ने अनुमति माग्न चाहन्छु। Dr. Poonam Chhatrapal Singh, an Indian national, became the first woman to assume the office of WHO Regional Director of Southeast Asia on 1 February 2014. In September 2018, member state unanimously nominated Dr. Chhatrapal Singh for a second 5-year term as a regional director. The 44th session of the WHO Executive Board member formally appointed her to the position on 26 January 2019. Dr. Chhatrapal Singh has devoted more than 3 decades to strengthening public health as a leader and merger at national and international level. She has vast experience in developing evidence-based, scientifically sound policy in complex state, national and international health system due to her work managing low-resourced health system, leading large multi-sectoral teams and collaborating with global partners and public health leaders. अबको मन्तव्य डाक्टर पुनम क्षेत्रपाल सिंहको।
A very good morning to Her Excellency, the Honorable President, Mrs. Bidya Devi Bhandari, His Excellency, the Honorable Prime Minister, Mr. K.P. Sharma Oli, His Excellency, the Honorable Minister for Health and Population, Mr. Krishna Gopal Shrestha, the Honorable Chief Minister of Lumbini Province, Mr. Shankar Pokharel, the Honorable Secretary, Ministry of Health and Population, Mr. Lakshman Aryal, and the WHO representative to Nepal, Dr. Rajesh Pandav. My sincere thanks to Dr. Pradeep Gaiwali, Executive Chief of the Nepal National Health Research Council, for the opportunity to deliver this keynote address. This innovative and high-level event is a credit to your efforts and to the commitment of the Ministry of Health and Population and the Government of Nepal to implement evidence-based policy that drives real impact in the lives of the most vulnerable. Amid the ongoing COVID-19 response and in the recovery from the crisis, such policy will be critical to fulfilling the region's sustain, accelerate, innovate vision and to achieve our flagship priorities and the Sustainable Development Goal targets. For 5 consecutive weeks, Nepal has recorded a decline in COVID-19 cases. Last week, a 38% decline. I commend the efforts of all responders who continue to go above and beyond the call of duty. And I congratulate the people of Nepal who, since the beginning of the response, have adhered to public health and social measures and supported one another to stay safe, healthy, and well. You can be certain of WHO's steadfast support in all aspects of the response, including on the issue to which we are gathered to address. That is, research in public health emergencies, specifically research by health and population scientists. We have heard a lot about regional and global triumphs in vaccine research and in research on diagnostics, therapeutics, and other areas of WHO's global R&D roadmap. Such triumphs have been truly remarkable. But equally remarkable have been the contributions of health and population scientists, including in Nepal. I commend you all. Throughout the COVID-19 response, health and population scientists have shared experiences and apprised policymakers of best practices, not only for combating COVID-19, but also maintaining essential health services and adapting programmatic interventions in other areas of health, both key priorities in our region. Embedded and operational research, in particular, can efficiently link research and policy decisions, providing rapid solution to a range of pressing issues from health financing bottlenecks to medicines dispensing, service delivery, and bed availability. Identifying that use embedded research methodologies to answer policy questions in primary care and then linking them to emergency response. I understand that these and other methodologies and tools have had significant impact in Nepal, enabling public health authorities at the federal, state, and local level to act in unison and make rapid decisions based on the best available evidence. I urge you to maintain momentum and to leverage the full power of health and population research, including embedded and operational research, to strengthen the response, build health system resilience, enhance emergency preparedness and response capacities, and achieve full compliance with the international health regulations exactly as you have gathered to do. Today, I have 3 messages, each of them critical to conducting high impact, high quality health and population research. First, identify clear and coherent priorities. Many questions may be asked, but not all of them are equally urgent, nor will all of them advance health equity and address the most vulnerable first. This is especially true in public health emergencies, where time is of essence and must be allocated based on whose needs are most pressing. But it is equally true in steady state scenarios, and I encourage you to prioritize accordingly. Second, apply consistent and transparent standards and ensure rigor in case study quality, data collection, and analysis. In emergencies, this can be difficult, but as much as possible, researchers must identify and apply the most appropriate study designs, the best methods of data collection, and the most insightful processes of analysis and interpretation. Throughout the recovery, I encourage all researchers to access the WHO Reader on Health Policy and Systems Research, which provides end-to-end guidance on all aspects of research design and implementation. Third, define how best to translate evidence into action, which I am delighted is the theme of this 7th National Summit. In the region and across the world, research too often falls to inform policy and practice because it does not respond to policy needs or because it is poorly communicated to policymakers. Deliberative forums such as this are critical to overcoming these and other barriers and to stimulating context-specific and evidence-informed action at all levels. I look very much forward to hearing of your deliberations and encourage you to remain closely networked, ensuring that research priorities are aligned with and can inform emergency response and health system priorities. In these and all other endeavors, Nepal can be certain of WHO's ongoing, unmitigated support to build health system resilience, to prepare for and prevent future emergencies, and to create a fairer and healthier region and the world. Thank you.
थ्याङ्क यू डाक्टर पुनम क्षेत्रपाल सिंह। अबको क्रममा हामीसँग स्वास्थ्य तथा जनसङ्ख्या मन्त्रालयका सचिव श्री लक्ष्मण अर्यालज्यूको मन्तव्य रहेको छ। उहाँको मन्तव्यको लागि हार्दिक आमन्त्रण गर्न चाहन्छु। उहाँको उपस्थिति भइसकेको रहेछ। उहाँको उपस्थिति भइसके पछाडि उहाँको मन्तव्यलाई फेरि हामी राख्ने नै छौँ। यसपछिको क्रममा म आजको कार्यक्रमलाई सम्बोधन गरिदिनु हुनको निम्ति आजका कार्यक्रमका प्रमुख अतिथि स्वास्थ्य तथा जनसङ्ख्या मन्त्रालयका माननीय मन्त्री श्री कृष्ण गोपाल श्रेष्ठज्यूलाई हार्दिक अनुरोध गर्न चाहन्छु।
कार्यक्रमका उद्घोषिका शोभिता गौतमलाई विशेष धन्यवाद। कार्यक्रमका सभाध्यक्षज्यू, स्वास्थ्य तथा जनसङ्ख्या मन्त्रालयका अन्य सहभागी साथीहरू, विश्व स्वास्थ्य सङ्गठनका क्षेत्रीय निर्देशकज्यू, नेपालका लागि स्वास्थ्य सङ्गठनका प्रतिनिधिज्यूहरू, नेपाल स्वास्थ्य अनुसन्धान परिषदका कार्यकारी सदस्य सचिवज्यू र अन्य पदाधिकारीज्यूहरू, यस सम्मेलनमा भर्चुअल माध्यमबाट जोडिनुभएका देश विदेशमा रहनुभएका सम्पूर्ण महानुभावहरू, पत्रकारहरू, लुम्बिनी प्रदेशका मुख्यमन्त्री माननीय शङ्कर पोखरेलज्यू र इजरायलका महामहिम नेपालका राजदूत डाक्टर अन्जान साके लगायत यस भर्चुअल माध्यममा जोडिनुभएका सम्पूर्ण सहभागी साथीहरू, नेपाल स्वास्थ्य अनुसन्धान परिषदद्वारा आयोजित यस स्वास्थ्य तथा जनसङ्ख्या वैज्ञानिकहरूको 7औं राष्ट्रिय सम्मेलनलाई सम्बोधन गर्न पाउँदा मलाई अत्यन्तै खुसी लागेको छ। स्वास्थ्य तथा जनसङ्ख्या मन्त्रालय जनतालाई उच्च स्तरीय सेवा पुर्याउन प्रतिबद्ध छ। यस मन्त्रालय दिगो विकासका लक्ष्य 2030 र यसका स्वास्थ्य सम्बन्धी उद्देश्यहरू पुरा गर्न नेपालको संविधान राष्ट्रिय स्वास्थ्य नीति 2076 तथा नेपाल स्वास्थ्य रणनीतिको मर्म अनुरूप मार्ग निर्देशित छ। विगतका दशकहरूमा नेपाल सरकार, साझेदार संस्था तथा जनताको सहयोगद्वारा स्वास्थ्य क्षेत्रमा निकै उपलब्धि हासिल गरिसकेका छौँ र यसको लागि नेपाल स्वास्थ्य अनुसन्धान परिषदको भूमिका पनि निकै प्रशंसनीय छ। नेपाल स्वास्थ्य अनुसन्धान परिषदले आफ्नो स्थापना कालदेखि स्वास्थ्यका विभिन्न क्षेत्रमा अध्ययन अनुसन्धान गरी स्वास्थ्य सम्बन्धी तथ्यहरूका आधारमा स्वास्थ्य क्षेत्रका नीति तथा रणनीतिहरू निर्माण गर्दै सहस्राब्दी विकासका स्वास्थ्य सम्बन्धी उद्देश्यहरूमा सुधार ल्याउनका लागि खेलेको भूमिका सराहनीय छ। परिषदले स्वास्थ्यका महत्त्वपूर्ण क्षेत्रहरूको पहिचान गरी प्राथमिकताका आधारमा रहेर ती क्षेत्रहरूमा अध्ययन अनुसन्धान गरी तथ्यमा आधारित नीति तथा कार्यक्रम निर्माण गर्न उल्लेखनीय भूमिका खेलेको छ। विश्वव्यापी रूपमा अनुसन्धानको महत्त्व हरेक क्षेत्रमा दिनानुदिन बढ्दै गइरहेको छ। नेपाल स्वास्थ्य अनुसन्धान परिषदले स्वास्थ्य मन्त्रालयलाई स्वास्थ्य क्षेत्रका महत्त्वपूर्ण विषयमा अनुसन्धान गरी अहिलेको कोभिड-19 को विषय परिस्थितिलाई सामना र नियन्त्रण गर्न सहयोग गर्दै आइरहेको छ। नेपाल स्वास्थ्य अनुसन्धान परिषदले वैज्ञानिक तवरले सिद्ध भएका तथ्यहरू सरकारका विभिन्न तहमा समाहित गरी सहजीकरण गर्नेमा म पूर्ण विश्वस्त छु। नेपाल स्वास्थ्य अनुसन्धान परिषदको 30औं वार्षिक उत्सव समारोहमा म स्वास्थ्य तथा जनसङ्ख्या मन्त्रालयको तर्फबाट यस परिषदले स्वास्थ्य क्षेत्रको अध्ययन अनुसन्धानमा निभाउँदै आएको महत्त्वपूर्ण भूमिका र यसले स्वास्थ्य योजना तथा नीति निर्माण र मूल्याङ्कनमा पुर्याइरहेको सहयोगको लागि आभार व्यक्त गर्न चाहन्छु। स्वास्थ्यमा गरिने अध्ययन अनुसन्धानको विभिन्न क्षेत्रहरू जस्तै स्वास्थ्य अनुसन्धानको नियमन, यसको नैतिकता र प्रचार तथा अन्तर्राष्ट्रिय योग्यता भएका देश विदेशका अनुसन्धानकर्ताहरूको क्षमता अभिवृद्धिका लागि उपयुक्त वातावरण सृजना गर्न र आवश्यक समन्वय गर्न स्वास्थ्य मन्त्रालय हरपल तत्पल रहिरहनेछ। नेपाल सरकारले हालै भ्याक्सिन ट्रायल सम्बन्धी प्रक्रिया पास गरिसकेको सन्दर्भमा नेपाल स्वास्थ्य अनुसन्धान परिषद क्लिनिकल रिसर्चको मार्गमा अगाडि बढ्नेछ भन्नेमा म विश्वस्त छु र क्लिनिकल ट्रायलको मार्फत पनि जनताले भ्याक्सिनको मात्रा प्राप्त हुने मार्गमा सहयोग पुग्ने मैले आशा लिएको छु। यस 2 दिने वैज्ञानिक सम्मेलनले नेपाल सरकारलाई महत्त्वपूर्ण सुझाव प्रस्तुत गर्ने आशा लिएको छु। अन्त्यमा वर्तमान अवस्थामा यस अनुसन्धान परिषद कोभिड-19 ले निम्त्याएको विषम परिस्थितिको सामना गर्दै 7औं शिखर सम्मेलन सञ्चालन गर्न सफल भएकोमा बधाई दिँदै कार्यक्रमको पूर्ण सफलताको शुभकामना व्यक्त गर्न चाहन्छु। धन्यवाद, नमस्कार।
धन्यवाद माननीय मन्त्री श्री कृष्ण गोपाल श्रेष्ठज्यू। अबको कार्यक्रममा भोट अफ थ्याङ्क्स राखिदिनु हुनुको निम्ति म नेपाल स्वास्थ्य अनुसन्धान परिषदका उपाध्यक्ष प्रोफेसर डाक्टर गौरव ढकालज्यूलाई हार्दिक अनुरोध गर्न चाहन्छु।
A very good morning to everyone present here and also to the dignitaries on the dais. At the outset, I would like to thank the message we received from Right Honorable Prime Minister Mr. KP Sharma Oli. This message was very important to NSRC because only with a strong political determination and a strong political will can research flourish in this country or anywhere else. That's what we believe personally. And also, we would like to thank Honorable Chief Minister, Mr. Shankar Pokhrel, for taking his busy time schedule, taking out time to address this national summit of opening ceremony. So we would like to thank him personally. I would also like to thank the remarks made by Dr. Rajesh Pandav, WHO representative to Nepal, and also the keynote address speaker, Dr. Poonam Singh, Regional Director, WHO Southeast Asia. So we would like to thank them because WHO has been a special partner with Nepal's health policy, and this has been more emphasized during this pandemic situation. So thank you for working closely with Nepal. Thank you, sir. I would also like to thank the remarks and the strong message put forward by the Honorable Minister for Health, Mr. Kopa Krishna Shrestha. We would like to thank you, sir, for your strong message. It was very apt that you showed us and you have shown the guidance towards us and emphasized the importance of clinical research, especially during these times. And also thank you for the safe passage and the passage of the clinical trial bill. I would also like to thank Professor Dr. Gyannath Baral, Chairperson, Nepal Health Research Council, and a special vote of thanks to the Executive Member Secretary, Dr. Pradeep Gyawali. I would also, and this summit would not have been possible without all the people and all the staff of Nepal Health Research Council. So the main people, the main heroes of this summit are the staff of Nepal Health Research Council, without whom this summit would not have been possible. And they have been working day in and day out since the last few weeks. So thank you everyone who is present here, and thank you also to those who have not been able to make it and who are at home, who are working from home or looking at this event from home. Thank you very much. A big round of applause to all of them. And it would not be justice if I do not mention a few names from Nepal Health Research Council. It's not possible for me to take the names of everyone. Dr. Meghnad Dhimalji, thank you very much. He is the spearhead of the research division of Nepal Health Research Council. And I personally know that he's had sleepless nights over the few weeks, if not days. Thank you. Mr. Subodh Karna, account head, thank you very much. So he's been keeping a tightness in the purse strings of Nepal Health Research Council. And Mr. Vijay Jha, thank you very much. So without him, this training will never go smoothly. Mrs. Namita Ghimire, she's at home, but we would also like to thank our research officer, Mrs. Namita Ghimire. Thank you very much, Mrs. Namita. And Mr. Bhusan Yadav from the library, thank you very much. And I would also like to thank the Scientific Committee of Nepal Health Research Council, the Steering Committee of Nepal Health Research Council, and the Organizing Committee of this summit. So they have been putting up all these scientific agenda, the deliberations that are going to be given within these 2 days. So the effort of this also deserve a big kudos. And I would also like to thank all the IT support staff here who have been able to put this magnificent summit within the next 2 days. So they also deserve a vote of thanks. And with this, I would like to thank everyone who's come here for this summit. I would also like to thank everyone who is joining us through Facebook, through YouTube, through Zoom, and enjoy this summit. It's going to be a very eventful summit for all of us, especially during these pandemic times. Thank you very much. Namaste.
धन्यवाद डाक्टर ढकाल। हामी कार्यक्रमको अन्तिमतर्फ आइसकेका छौँ। यो 7औं राष्ट्रिय स्वास्थ्य तथा जनसङ्ख्या वैज्ञानिकहरूको शिखर सम्मेलनमा सहभागी हुने तपाईँ सम्पूर्ण महानुभावहरू एकदमै व्यग्रताको साथ हेरिरहनु भएको छ। हार्दिक धन्यवाद ज्ञापन।
सम्पूर्ण एनएचआरसी फ्यामिली, फिजिकल्ली उपस्थित हुनुभएका हाम्रो इन्भाइटेड हाम्रो गेस्टहरू र यो भर्चुअल मिन्सबाट लिङ्क हुनुभएका सबै महानुभावहरू जो आफ्नो रिमार्क्सहरू प्रेजेन्ट गर्नुभयो र जो पछि आफ्नो प्रेजेन्टेसनहरू पनि डेलिभर गर्दै हुनुहुन्छ, यहाँहरू सबैप्रति म आभार व्यक्त गर्दछु। यो 7औं शिखर समिट हामी एभ्री इयर मनाउँदैछौँ र यो मनाउने क्रममा हामीले पहिलेको भन्दा हामी कसरी अगाडि बढ्दैछौँ भन्ने कुराहरू केही कुराहरू अहिलेसम्म थाहा भइसकेको छ। हामीले पहिले अब्जर्भेसनल स्टडीबाट सुरु गऱ्यौँ, अहिले क्लिनिकल ट्रायल्समा पुग्दैछौँ। यसको अर्थ हाम्रो एउटा माइलस्टोन नै हो। हामीले यो पब्लिक हेल्थलाई अपरेसनलाइज गर्नुपर्ने अवस्था पनि आइसकेको छ। हामीले प्रिडोमिनेन्टली रोगको रोकथाम, प्रिभेन्सन र प्रवर्धनलाई मेनली यो पब्लिक हेल्थमा हेरेका थियौँ भने अब थेरापेटिक पार्टलाई पनि उत्तिकै तेस्रो आयामको रूपमा लिएर जानुपर्ने अवस्था आइसकेको छ। सो वी हेभ टु अपरेसनलाइज, रिडिफाइन द पब्लिक हेल्थ स्कोप। यो क्लिनिकल ट्रायलले यही कुरा नै भन्छ। यो गर्न थाल्यो भने हामीले पब्लिकलाई र समाजलाई एउटा अनुसन्धानात्मक रूपमा एउटा इभिडेन्स बेस्ड डाटा जेनेरेट गरेर हामीले एउटा न्यू प्रडक्ट दिन सक्छौँ, जसले गर्दा जनता र समाजको लागि फाइदा हुनसक्छ। यही क्रममा हामीले आजसम्म के कस्ता गऱ्यौँ, कति काम गऱ्यौँ, कति गर्न बाँकी छ भन्ने कुराहरू नै हामी प्रत्येक वर्ष यसरी नै साइन्टिफिक पेपरहरू प्रेजेन्ट गरेर, हाम्रा एक्सपिरियन्सहरू सेयर गरेर, प्रविधिहरू सेयर गरेर हामी आफैलाई अपडेट गराउँदै जान्छौँ। र हामीले आजसम्म गरेका कामहरूले, स्वास्थ्य अनुसन्धान परिषदले गरेका कामहरूले डाटा जेनेरेसन गर्ने कामहरू धेरै गरेको छ, अब्जर्भेसनल स्टडीहरू धेरै गरेको छ र यसले हामीलाई एक्ज्याक्ट यो प्रडक्ट आयो भन्दा पनि हामीले ब्याकग्राउन्ड इन्फर्मेसनहरू धेरै लिइसकेका छौँ र केही अरू कुराहरू पनि लिएका छौँ। यसलाई यो सानो ठाउँबाट अथवा बेन्चवर्कबाट बेडसम्म पुग्ने किसिमको डिरेक्सनमा लाने प्रक्रियामा हामी छौँ। यसले स्वास्थ्य अनुसन्धान गराउने र एजुकेसन, अनुसन्धान सम्बन्धी एजुकेसन दिएर क्यापेसिटी बिल्डअप गर्नेतिर पनि लाँदैछौँ, जसले गर्दा हामी अहिले लर्निङ फेजमा भएको रिसर्चको अवस्थालाई एउटा कार्यान्वयनको लेभलमा पनि लान सक्छौँ र हाम्रो देशको स्वास्थ्य चाहिँ इभिडेन्स बेस्ड मेडिसिनमै आधारित हुनेछ भन्ने कुरा प्रणित गर्न सकौँ भन्ने डिरेक्सनमा गइरहेका छौँ। यसको लागि हाम्रो लाइन मिनिस्ट्री भनेको यो स्वास्थ्य तथा जनसङ्ख्या मन्त्रालय हो र यहाँ हाम्रो प्रमुख अतिथिको रूपमा स्वास्थ्य मन्त्रीज्यू पनि हुनुहुन्छ। उहाँहरूको कोअपरेसन र सधैँ हामीलाई स्वागतयोग्य छ र उहाँहरूले हाम्रो कामहरूलाई पनि धेरै स्वागतयोग्य भनेर भनिरहनु भएको छ। यो हाम्रो आपसी सहयोगबाट, आपसी कार्यान्वयनबाट, आपसी कोलाबोरेसनबाट नै हामी यो सम्भव हुनसक्छ। यो हाम्रो सबैको जोइन्ट एक्सन हो र हामीले यसमा जति कुरा गर्छौँ, जति काम गर्छौँ, हामीले देखाउन सक्नुपर्छ। हामीले इभिडेन्स देखायौँ भने मात्रै हामीले काम गरेको ठहर छ र हाम्रा जति यहाँ यो सहभागी हुन आउनुभएका अनलाइन अथवा यो फिजिकल्ली जति आउनुहुन्छ उहाँहरूले आफ्ना सेयरहरू गर्नुहुन्छ होला, आफ्नो डेलिभरेबल दिनुहुन्छ होला। त्यसले गर्दा हाम्रो फर्दर डिरेक्सनलाई पनि केही मार्गदर्शन गर्छ भन्ने मैले आशा लिएको छु र यसरी यो सभा बढाइदिएर र यहाँ आएर आफ्ना रिमार्क्सहरू राखिदिएर हाम्रो सम्मेलनलाई सफल पार्न सहयोग गरिदिनु हुने सम्पूर्ण महानुभावहरूलाई म नेपाल हेल्थ रिसर्च काउन्सिलको तर्फबाट धेरै धेरै धन्यवाद दिँदै म आभार पनि व्यक्त गर्न चाहन्छु। यो हामीले देश तथा विदेश सबै ठाउँका सहभागीहरूलाई हामीले लिङ्क गरिराखेका छौँ। त्यसैले यो हाम्रो डेलिभरेबल हाम्रो साइन्टिफिक सेसनहरू सबै अङ्ग्रेजी माध्यममा हुनेछन् र हामीले यो नेपाल सरकारको उद्घाटन समारोह भएकोले गर्दा आफ्नो राष्ट्रिय भाषामा सुरु गऱ्यौँ र केही म एड्रेस गर्न चाहन्छु यो अङ्ग्रेजी माध्यमबाट पनि सुरु गर्नुपर्ने भएकोले के एड्रेस सर्टमा गर्न चाहन्छु। नमस्ते एन्ड ग्रोम ग्रिटिङ्स। आई एम प्रोफेसर गेवनाथ बराल, चेयरम्यान अफ नेपाल हेल्थ रिसर्च काउन्सिल. Nepal Health Research Council is an autonomous body of Nepal government with the role assigned to promote and regulate health research in the country. Today is an auspicious occasion for the research scientists in Nepal to celebrate 7th Summit of Health and Population Scientists. Our delegates are participating from and outside the country with different research capacities in health sciences. The method of delivery is virtual at the moment as per government directives in such a difficult situation of a COVID pandemic. However, we have taken it as an opportunity to widely involve all concerns and stakeholders at a time that would not have been possible otherwise. I expect active participation in order to share research experiences amongst all and come up with a concrete resolution as a deliverable. My wish is to assure our health research for the people and society by generating scientific evidence. Stay safe and succeed in translating research product from bench to bed. Thank you very much. I again wish this summit a grand success. Greeting to all and namaste again. अब यो हाम्रो उद्घाटन कार्यक्रमको कन्क्लुडिङ सेसनमा म गइरहेको छु र यो कन्क्लुड गर्नु अगाडि हाम्रो प्रमुख अतिथिज्यूलाई उहाँ भर्खरै आफ्नो पोर्टफोलियो चेन्ज भएर हाम्रो लिडरसिपमा आउनुभएको छ, उहाँलाई स्वागत पनि गर्छौँ। एक त न्यू पोर्टफोलियोमा आउनुभएकोमा, अर्को हाम्रो प्रमुख अतिथि भएर आउनुभएकोमा यसको लागि म टोकन अफ लभ म प्रदान गर्न चाहन्छु।
धन्यवाद डाक्टर गेहनाथ बरालज्यू। त्यसै गरी अब मायाको चिनो प्रदान गर्नको निम्ति म WHO रिप्रेजेन्टेटिभ टु नेपाल डाक्टर राजेश सम्बाजीराव पाण्डवज्यूलाई पनि प्रदान गरिदिनु हुनको निम्ति म अध्यक्षज्यूलाई हार्दिक अनुरोध गर्न चाहन्छु। समादरणीय दर्शक महानुभावहरू, यो सँगै हाम्रो कार्यक्रमको औपचारिक उद्घाटनको समापन भइसकेको छ। यस पछाडि हामीसँग धेरै सेसनहरू रहेका छन् र अबको सेसनको लागि म डाक्टर विष्णु मरासिनीलाई यो फ्लोर हस्तान्तरण गर्दै म पनि यहाँबाट बिदा हुन चाहन्छु। यहाँहरू सबैजनालाई फेरि पनि हार्दिक धन्यवाद दिँदै म यहाँबाट बिदा हुन चाहन्छु। हवस् त, नमस्कार, शुभ दिन। अतिथिज्यू र आमन्त्रित व्यक्तिहरूलाई जलपानको लागि पनि हार्दिक अनुरोध गर्न चाहन्छु।
You. Namaste, a warm good morning to all of you. Respected chairman and board members of the NHRC, distinguished delegates, distinguished health professionals, ladies and gentlemen, it's my immense pleasure to welcome all of you in this Research in Public Health Emergency session. I am Dr. Vishnu Munasini from Nepal Health Research Council and will be the host of this session. For this session, it's my great honor to invite Professor Dr. Janak Koirala on the stage to chair the session. Professor Dr. Koirala is the Professor of Medicine at Patton Academy of Health Sciences and Professor Emeritus of Southern Illinois University School of Medicine, USA, and Senior Consultant of Nepal Health Research Council. He has published over 50 peer-reviewed research articles and book chapters in the areas of health and medicine. He had served as Chair of Infection Control and Safety Committee, Southern Illinois University School of Medicine. He is also the Fellow of American College of Physicians, also the Fellow of Infectious Disease Society of America, and many other professional societies. Similarly, I would like to invite Dr. Suresh Tiwari on the stage to assume the chair. It's my honor to introduce Dr. Tiwari, who is the public health and public financial management professional with national and international experiences in formulating the public health policy, national strategic plan, and policy evaluation. His area of expertise lies in epidemiological research, social protection. He also has been involved in developing COVID policy, epidemiological modeling, and developing health insurance policy. Currently, he is a director. He is the country director of Oxford Policy Management in Nepal. Now, I would like to hand over the session to the chairs.
Thank you, Dr. Vishnu. Without having further delay, I would like to invite today's first speaker, Dr. Krishna Paudel. Dr. Krishna, please. Dr. Krishna Paudel is well-known public health pediatrician, currently the director of Epidemiology and Disease Control Center. Most of us watching him in the television telling us what to do, what to not to do in COVID context, and his contribution in preventing and controlling COVID has been significantly impacting in Nepali society. We would like to welcome Dr. Krishna for his prestigious presentation today. Dr. Krishna, please.
Thank you very much, sir. Honorable, respected chairpersons and all the dignitaries who are present here physically and virtually in this 7th Virtual National Summit of Health and Population Scientists in Nepal. First of all, I would like to thank NHRC for inviting me, including Minister of Health and Population. In this presentation, though it will be short, we will be talking about some of the milestones, some of the activities, some of the ongoing activities, some of the efforts being taken by the ministry with the existing data. So I will proceed with my presentation with permission from Chair, and if there are any doubts and any concerns, we will address those later. Thank you very much. So this shows the milestone of COVID-19 in Nepal. So with the beginning of COVID pandemic, we were able to identify first case in 27th of 27th January in 2020, and since then lot of activities, lot of events have happened to us. So we strengthened our laboratory capacity from 1 at National Public Health Laboratory to 96 different public laboratories across the country. Out of them, 57 are government-owned laboratories, and these laboratories do provide free treatment, free testing for all the people who are presented there with symptoms. So that's being one achievement, and till now almost 16 lakhs of antigens have been distributed to all 753 palikas across the country. So testing is available everywhere. It's time for us to make maximum use of it. And just to talk about the data, we've been able to do more than 33 lakhs of tests in terms of RT-PCR. In terms of population per 1 million, it may not be high, but we have been doing those who are presented with symptoms and those at contact tracing. And in terms of reporting in antigen test, we've been getting only 1,84,000 only, though I told more than 10 times almost the antigens have been distributed to the palikas. There are limitations in reporting. So altogether, more than 35 lakhs of tests have been done, and out of that, 6,36,316 cases positive from RT-PCR, and 33,944 have been identified from antigen test. And we have 88.4% recovery rate, 1.4% case fatality rate, and as of now, active cases are around 10.2%. And we've been able to vaccinate at least 25 lakhs and more population at least by one dose, and out of them only 7.5 lakhs of people have received second dose vaccination. There are disparities in terms of case positivity rate at the provinces, depends on the number of samples being tested also. Last 24 hours, there was highest test positivity rate at Gandaki province, however lowest 11% at province number 2. And we have been circulating these through our different platforms like MOSP Viber community, Hamro Swasthya mobile application, and different portals from Ministry of Health and Population. That's covid19.mosp.gov.np, portal.edcd.gov.np, and MOSP COVID-19 Viber group 2. So just to show the situation in 2 days back, that was 15th of Asar, when we had active cases more than 520 districts. And this is much better compared to what we saw in earlier. Let's see, for Asar 10, we had 36 districts with more than 500 active cases. However, if we go to Asar 9, it was 36 districts with more than 500 active cases. And going back to 26th of Jesta, we had 46 districts which showed more than 500 active cases. So we can say from them that the cases are being decreasing in most of the districts. So this was the situation of second wave, when on 4th of Baisakh we had only 6 districts having more than 500 active cases. However, in 3 weeks it reached to almost 40 districts that time. So this is how the pandemic spread this second wave this time, and a lot of activities we planned could not happen in time. And as of yesterday, we had only 17 districts showing more than 500 active cases. So these are the ground crossing health desks which being started from last year at 13 different ground crossings. And here we need to understand that we do share around 1,800 kilometers of open border in India. There are a lot of traditional ways to enter our country from these different routes, and these point of entry health desks have been able to screen at least 3,04,755 cases as of 20th of June, and 16.7% case positivity has been noted there, with test positivity of 7.6%. 16.7% were tested with antigen, those who fit with our national testing guideline. There are a lot of criticism about CICT, case investigation and contact tracing. As per our current understanding, the local palikas, the municipalities rural or the municipalities urban, both are responsible for conducting CICT, and for that a lot of guideline in terms of testing, training, IMU in terms of data updating, and Zoom meetings have been conducted with these palikas, supervisors, health workers at different level, including the leadership, mayors and vice mayors. But in spite of that, there have been challenges. We can see activities being conducted across timeline. So if we see just the data of till yesterday, so the day before yesterday, we can see that in terms of cases per million people, we are just below Sri Lanka in recent days, but we picked more than India and these countries, neighboring countries, Sri Lanka, Nepal, India, Pakistan, in first wave as well as second wave. So in terms of death also, we reached highest death in terms of per million people, age high, age more than 6.5, and during the peak of this wave, and now it's declining, and it's second in the region below, just below Sri Lanka, though we are above the live death rates in terms of India and Pakistan. In terms of vaccination, we are being able to vaccinate around 8.5% of population with at least one dose. Here also we are third in the in this compared to India, Sri Lanka, and Pakistan. India itself has one of the largest manufacturing plant with Serum Institute in India. And this is the trend and timeline. So we can say that in South Asia, we're the second country to start vaccination. In Southeast Asia, we're the third country to start vaccination, though we could not speed up our immunization because of a lot of limitations, most importantly linked with the supply chain problem. So a lot of guidelines has been planned, prepared by Ministry of Health and Population for community-based testing, and in terms of the total COVID, facilitation group at every community level, where female community health volunteers and teachers or the community workers can be, the very important assets in these COVID Sahajikarana Samma, we said, facilitation group. But this could not materialize because we are relatively new in the exercise of federalism. We have 3 tiers of government, and we try to coordinate with all these levels. Some of the palikas did exceedingly well, but some of the palikas, there were limitations. That's why we could not have adequate contact tracing and the community-based activities. They were even incentivized also for we said we'll reimburse CICT expenses to the palikas, and the protocol has been approved by Ministry of Health and Population. These are the efforts. We do provide 24-hour call service in terms of 1133. 1133 and like that operates throughout the 24-hour, and there is one call center to 1115 which operates 6 a.m. to 11 a.m. and it's again here interactive voice response is also there for general information as well as technical information wherever people want. So in terms of case management, this is a protocol. So the EDCD call center is looking after the Kathmandu Valley cases, and currently as we don't have much cases over the country, they are also doing whole country's case management also from the call center. So they are receiving different incoming calls, outgoing calls, and every day at least 1,000 calls have been taken by the call center. Some of the activities and positivity rates, as we can see the positivity rates, weekly test positivity rate going down, but still we need to ramp up, increase number of tests being conducted. There are a lot of challenges. We can see the disparities in test positive rate across the provinces, and we can see positive case outside and inside valley both are declining. So there are certain subtle differences between two waves. I will not go into detail. I have already saw the ring bell, and we can see the age difference. Age group predominantly affected is around 20 to 59 years. Almost 79.1% of total cases were in that age group in Nepal. And critical number of cases, critical cases are also going down as per our data system, and this is the reported to HMIS in daily update. And I'll just show that the bulk of cases is maximum in Kathmandu, the Bagmati province, 41%. Out of that, 31.7% is in Bagmati province. So I'll not go into this detail. I'll skip this in the best interest of time. And we can see disparities in terms of death among the provinces also. Bagmati province had highest deaths, and we can see the gender difference also. Males were mainly affected compared to female, and our case fatality is as high as 14.94 after 85 age group, and it's lowest in pediatric age group of 10 to 14, 0.06, and 0 to 4 years, 0.48. So at least 92% of deaths have happened in the hospital. The healthcare system has catered that death. We can see the federal hospital, provincial hospital, and private hospitals do share maximum number of deaths. So in terms of these are the financial expenditures in terms of from the government and the donations received from different partners. So I'd like to thank all the partners, all the friendly neighbors and the countries who have supported our endeavors to support COVID-19 program, and we have been distributing those to different palikas. So again, we have started a new initiative where each palikas will have public health inspectors from now onwards. though we had mobilized people as CI/CD facilitators, that could not function that well as expected. So we will be mobilizing at least one like public health inspector in each palika, that is in the rural municipal palikas, and then in the largest metropolitan cities, there are 5 or 7 at least public health inspectors. So we hope to have a better outcome in coming days. We reported black fungus or mucormycosis cases also, and these are few resources for comparison. And only one update: we are going for seroprevalence survey, which we will be going to throughout the country, all 77 districts, and we have divided these 77 districts based on case load into 3 strata. So around 13,700 samples will be collected across the country. Each cluster, 10 samples will be collected. There are 22 strata across the country, and we will be releasing this report, and we are very hopeful that this seroprevalence survey, which we are doing along with the support from WHO, NHRC, Central Bureau of Statistics, is going to be very important milestone in terms of COVID containment, COVID planning in future. With this, I would like to thank everyone and conclude my presentation. If there are any queries, I will be able to respond. Thank you very much. Namaste.
Thank you, Dr. Krishna. Now we take some questions to Dr. Krishna. So any questions from here in the room, please? And then after we'll take the question from the virtual questions, and our colleagues are working to get your questions if there are any virtual questions. Please.
While we're waiting, I'll just make a quick comment and a question. So excellent presentation, first of all. Just wanted to, I don't know if you have the answer right now or not, but wanted to find out the difference between the 2 waves in terms of the age group distribution and the mortality rate. So if you have it, I mean, you can tell me.
We already have that data. Actually, I could not share it here in detail. We found a salient difference in terms of mortality rate compared to 65 years and above earlier. Compared to earlier, almost 1% decline this time in that age group, thanks to the vaccine rollout, more than 65 plus age group. And we have found more death this time in 20 to 44 age group compared to earlier wave. And there is a change in terms of gender distribution also. In previous wave, we had predominantly male affected, around 33% only female. This time 42% females are affected. So that gender age distribution is also there, change is also there. And in terms of case positivity rate, we this time highest age group is 20 to 44 age group. These are some which I can remember now, but we are looking these comparative studies also. We do have data to share that. Thank you.
Thank you, Dr. Krishna. If we don't have any in-house questions, the question that we receive virtually will be kindly answered by Dr. Krishna after the session.
I'll answer over Zoom itself in the chat box.
Okay, sure. So with this, we would like to thank you so much, Dr. Krishna, for your kind, informative presentation. Your presentation basically laid out not only the evidence-based policy, since entire world has been learning a lot from COVID-19, its pathogen, its science, its treatment, its control, its prevention. So I think Nepal is somewhere in the big picture that trying to provide the effective public health measure, effective treatment, policy, and financing the policy as well. And your presentation is highly informative. Thank you, Dr. Krishna, for this nice and comprehensive presentation. Once again, thank you.
Thank you very much. Thank you.
Our next speaker is Dr. Meghnad Dhimal. Dr. Meghnad Dhimal is environmental health, PhD in environmental health, and he is the chief researcher at Nepal Health Research Council, and actually I like to call him chief scientist. I don't think there's a position like that here, because he's the one who runs or looks after all the research activities. I don't know how many, probably more than 100 research activities by himself, and I don't know how he manages. And he's also the main organizer and the main main engine for conducting this research summit also. So Dr. Dhimal is going to present the health research in COVID-19 pandemic in Nepal, and I think he's the most appropriate person to give this talk.
Thank you so much, Chairs, and for a nice introduction also. It's my great pleasure to talk about the health research in COVID-19 pandemic in Nepal. Slide. Just a moment. We all know that Nepal Health Research Council was established in 1991 by an act of parliament, and it has given a mandate to do research and cost to do research at the high level study and research work in Nepal. So it has a clear mandate for the 4 scopes. One for the research regulation, second for capacity building, third evidence generation, and fourth promoting use of the evidence. So guided by the National Health Policy of Government of Nepal, NHRC is continuously working for improving the health status of the Nepalese people. As per our latest health policy 2019, the key policy of the government of Nepal is to promote the high quality health research in Nepal so that we can achieve the international standards. And accordingly, NHRC is expanding its structure, and I hope that in the days to come, it will also amend its act, and we have already formulated the National Health Research Strategy based on the National Health Policy of Government of Nepal. And in the days of this COVID-19 pandemic, we are entirely focusing on how to address this pandemic through evidence-based informed decision making. Our colleague Dr. Paudel just presented earlier, and in each meeting we are together in the ministry, and we are talking about the evidence which are generated at the local level, at the national level, and at the international level. So the ministry is very, very positive to use the evidence generated from the research and to promote the research in the policy and planning process in Nepal. That's very good news for all the researchers in Nepal. So guided by the Constitution of Nepal, which has also a clear mandate for the health research in Nepal, if you see the Article 51 of the Constitution of Nepal, and also Nepal Health Research Council. So now we are working to promote the high quality health research for improving the health of the people through 4 pillars. One is the health research regulation, second is the capacity building in health research, third evidence generation for health, and finally promoting use of evidence. So when we had the first case of the COVID-19 on 23rd January 2020, then immediately you also think the research priority area, and WHO has prioritized the research area in a global landscape, and accordingly we developed this national guideline for strengthening the evidence generation on COVID-19. Then accordingly we started the work for the capacity building in health research in the time of COVID pandemics, amend our regulations for promoting research at the time of COVID-19, because the consent process and others are totally different in normal situations and the pandemic situations. For promoting use of the evidence, we also started virtually and also started communicating the risk communication with the ministry through the virtual way. And also we focus on the COVID-19 research by the ourselves as a race. We also encouraged to do more research on the COVID-19, and we provided the ethical approval in a very short time. Even sometime in a week, we had 3-4 meetings of the ethics review board. Means our aim was to expedite the research project which were related with the COVID-19. And if you see this graph, it clearly shows the good research culture has been established in Nepal. In the earlier days, we had like 2-3 research projects in the country, and mostly applied from the foreign country. But now, if you see the data of just before the COVID-19, we were around like 1,000 research projects approved from the Ethics Review Board of NHRC. Around 2,000 research projects approved from the 52 institutional review committee approved by the NHRC. Means around 3,000 research used to be conducted in Nepal. And even in the COVID pandemic situation, in 2020 we approved 863 research projects. And most of them, around 400 were on the COVID-19. And even this, by the June of 2021, we have already approved 406 research projects. Means good culture has been established. And accordingly, if you see the number of publications of Nepalese scientists in the PubMed, that means that also drastically has increased. That means we have developed good culture, and we have already increased the quantity. Now time has come to promote the quality of the research so that such research can be translated into policy and action. So there are certain types of research which need to be get clearance from the Ethics Review Board of Nepal, that is like somewhat like national and international level studies, external sponsored research, and clinical trials involving human subject and animal subject need to be get clearance from NHRC. Otherwise, we have already approved 52 IRC, and this IRC has a mandate to approve the research project submitted by their faculty and their students. And for this talk, I will focus more on the COVID-19. We have done all 35 research projects on COVID-19 just by from Nepal Health Research Council. And we have already completed 21 research projects on COVID-19. 10 research projects are in implementation phase and 4 are in the ethics review phase, because even for the project submitted from the NHRC also need to go through the expedite review process or full ethical review process. So at the beginning, what we did means we did the assessment of the health-related country preparedness and readiness of the Nepal for responding to COVID-19 pandemic. And similarly, we also did the telephonic survey. Like first we did when there was a first case, second case, then we thought it is better to do the baseline assessment of the health-related country preparedness and the readiness of Nepal for responding to COVID-19 pandemic. And we took around like 95 hospital clinics, and we assessed the situation of the hospital in terms of healthcare facility preparedness and planning, infrastructure, clinical service, support service, human resources, and so on. So that give a good picture. Like if you see the, let's see, ICU bed and ventilator, they are very minimal. And now government has made a drastic change. And just because of this finding, now we can say the progress made by the government. So such study has very helpful for the government to track the progress also. Next we did telephone-based active surveillance of COVID-19 symptom adherence to human quarantine. When there is a foreign returning coming back to Nepal by the air route as well as through the ground route, we tracked their telephone number and we did the survey, and we found that large portion of the returnee have had the good knowledge related to COVID-19. And symptoms involve were fever, cough, and shortness of breath, etc. So the sample size of this study was more than 8,000, and this finding were also utilized later for developing guideline and other, and even from the CCMC. And next, based on the recommendation of the government and the decision of the incident command system, we did the baseline status of the SMS measure, social distance, mask use, and social distances, sanitizer use. And we did a study in the 4,502 individuals and also in the institutional level, and we come up with a quite good finding. Like around 75% people used to use the face masks, but among them around 30%, let's say 20% did not follow the appropriate technique for using, right? So such finding we just generated and we gave to the government. And we are talking about the COVID-19 and even our routine immunization and other were disturbed, but in the same time we did how this COVID-19 and lockdown has affected our essential sexual, reproductive, maternal, neonatal and child health services in Nepal, and we did a survey and we got a very good finding. And all these reports are in our website, so I will not go in detail of all findings. But just I want to highlight, we also did the rapid epidemiological audit of the COVID-19 in Nepal, and we come up with a very good finding. What are the data gaps at the province level, local municipality level, and the federal level. Next, we did also the policy audit. Means government of Nepal has made us so many policy and guideline, but what about the implementation status? We did auditing at the federal level, provincial and local level, and also we come up with a very good finding. Similarly, we did the rapid assessment of COVID-19 diagnostic laboratory in Nepal, enrolling the 64 COVID-related lab, and now we have more than 94 lab in the country. That's also the good progress, but quality part need to be still addressed. Similarly, we did the assessment of the health status of home related COVID-19 patient in Nepal. And now we have some ongoing research project like clinical evaluation of STD decoction in management of mild to moderate COVID-19 cases, open label control trial, because we say we are the rich in the medicinal plant, but what about the use in the COVID and other treatment? So we are doing that. Similarly, we are collaborating with the Oxford University and doing the randomized evaluation of COVID-19 therapy as a recovery trial. Similarly, we are doing the adverse event following the COVID-19 vaccination reported in Nepal and experience of vaccination as a retrospective study. We just completed the willingness to pay for the potential vaccine against the COVID-19 and its association factors, and we came to know that like 75% people are willing to accept the vaccine, but still 25% people do not want vaccine. And among the people who want the vaccine, 65% are willing to pay at least 1,300 Nepalese rupees for the vaccine themselves. So that is the finding of before in the first wave, but if you assess now, the situation might be different, so we are making the follow-up study after the second wave too. Thank you so much, and if there are any questions and queries, I will be more than happy to answer. Thank you.
Thank you, Dr. Meghna Dhimal, for that excellent presentation in such a short time. I know that each of those research projects could be presented for half an hour to an hour. They are very valuable projects. And also over past year, NHRC has done a lot of work and taken a lot more responsibility in terms of research. So I would like to congratulate you for that. Are there any questions from here or from outside on the internet?
If no question from here, I do have two suggestions to Dr. Dhimal. One would be just one of the major role of NHRC is to creating evidence and bridging those evidence into the policy, and that policy, make sure that that policy get the resources, financial or human resources. One of the immediate and pressing need is to conduct the post-vaccine monitoring, as Nepal has accepted number of vaccine to be inoculated in the country, and there are not only side effect but also the antibody status within the human and whether the vaccine is really working or not. That's why my recommendation to you would be also look at the importance of having post-vaccine monitoring, not only post-vaccine monitoring, but also post-treatment effect analysis. We have been hearing from different media that there are a number of side effects after people getting treated from the hospital. These could be two areas for scientists like yourself and your institution to take it forward.
Thank you so much, Dr. Tiwari. Very excellent questions. And there was in slide, but I forgot to present. We have already started the antibody status of the vaccinated and non-vaccinated with the single dose, double dose, and with taking the more than 2,000 sample. And regarding the next question of the post-COVID complication study, also we have started. So thank you so much for a very nice introduction, recommendation. And hopefully within the next 1 month or 2 months, we'll come up with the finding and we'll present. Thank you so much, sir.
Thank you, Dr. Dhimal, for excellent presentation and for all the work you are doing for the country and for the NHRC. Thank you. And I request my co-chairman, Dr. Tiwari, to introduce the next speaker.
Thank you, Dr. Zonet. Next speaker is Dr. Pradeep Gewali. I would like to request Dr. Gewali to, hope he is presenting virtually or? Virtually. Oh, okay. So Dr. Gewali is the Executive Chief of Nepal Health Research Council. By profession, he has done his MD pharmacology. That's why the scientists like Dr. Gewali is of the very much need of country like Nepal, because the COVID treatment, post-treatment effect, and there are a lot of research-related issues, and we are talking about whether Nepal can really start the vaccine development and vaccine production can happen in Nepal, and all these questions can better be answered by Pradeep, Dr. Pradeep and his team at NHRC with his education experience. I would like to request Dr. Pradeep Gewali for his prestigious presentation. Dr. Gewali, please.
सबैलाई नमस्कार, good morning, good afternoon, and good evening. Myself, Dr. Pradeep Gewali, Member Secretary and Executive Chief of Nepal Health Research Council. This morning, I am presenting in the topic entitled Clinical Research Importance, Possibilities, and Future Plans in Nepal. I will be summarizing on clinical research and its importance, current status of the sector and its possibilities, as well as future plans in Nepal. Clinical research is defined as a component of medical and health research intended to produce knowledge valuable for understanding human disease, preventing and treating illnesses, and promoting health. Basically, clinical research is conducted in human or human tissues, including study of disease mechanism, therapeutic interventions, epidemiology, and clinical trials. The interaction between researcher and patient data is key feature in clinical research. It is aimed at deeper understanding of the human disease, identification of new methods of detection, diagnosis, treatment, and prevention, which ultimately contribute to improving human health through enhancing patient care and patient safety. Carefully controlled clinical studies in patients or normal subjects helps understand basic physiological mechanism and their disruption in human disease. In vitro and preclinical animal investigation to human subjects to confirm human relevance of proposed disease mechanisms, which will inform scientifically targeted medical therapeutics. With clinical research, translation of basic science to human studies and translation of new knowledge into clinical practice is possible. Some remarkable milestones of clinical research that include linking HIV to AIDS, lung cancer and tobacco smoking relationship, association of the use of nematode and its association with mercury, antimicrobial discovery, treatments for tuberculosis, tamoxifen and breast cancer prevention, recent COVID-19 vaccine, etc., etc. So we may refer clinical research as bench to bedside translation research. Based on recent national reports, over the recent years, there is persistently high prevalence of communicable diseases, as for example, diarrheal diseases, measles, neonatal disorders, malaria, tuberculosis, and HIV, and non-communicable diseases like cardiovascular diseases, diabetes mellitus, cancers, chronic respiratory diseases, and posing considerable threats to human health, national economy, and attaining indicators of sustainable development goals. However, there are limited clinical data and information on factors associated with illnesses and effectiveness of interventions in our context. This state strongly demands the need of clinical research in the country so as to identify cost effectiveness and novel treatment goals, increase access to modern clinical care, update treating guidelines, and foster scientific and evidence-based decision makings by the clinicians in low-resource settings like ours. Presently, given the increasing number of registered clinical studies in the National Ethical Review Board, it seems clinical research is flourishing in the country. This pandemic has created both the challenges and opportunities in this sector. Despite inherent ethical and methodological challenges of clinical research, insufficient funds in this sector remains the major challenge. There are a few loopholes in the regulatory systems, causing confusions and imperceptibly slowing the processes. Shortage of skilled clinical researchers and infrastructures are more concerning, indicating urgent need of capacity strengthening at individual, institution, and national levels. The persistent political instability has caused significant impact in the sector. There exists contextual ethical concerns such as conduct of placebo-controlled clinical trials despite availability of effective comparator interventions, unethical informed consent despite power inequities, obligation of international high-income countries researchers to readdress health disparities of Nepal and others. In the face of challenges, there are outstanding opportunities for clinical research in the country, which are strong political determination. The remarks this morning from Honorable Prime Minister is motivating to us and relevant stakeholders for organizing research, clinical trials of therapeutics and vaccines. Similarly, prioritizations in health policies of research for infectious diseases have been milestone. Strengthening research capacity in developing countries like Nepal is one of the most effective and sustainable ways of advancing health and development in the country, as well as help in correcting the gaps in health research and contribute to overall global health. The future plans of the country are conducting clinical research, especially based on national priorities, thereby developing a tailored mechanism to recommend to the health policies through translating the concrete evidence and respond to the country's needs, reinforcing national capacity in the sector, making appropriate and timely revisions of the national guidelines and procedures for clinical trials for diagnostics, therapeutics, and vaccines, creating favorable environments for pharmaceutical companies, academic and research institutions, philanthropists, sponsors for clinical trials and product development, to promote local investigator-initiated clinical research in the country, and making necessary revisions of guidelines to research. With this, I would like to conclude my presentation. I thank you all for your attention. Namaste. Thank you very much.
Thank you, Dr. Pradeep. Any questions, in-house question to Dr. Pradeep? If not, Dr. Chanak, would you have any suggestion to him, Dr. Pradeep?
I think that was excellent overview of how, the research, regarding the research policies of Nepal and what are the possibilities in the future in terms of research in Nepal. So if Dr. Pradeep is listening to me, I think we should continue to grow the research in Nepal, make it more organized, and make it more scientific, and collaborate with the international communities so that we can also be ahead and in the forefront of research so that we don't have to, as a clinician, I know that we read a lot of textbooks from the Western countries, which may or may not apply or imply to the Nepalese population. I have seen things, my students, residents, studying about research from Western countries and trying to implicate that in Nepalese context, but we have to do our own research, we have to build our own database, we have to do our own epidemiological study so that we can actually treat our patients based on our textbooks, not the Western textbooks. And I'd like to congratulate for that nice talk, Dr. Gewali. Thank you very much.
So if there are no questions, maybe we chairs are putting some suggestion to Dr. Pradeep. Dr. Pradeep is here with us. I think sorry. Oh, which way it goes? I didn't intend to block him. So Dr. Pradeep, thank you for this really good comprehension. And I know it's going to take a lot of time to really describe each area, issue, and way forward. One of the sitting questions that we have in Nepal is what is our preparation in terms of proceeding with the clinical trials? It could be therapeutic, it could be vaccine. What are the technical difficulties or technical preparation that country is facing, and what are the preparation of Nepal Health Research Council, so that Nepali people will soon able to listen this good news that trials happening in the country and ultimately vaccine produced in the country. Dr. Pradeep, please.
Thank you, Dr. Suresh, for a very nice question. And our respected chairs, Professor Janak Koirala and Dr. Suresh Tiwari, and all the participants. So we are on live or in person. So just I aroused the issue of clinical research. So this is because this is very new in our country. So we have just started the clinical research capacity in the country. So NHRC is taking the lead. So recently, just we conducted some few researches like clinical trial of favipiravir. So that is a Nepali company made medicine, and the trial is going on. And the second is the remdesivir and convalescent plasma therapy that was successfully conducted as a clinical research. And we are also organized international type of trial, randomized evaluation of the COVID-19 therapy, that is recovery trial. So that we are conducting the study for the high dose of steroids. So just we are started the clinical research capacity. So that's why we need to have the strong collaborations between the institutions like medical institutions or hospitals, and we have to also improve the capacity of the researchers, so young researchers. That's why we have into the phase of the clinical research capacity building. So recently we conducted the training like systematic review meta-analysis, and we are planning to conduct RCT, randomized control trial of studies, and we are also try to involve the clinical researchers. So we have now from the very beginning we have successfully conducted observation studies. Now this is the era of the clinical research, RCT, randomization. So that's why we can make some protocols, design, or some we can change the clinical practice also. So now, as your question, so we are planning to conduct like clinical research, like clinical trials. So recently our Nepal government had passed the clinical trial process, and so that the door is open. So if any company or organization that want to do a clinical trial in our country, first the proposals should be submitted to our ethical review board, and our ethical review board scientifically discuss with the proposal, and after finalizing the proposal by our scientific body, so that file goes to the Ministry of Health and Population, and from that it goes to the cabinet, and cabinet will allocate some points for the clinical trial, like those of the vaccines or the timing of the vaccine getting to the people, and the pricing of the vaccines, and if any company want to produce the vaccines, so that can be also possibility. So after having that, so that file goes to the DDA, and we can get the final approval. So that's why we are planning to conduct clinical trial, and we are increasing the capacity of the clinical researchers, and having the MOU between different institutions, and planning to make the center for excellences for a few institutions or few hospitals in the country. So that is our plan. So for that purpose, so we need to have the strong collaborations between the researchers, collaboration between the different institutions, and support from the ministry and the cabinet, and the support from the international organizations as well. So that is the collective work. So if you can get the collective work, so we can be successful also. Thank you very much.
Thank you, Dr. Pradeep, for giving comprehensive answer here. And as we understand that in order to move to next level of scientific era, every country really needs some time, effort, and critical analysis before we get into the vaccine development and trials and so forth. So I think we believe with your under your leadership, the young scientists in this country will see the silver line nearby them, so that the clinical researches, clinical trials, and the therapeutic and vaccine developments happens in youth's time, in your time, in your generation. Thank you, Dr. Pradeep, for this. Now, Dr. Zanok, please.
Thank you. So thank you, Dr. Pradeep, for clarifying that and telling us what's going on. And to segue to the next speaker, I just wanted to also add to what Dr. Pradeep Gyawali just presented, that it's important to build up the capacity of the medical institutions in Nepal. As we know, we have growing number of private institutions, academic institutions, who also have excellent physicians and probably have a lot of research capacity if provided support. And I think similar to the other countries' model, we should also start providing support to them in terms of technological support, as well as in terms of financial support and all kinds of the support that the researcher in this country would like to get, so that they can also advance the research at their institution. So in the same manner, we have a presenter, next presenter, which is Dr. Diptesh Aryal. He is an intensivist and ICU coordinator at Nepal Medicity Hospital. He has done his MD in anesthesia from Tribhuvan University Institute of Medicine, and he has also done his clinical fellowship training in critical care medicine at St. Michael's Hospital, Canada. And Dr. Diptesh Aryal is presenting online, I believe, and his topic today is why participation in clinical trial platforms matter during pandemic, implementation of REMAP CAP in Nepal. Dr. Diptesh Aryal, please go ahead.
Respected chairpersons, all the dignitaries, and the participants, thank you for giving me this opportunity to present some of the work that we have been doing regarding clinical trials in Nepal. And I'd like to share my screen here. So in the next few minutes, I'll be basically talking about why we need to invest more on capacity building for research development in our setting, especially the in low and middle income country settings like Nepal, why it is important. And I'd also like to share our experience of implementing one of the biggest clinical trials in COVID, REMAP CAP, which is a global trial, and we have been successfully running this trial in 5 sites within Nepal, and there have been some significant contribution from our side to this truly global clinical trial. So REMAP CAP is a randomized, embedded, multifactorial adaptive platform for community-acquired pneumonia. This trial, initially was started in 2016, especially after the H1N1 pandemic that happened in the a few years back. This was a project led by Monash University in Australia, and recently this has been adapted for COVID since 2020. At this moment, over 300 sites in 21 countries are participating in this global trial, and in Nepal we have 5 sites, and we have been doing some 3 domains of interventions within this clinical trial. Why this particular trial is so important? Because compared to the conventional trial, this has a very different type of design. So here in this trial, the patients can have a random allocation to more or one or more interventions. Like there are different domains where the therapeutics are tested simultaneously, and one patient can be randomized to more than one interventions. And one of the good points about this, the design of this trial is this is embedded in a already existing clinical registry. So that makes the data curation and the implementation part very simpler and more like a sustainable and adaptive. And within the same trial, there are different patients can be randomized to more than one interventions. And this is also something very different, like in the convention trial where they have to test the things in sequentially. Most of the patients can be randomized to more than one intervention and they can be tested simultaneously. And the good thing about this trial is like this is an adaptive model where the regular data analysis goes on to decide whether the trial needs to be stopped or modified. Like this kind of trial doesn't have a fixed sample size. Like based on the randomization and the enrollment, as soon as the results are obvious, the trial can be modified or stopped. Like if there's the intervention is inferior or superior, or you can reach the endpoint at certain during the trial itself. So these are the few very peculiar and advantageous characteristics of REMAP-CAP, and this has helped generate the evidence in this current COVID pandemic. So the adaptive design is very different from the traditional clinical trial, and we have been following this, where a patient can be randomized to different interventions and different outcomes can be tested simultaneously. So this is the REMAP organizational chart and the International Trial Steering Committee, under which we have been, the Nepal National Coordination Committee works under Critical Care Asia Network. So that's a regional network with whom we have been collaborating. And this has been very important because let me just share with you all the what barriers that we usually face when we run clinical trials in LMICs. So we all know that high quality clinical research co-designed and conducted in low socio-demographic countries and in low resource constrained LMICs is required in order to discover or verify both the efficacy and effectiveness of these different interventions in these diverse settings. But LMICs remain severely underrepresented in clinical research, and most of the research work are concentrated only in high-income countries. So there are some of the barriers that have created this situation is the limited expertise of infrastructure or to conduct this kind of research. There is lack of financial and human resources and lack of peer-to-peer support. And there are complex ethical and regulatory processes which to navigate cost both time and energy for already overburdened clinicians. So it's very difficult to run a well-designed clinical trial in LMICs. But with the collaboration with the REMAP-CAP and Critical Care Asia Network, we have been able to implement this platform trial, and this trial is supported as a welcome model Critical Care Asia LMIC-led collaborative. So we have our own regional management committee which help in implementation and the monitoring of the trial, and we have used the CCA registry platform. Like there's a ICU registry which was already built up that helped us in using the existing infrastructure to operationalize the REMAP-CAP in LMIC ICUs of Southeast Asia, including Nepal. And we are also collaborating with NHRC to scale up the registry and the clinical trial potential opportunities across different ICUs in Nepal. So that's in the pipeline. So the collaboration of international clinical trial and the regional bodies like Critical Care Asia has been quite fundamental in helping us implement this trial in Nepal. So what we have basically done is we have followed this approach of CCA, where we have focused on strengthening an already existing community of practice, like that's been going on for quite some years within the CCA registry network, and
Dr.
there have been
Diptesh,
support not only from national but international
Dr. Diptesh,
colleagues and support system, which have
2
helped
minutes
us.
warning, please. 2 minutes. You have 2 minutes more.
Sure. And we have been they have been helping us in this, and this has been embedded within the registry. And with that, we have implemented this trial in 5 centers in Nepal, and we are currently running 4 domains: anticoagulation, vitamin C, aspirin, and simvastatin. And this is a summary of the screening of the participants. So we have screened almost more than 1,500 patients and enroll almost 400 patients in this trial. So the anticoagulation domain, there have been 2 significant publications on this, where it has been proven that therapeutic anticoagulation in critically ill patients in COVID-19, it doesn't help. So this has been a major achievement of this trial. And there's one more publication which is under peer review, like in patients with moderate COVID, the therapeutic anticoagulation does help in improving the outcome. And recently, aspirin, this was also one of the domains of the trial, and because of the no ineffectiveness of the aspirin in COVID outcomes, this domain is on pause. So these are, we are part of all these domains, and we have contributed to generate the evidence, and we look forward to continue our work with REMAP in contributing the evidence for the for COVID. So finally, I'd like to conclude by saying that the implementation of REMAP CAP for COVID trial in LMICs like Nepal is feasible, and this can be facilitated by multidisciplinary collaboration, just like we have built with Critical Care Asia Network. And this investment, which has helped us in build up the capacity, will establish important groundwork for future learning health system endeavors, including research projects, and the operationalization of randomized control platform trial in registry embedded manner in LMICs in a network like Nepal can be a stimulus for further democratization of international trial participation. So with that, I'd like to thank everyone, all my team members, NHRC, and all my seniors for giving me this opportunity to share our work. Thank you.
Thank you, Dr. Diptesh, for that excellent presentation. And thank you for all the work you're doing on this important front. As we know that, as a clinician, we know that the anticoagulation, therapeutic versus preventive anticoagulation was a big question. And of course, you have seen that, including, the trial in Nepal has shown that the therapeutic was not as effective or was not as important as it is in terms of the preventive anticoagulation. So, and then I'm sure that there will be more data that will be coming out of this trial, and this is one example of how the private as well as the other institutions who also can do this kind of important research that could contribute to the science. And thank you for that presentation. Are there any questions on the floor or from the internet? And also, after all the presenters will present, we'll have a discussion session where we will take the questions from the internet, meaning all of the platforms that are being used right now. And the speakers will come to the stage or from their own site, and then they will answer the questions. So please send your questions to the speakers. So I don't see any questions right now, but I'll request the speakers to stay online so that the questions that will come through the internet will be compiled, and you can answer those questions at the end. I will request Dr. Tiwari to introduce the next speaker. Thank you.
Thank you, Dr. Zanak. So I would like to call upon the next presenter, Dr. Roshan Hanifa. She is presenting importance of registries in low and middle income countries. Dr. Hanifa is a senior clinical researcher at University of Oxford, and she has done number of research in the area that she's presenting today, and her interest is to carry out the clinical researches in the developing country across the world. And I would like to invite Dr. Hanifa. Dr. Hanifa, please, your presentation starts now.
Thank you very much. It's a real pleasure to present today. Thank you to the NHRC for this invitation. And I hope I can outline some of the benefits of a registry in low and middle income country settings. So I work for the University of Oxford, but I'm also lead of the critical care registry in Sri Lanka. I'll share some experiences from there as we talk about the benefits. I also co-lead the Critical Care Asia and Africa program Diptesh highlighted in the last talk. It's a network which is across, sorry, just going to try and move this slide. Yeah, so it's a network which has been implemented across more than 15 countries in Asia and Africa with the aim of developing quality evaluation, quality improvements, and clinical trials in those LMICs using the registry or a critical care registry as the basis of that platform. So I'll speak a little more about that. I just wanted to give a highlight of the Critical Care Asia Africa network. Diptesh highlighted that this is an LMIC network. This is at the moment more than 15 countries across Asia and Africa, federated and curated by the team in Sri Lanka who lead this collaboration. Over the last year alone, we've had more than 48,000 patient encounters with and without COVID contributing to this network. So some of the lessons and experiences I want to highlight about the potential benefit of registries in LMICs come from this experience, and also some of the experiences from colleagues across the world, and I will share those a little bit. So I wanted to talk about maybe 6 reasons why registries are important for LMICs and why I think they would be a good vehicle to accelerate some of the challenges and opportunities which are being highlighted in the talks this morning hosted by the NHRC. The first reason why I think registries are important is because they are an essential component of learning health systems. So what do I mean by learning health system? A learning health system seeks to improve continuously. It is seeking information about its performance, looks for its strengths and weaknesses in terms of patient structure, process, and outcome measures, and then is seeking to improve in an iterative, cyclical manner, motivated by within itself, not necessarily motivated by government, regulators, or international funders, but with an inherent internal motivation. For a learning health system to function, it is important for there to be continuous data, which is reliable and collected by the health system in a continuous cyclical manner. In addition to that, it also needs to have a community of practice, people who are interested in leading this work and participating in those evaluation improvement cycles. Thirdly, with the learning health system being hosted by the platform and the community of practice, you need data-driven research and improvement. And people have talked this morning about some very nice examples of how that could happen. Diptesh talked about a particular example of Remap using this registry platform. A lot of the projects which are being described as being happening in the hospitals could be potentially enhanced and improved by such a learning health system platform, which is what the registry is. So a registry at its core records patient information about every episode admitted to that institution for a particular setting. The registry we are talking about predominantly talks about the critical care registry, is based on ICUs, but The same platform is being used in other countries in cardiology and in perioperative medicine, and I'll give some examples of that. So the registry outline I'm describing is not limited to critical care, but a lot of the experience we have is coming from critical care. And I will highlight maybe 5 more reasons why the registry approach will be beneficial. I wanted to talk about the community of practice, and Diptesh highlighted an LMIC-led collaborative network. The registry at its core enables these collaborators, research projects, and improvement efforts to happen using it as its center. The second reason I wanted to highlight was service improvement and operational research. In Sri Lanka, the critical care registry networks every ICU in the country. It works across more than 130 adult, pediatric, and neonatal ICUs, and it provides an emergency bed system for Sri Lanka. We operate that for the Ministry of Health in collaboration with the Ministry of Health. So when somebody wants to find an ICU bed, they ring this number and we help them find this number using a very basic technology portal and some telephone lines. It means that the Ministry of Health, the administrators, clinicians have access to a portal where they can see how the beds are occupied or not occupied. And you can see this importance in COVID, you can see this in adults, pediatric, and neonates. And this is kind of the impact it can have on a month-to-month, day-to-day basis. You can have near real-time information, and you're also saving lives by directly helping patients find ICU beds. And this is an example of a new portal which we have developed for the same service. I have blacked out the hospital names. Really delighted to say that the same facility is available through NICRF and NHRC for Nepal if people were interested and wanted to use the system. Our team would be delighted to facilitate that for the system to be hosted out of Nepal and to be used in a similar manner as we are using in Sri Lanka. Very, very happy to help do that. The third reason I wanted to highlight was about enabling observational research. Because the registry infrastructure is already there on the ground, a lot of the research which can come on top of it can be seamless. So for example, when COVID started last year, we could adopt the registry platform from centrally and push out to each individual unit, and including units in Nepal, if they wish to participate, could contribute to ISARIC without having to collect extra data. So for example, our system has contributed nearly 13,000 patients with suspected and confirmed COVID to the ISARIC registry platform, which is nearly a half of the LMIC-based contribution from ISARIC, which is very important, and it means data collection burden for sites is very minimal. All the curation is done by a central team, and participation is voluntary and is led by the LMIC stakeholders. It also means, for example, this is an example from Pakistan, which is about to be published. If people on the ground in Nepal and Pakistan wanted to publish their own research, they can still publish it, but they can also publish it in collaboration with ISARIC. And our team would be delighted to help curate and moderate and mentor anyone who wants to publish it. And I know, for example, Dr. Hempaneru is about to publish his work using the registry data. The fourth example I wanted to highlight was that it enables safe and equitable data sharing. This is always a challenge. Who should share the data? How should it be shared? Is it safe? What are the challenges of sharing this data? By having a team of people who are used to collecting data, by having permissions already from NHRC and from the institutional administrators, there are already rules in place about what data is allowed to be shared and what cannot be shared. So if a new data request comes, the local stakeholders can decide how they wish to share the data. I already highlighted about ISARIC. This is another example called Logic, and there's another example which is the WHO. So the LMIC stakeholders are now contributing data to platforms which are good global. These are global critical care data platform. And if Nepali hospitals are willing to contribute data, we can also contribute data to the Logic platform, which will mean when people are looking at data internationally, and this portal has more than 13 million episodes, each year it has more than 1 million episodes from across the world, it means LMICs are also part of that contribution and collaboration. The way we can do that is we can federate the data. So it can happen from different sites. If, for example, Nepal didn't want to contribute data, it's not a problem. We can make sure that the data from Nepal is not shared until the sharing is ready to be enabled. The fifth example, or the fifth reason I think the registry is important, is it enables QI. Quality improvement is central to what we do as clinicians, administrators, and what we expect as patients. We want systems to keep improving. So I give a couple of examples. So the registry is enabling quality indicators to be collected in Sri Lanka outside ICU in the cardiology units. It includes 6 tertiary centers in cardiology. It has captured more than 5,000 patient episodes. And what it has highlighted is there are gaps in secondary prevention, there are gaps in time to reperfusion, and there are gaps in cardiac rehabilitation. So what now the registry enables us to do with the clinicians, with an internal drive, is to make efforts to improve those processes. And the registry then enables those processes to be audited in a cyclical manner with no extra effort to capture process improvements using the same platform. Really nice example of locally led quality improvement using an international platform. I give another example. This is a perioperative example, and I move on to my last slide shortly. The perioperative example is a quality improvement project in Ethiopia, which is led by a non-physician anesthetist in Ethiopia, and they have highlighted some gaps in quality of care before and after surgery in Ethiopia and Sri Lanka. Again, locally led quality improvement using the same registry platform. And these are some examples of feedback systems which are inbuilt into the registry, which can provide that feedback. And the last example was registry embedded trials. Diptesh has already highlighted how REMAP CAP is happening in Nepal, India, Pakistan, and also in some other CCA countries soon. MEGAROX is another clinical trial which we hope NHRC will shortly give approval, and we can again get going in Nepal. We know the recovery trial is also going to be co-hosted from the registry, and congratulations to NHRC and the Nepali team in getting the recovery trial going. I won't talk more about it, but it's embedded into the registry so that data collection, screening, monitoring, and follow-up are all seamless. So it's possible for a remote team such as ours, based out of Sri Lanka, to help the team in Nepal, in the individual hospitals which are burdened with COVID, to help with the screening, monitoring, enrollment, and with the data quality issues before sharing seamlessly with the central team, whether that is with Monash for REMAP or in Oxford for recovery. Lastly, I wanted to say, hopefully I've given an overview of how the registry system is useful for every site in Nepal and internationally, but mostly it creates opportunity. It creates opportunity to individual clinicians such as Diptesh or Dr. Paneru, or for the team in NHRC to take forward the projects they want to take forward, and also for nurses, physiotherapists, and pharmacists, whether that is a local quality improvement project, whether that is an MSc project, or whether it is a PhD project. The registry gives the platform for those projects to be embedded efficiently into the health system in collaboration with the local stakeholders. And if anyone's interested in making those collaborations, please contact Dr. Diptesh. He is the lead of the registry NICRF in collaboration with NHRC in Nepal. Thank you very much for this opportunity. If there are any questions, I'm happy to take them online or also answer on the chat. Thank you very much.
Thank you, Dr. Hassan. The quick improvement, I mistakenly say her, C there. This was part of maybe respecting you. The C is always respected. Sorry for being a little bit your information was not well distributed. And now we know, all Nepali young scientists heard you today, and all the researchers, policymakers, the professors, the clinicians, practitioners have heard you today. It is really useful, and thank you for nice presentation. May I request the colleague here in the room to have floor any question to presenter today? Dr. Janak, please.
Dr. Hanifa, thank you for that excellent presentation and highlighting all the importance of registries. It's very important, and we realize that, and I think we've also tried to build some or start some registries at NHRC. I'm involved in one of them, and the problem we are facing is that getting the information together. Even though we have done a lot of webinars and try to get the institution involved, probably the amount of information you have to put in or the amount of work is involved. Unless you have a designated person, it's very hard to do it. So I just wanted to hear from you briefly, what do you do to ensure the data is entered into the system? How do you collect the registry data? We can't hear you. I think your microphone is off.
You are mute.
I have unmuted. Are you able to hear me, sir?
Yes, now.
Okay, thank you. Thank you. Yes, I think that's a very important question. Thank you for raising that. This is a challenge all registries face internationally. So I wouldn't be disheartened that it's a problem you're facing. The strategies we use are to show benefit of the registry to the local user in some way early on. And it's important that the benefit is apparent to the user. So I give two examples. One example is the bed system in Sri Lanka. It's obvious to the user that they can see how that impacts everyone. Another example is a local quality improvement project. So rather than being an abstract research question, research questions are difficult for clinicians and local site leads to understand and anticipate, because they see that as a little bit abstract and they see that as a little bit further down the line. And they see the benefits as later. Whereas if you can make the registry answer or solve a problem which is immediate or local, whether that is remap CAP, whether that is a quality improvement project we are helping some colleagues in Nepal, whether that is a colleague taking on a PhD project, whether that is solving an operational issue like a bed system, that for me is the best way to get traction. But in answer to your question about personnel, our learning is also sometimes you have to hire data collectors. And it's important that you can hire them in a sustainable way, in a distributed network, and very happy to discuss a bit more if you want some practical examples, and happy to chat with you and Diptesh about that if that helps you, sir.
Thank
you. If not other questions, Dr. Hanifa, I have one kind of intuition. You must have gone through such kind of intuition coming from different people already, but bear with me if I'm repeating that. So while listening your presentation this morning, specifically the importance of the registry, why we conduct the registry, yeah. So if you diversify your audience or user of the registry, I think the benefit can be plotted into the primary and secondary benefit of the registry. If your presentation, if a secretary of Ministry of Public Health listens, uses the registry, his interest is more on the policy than the quality, right? If a minister uses the register, who knows, we get in Bhutan, the Prime Minister is clinician there. So, right. So what is the message? What is the importance of registry for the policymaker, for the managers, for those who allocates the resources? I think these three areas, if you don't mind, maybe need to be looked upon while presenting or while writing the paper on these important topics. Just a suggestion. If I repeated it, I'm sorry for that. Over to you.
Thank you. Your intuition is very correct. I think it answers also the first question I was asked. No, because the audience is different. You need to cater to the different audiences, whether that is administrators, policymakers, clinicians, or local sites. My learning is you can have something for everyone. You can't have everything for everyone. That's not possible. But you can have something for everyone. And our experience is that you can do that in a practical and sustainable way. And we look forward to doing that with NHRC and NICRF. And yes, we can distribute it in different settings.
Thank you. Thank you for the response, and thank you for your time this morning. Thank you, Dr. Hanifa. So, Dr. Janot, please, next presenter.
Again, thank you, Dr. Hanifa, for that excellent overview. I would again remind all the speakers who are on the internet as well as on the floor to stay around, because after this last presentation, our final presenter is presenting next. After that, we'll have discussion session, and there are questions coming through the internet for you. So please stay around, stick around, and we'll let you know after this presentation. So moving to the next presentation, our next speakers, there are two speakers for the next presentation. And the first one is Dr. Sorry. There are two names, Professor Dr. Simon Ruston and Professor Dr. Susan B. Marhata. So the presenter today is Dr. Simon Ruston, who is the Director of Research and Deputy Head of Department of Politics and International Relations at University of Sheffield, UK. Dr. Simon is also an Associate Fellow of the Centre of Global Health Security at the Royal Institute of International Affairs in UK. So Professor Dr. Simon Ruston, he is going to present the effect of federalization on Nepal's health system. Professor Ruston, please go ahead.
Hello, and thank you for coming along to listen today. My name's Simon Rushton from the University of Sheffield in the UK, and I'd like to start by thanking the organisers for inviting me to give this talk. I'm afraid I'm pre-recording it. I can't be there in person because it's extremely early in the morning in the UK. But I'm going to talk to you for about 10 minutes about our research project, which is ongoing at the moment with colleagues from Nepal. And Professor Sujan, I think, will be there and will be able to engage in the discussion and to answer any questions that you might have. So I'm going to start by sharing my screen. And what I want to do today is to introduce you to a project which began about 1 year ago. And of course, almost coincided with the beginning of the pandemic. So has had a difficult first year in many ways. And this is a project which is being run by a team of researchers from the UK and from Nepal, including Professor Sujan, who's with us today. And I'm going to be presenting in this talk on behalf of the whole team. As you can see by the title, this is a project which is looking at Nepal's transition to a federal system, and particularly looking at how that transition is playing out in the context of the health system. I'm going to start by giving a brief overview of the study, and then I'm just going to give you a brief update at the end on some of our early findings which are emerging from the fieldwork that we've done so far. So this is a project which is funded by the Health Systems Research Initiative, which is a collaboration of different UK-based health research funders. And it's a 3-year project which began in April 2020. So as I said, we're just over 1 year into this 3-year project. It's a very large team, I think over 20 researchers in all involved in the project, including 7 research fellows working on the project, 2 here in the UK and 5 in Nepal. And we're working across a whole range of disciplines, so bringing together scholars from public health, from sociology, health systems, health economics, from political science, which is my own background, and many other disciplines. So we're really taking a very multidisciplinary look at Nepal's health system and the way that the move to a federal system is impacting upon it. And I just wanted to outline some of the key features of the project design. This is a project which is looking over a 3-year period at this process of change, a process which of course started before the project started, but nevertheless we're going to be tracking it over that 3-year period. And we're very much working in an applied way with stakeholders in the health system, working with them to co-produce ideas that can be put into practice. So we're not a team that's coming with a set of solutions. We're a team that's coming with a set of methods and ways of engaging with health system stakeholders. Really importantly, we're working at all levels of the health system in this project, starting from the bottom and working our way upwards, working from the service delivery level, whether that be the village health post or health centres in urban areas, right up to the federal government level. And we're also interested in the health system as a whole. We're using as our framework the World Health Organization's health system building blocks, which I'm sure you'll be all familiar with. So we're looking at all of these different building blocks and how each of them has been impacted either positively or negatively and by the shift to a federal system. And lastly, I think, and perhaps most interestingly, we're using a lot of participatory methods in this project. As I said, we're not coming with a kind of set of solutions from the health system for the health system. Actually, quite the opposite. The whole ethos of this project is that those working in the health system at whatever level, from female community health volunteers right up to ministers at the federal level, are the real experts. And what we're trying to do in this project is to gather information, of course, but also to facilitate spaces that allow people to reflect on their experiences in their working lives in the health systems, to identify problems, identify areas of good practice, and for them to work with us to produce ways of addressing any of the problems that are being thrown up by federalisation. Of course, with the aim that we make this process as smooth as possible and make sure that its impacts on the health system are as positive as they can be and that any negative impacts are mitigated as far as possible. I'm not going to read through all of these, but these are the research questions that are underpinning the project. And as you can see, this is essentially what I've just said to you in the last few minutes, which is about this move to a federal system, how stakeholders within the health system perceive those changes, how that's playing out across the different building blocks, how can we strengthen, capture the positives of moving to a federal system and mitigate the negatives. And hopefully at the end, we'll also be able to learn some lessons from Nepal's experience, learn some lessons for other countries that undergo similar shifts from unitary to federalised structures. As I've already mentioned, we're using some participatory methods, but we're using some more traditional, let's say, social science research methods too. We've already undergone a process of writing some systematic literature reviews covering various aspects of the project. We've done a review of policy at different levels, and one of our colleagues here in the UK has been undertaking a really important piece of work looking at the provincial health policies and the similarities and differences between the provincial level health policies. We're doing key informant interviews and focus groups. Of course, with the pandemic and lockdowns and so on, some of those have had to be done online or by telephone, and some of that work has naturally been delayed. But we were fortunately, between the waves of COVID, our researchers were able to get out into the field to do some of that data collection in person also. What we'll be starting soon at the end of the summer will be a series of participatory policy analysis workshops, and that's where we'll be working with health system stakeholders, bringing together stakeholders from different levels, whether that be the service delivery level, district, provincial, or even the federal level, bringing together stakeholders through a series of participatory exercises and programs to try to analyse problems that have been thrown up by the move to a federal system, try to work together to identify potential solutions or mitigation measures for those problems, but also, of course, to try to work together to identify good practice, and perhaps good practice that can be shared to other provinces or to people working in other areas of the health system. Alongside this, we'll be doing some quantitative analysis on the secondary data to try and understand how this shift over time to a federal system is feeding through into health outcomes, into health service utilisation data, and so on. And importantly, we're not going to be sharing all of our findings at the end of the 3-year period. We're going to be sharing these findings as we go along, with the idea that hopefully the findings from this project, the ideas and the solutions that we generate through this participatory policy analysis process can be fed back into the system in real time. We've selected 3 provinces in which we're working, and within those some particular districts and research sites. These have been selected, as you'll be able to tell from the map, to really, I suppose, try to capture at least some of the diversity of Nepal in terms of course, geography with the Terai and hill and mountain regions, but also in terms of different demographics, different population dynamics, and different health challenges as well, different degrees of remoteness. So we're working across these different areas, and we've already gone through a process of selecting particular wards in which we will be working in within those particular districts. Finally, I wanted to just give you a kind of update on just over a year into the project, where we are, and I'm using here some slides prepared by my colleague Dr. Sapkota, who's one of the research fellows working on the project based from the Manmohan Memorial Institute of Health Sciences. As I've already mentioned, we've already conducted in the first few months of the study some literature reviews, systematic literature reviews, examining various aspects from the global level. What can we learn globally about how other countries have coped with the move to a federal system and what that's meant in terms of the health system, but also the literature that exists on Nepal specifically and on the health system in Nepal as well, of course. As I mentioned, we've managed to do a first round of data collection. This was, as you would expect, significantly impacted by COVID and by the lockdowns. We're not, according to the original plan, of course, which was developed pre-COVID, we haven't done as many in-depth interviews, and we certainly haven't done the PPA workshops, which have been delayed due to COVID. But nevertheless, we've already collected quite a significant amount of data. As you can see from this slide, we've conducted 67 in-depth interviews at all different levels of the health system so far. Those are currently in the process of being transcribed and analysed, and we've already got some of the early findings, which I'll talk you through in a moment, starting to come out of those. The participatory workshops, as I've already mentioned, we're hoping that the COVID situation will be, after the monsoon, will be such that we'll be able to start those workshops and start working over these last 2 years of the project with stakeholders at all different levels on some of those participatory initiatives. So what are we finding? I want to really stress that these are very preliminary findings just based on our initial analysis of not even all of the interviews have been transcribed yet, but we thought it was worth at this stage coming to this summit to present some of these initial findings. Certainly we find stakeholders are identifying a strong link between this move to a federal system and local level development and local level empowerment, and the ability of health system actors at the local level to really make decisions and to implement changes. And I think we've seen some really important examples of that through the COVID response, which of course was something that we weren't anticipating when we designed this project. But I think some really interesting findings about the ways in which that local level agency and local level flexibility has allowed for the kinds of COVID response that in a more unitary system may have been perhaps more difficult to implement. We've also found that many of our stakeholders have been very keen, and this is of course true, to stress the fact that federalisation isn't an event which happens overnight. So this is very much a process. It's very much an ongoing process, and I think that's really vindicated our decision to try to track this over time rather than to just look at a particular snapshot in time. there's been some concerns raised by some of our participants about the impact on the health system, about how that could undermine health indicators, about some of the confusion and complexity that's been introduced into the system in different ways. And even, as you can see on this last point, some of our participants suggesting that we didn't need this, and that this is a degree of system change that we didn't need, that we already had, particularly at district levels, local structures capable of doing these things. And some people have so we've had a range of views, from the very positive about the move to a federal system to more cautious or more negative views, let's say. Oops. In terms of opportunities and challenges, definitely, as I've already said, a number of stakeholders at the local level have talked to us about the opportunities that they have in terms of increased responsibility over allocating resources. That means that they can tailor those to local needs more, and that they can essentially be more responsive to local needs, which is, in the kind of theory of federalisation, is one of the things that it's hoped will occur. But also many challenges have been identified about coordination between levels, about cooperation between levels. Interestingly, quite a lot of work about people's mindset and actually how people very often working in the health system are still thinking in terms of the old structures and how difficult it is for them to reorient not just their organizations, but also their individual mindsets into the new structure. Lots of interesting findings about the power dynamics between the different levels, and particularly about those who control the resources very often are seen as those with power. And also some skepticism about the capacity of the local level in different places to be able to really carry out the functions that are being asked of them and really be able to make the most of the opportunities of decentralization. In the interest of time, I'm not going to go through all of the building blocks in a lot of detail, but we've already started trying to use this building block lens of the 6 building blocks to try to identify some of the opportunities and some of the challenges that are being found across all of those building blocks. So you can see, for example, if we take the human resources building block, real issues around the adjustment of the workforce, staffing those ministries at provincial level, all of those kinds of questions which have been thrown up. But similar opportunities and challenges we're finding across all of the building blocks: leadership and governance, medical products, financing, service delivery. In some of these areas, including service delivery, stakeholders have been saying to us that they haven't seen actually major changes or major disruption in terms of the move to a system. In other places, for example, in terms of health financing, that's being seen much more as those elements. Please do feel free to get in touch with either myself or Professor Sujan or the rest of the team if you want to follow up, or if you have any questions or anything you would like to discuss. And in the meantime, thank you all very much for listening. Goodbye.
Thank you, Dr. Rushton, for that excellent presentation and the work you're doing in terms of the impact evaluation of federalization of health system in Nepal. Like any other change in the country, any country which goes to the change, there are always challenges. Our system also became federalized not too long ago, and our health system, of course, there are new structure, new division into the provinces, and more power to the provinces and the local government. So that always creates confusion, miscoordination, and things like that. But we all hope that those challenges will be taken over, and with time, all those challenges will be met with new solutions, and it'll progress towards the becoming a better system, health system in the country. I'm not sure if Dr. Rushton is available to take my question or not, but one good question here would be, I see that you're doing a lot of interviews, workshops, and discussions and things like that to look through this, the impact evaluation you're doing. We'll also look at those actual data and the health indicators. Thank you again to Dr. Rushton. We will move to the discussion session, and I will pass the microphone to my colleague and co-chair, Dr. Tiwari.
Thank you, Dr. Janak. The first, Dr. Krishna, you got your questions. Could you please briefly answer those? Your time starts.
Thank you, respected Chair. There were a lot of questions actually. Some of the questions I tried to answer over chat box also. Some I think it will be better to clarify over here. So regarding the lot of queries about possible third wave, that we are not sure. We might, once some of the current provisions of lockdowns being loosened over different countries, actually this decision will be taken by the local administration, taking over the risk mapping of that particular district. So the CDOs who are being the focal persons for implementation of these activities, each districts do decide based on their caseload, their transmission status and the number of active cases. So that provision is already there with the CDOs, but we are worried the cases might go up if the public health social measures are being loosened, and it's and every individual's responsibility to maintain public health and social measures. And there is some queries about third wave and children. So third wave and children, the ministry have clearly mentioned all the hospitals in terms of preparedness, because it seems that it's very unlikely that the children are going to get vaccine soon. Government of Nepal is trying to acquire vaccine from different sources. And as for the current global scenario also, we see that some of the countries only started vaccinating children 12 to 18 years only. So we, as of now, our under 19 population is total 8.8% of total infected are that age group, and our seroprevalence study is underway. So our preparation is needed for catering that age group, because the ventilators or the ICU beds and all the infrastructures and human resource for children are relatively different. They need different size and all. So government is trying to do in terms of human resource preparation, training, as well as the equipments, instruments, and bed provision for children. Let's hope for the best that there won't be any third wave and the children won't be affected. But we don't know this pandemic, and still many things are not unknown. And there are some questions regarding seroprevalence survey facilitation committees at the communities, which called Tol Sahajikaran Samiti in Nepali. So they will be the active persons from health to cater the health needs, and they can even look for the quarantine and isolation and public health social measures along with the team, and they will inform the system about this also. And something about mucormycosis, we have been getting around 24 cases being reported to us. Out of them, 16 received liposomal amphotericin B. There is a critical shortage of this medicine, liposomal amphotericin B, in our market, and government supply also, the stock is out. Actually, we don't have stock, and we are trying to get it from WHO, and the Department of Health Services also trying to procure. The procurement is challenging because India, the government of India have banned the export of this medicine, and when we try to get it from other countries, that is also expensive. So we are trying to get it in the meantime. We have got posaconazole available in the market, and that's being managed that way. Yeah, and regarding the learnings, we had a lot of challenges and learnings from each wave of COVID-19, be it point of entry, health desk, quarantine, isolation, or case management. So we are building on each of the learnings in earlier wave, and this time to get prepared, we are focusing not only on curative aspect of COVID-19 containment, we are trying to focus on the community level activities also. That's what I said about role of public health inspectors in each palika or in each municipality level. And I already shared the challenges we have been having, but there is a central coordination mechanism has been formed, and new modality of CCMC has been formed. We are hopeful that all the stakeholders, all 3 tiers of government, and whole of the society, whole of the government approach will apply with this new modality of CCMC, that's Central COVID Crisis Management Center, being headed by a totally independent person, not from Ministry of Health, not from any other ministry. So hopefully that will work out in improving the coordination, collaboration between all the relevant stakeholders. I think that's it. The major queries I try to answer, and still there are few I can be reached personally, and most of the queries which come to social media and all, we are trying to address those during press briefing, which we do twice weekly, and most of the commonly asked questions, frequently asked questions, are being answered in terms of infographics at MOHP COVID-19 fiber community, and more than 50,000 people are the current subscribers of that group, and even our Hamro Swasthya app that is available in iOS and Android. Thank you very much. Thank you.
Thank you, Dr. Krishna. And it's really important for us to learn through the questions, get the response. There is a saying in the science that when you want to go to the scientific innovations, sometime you may listen to ask the question, but most of the time you may need to listen to understand the question. I think that's the message from Krishna. Dr. Krishna. Now next, thank you, Dr. Krishna, for your answers. Now I would like to invite Dr. Dhimal for the responses. Please, your time starts.
Thank you so much, Chairs. There were some queries. Like first was the finding of the SMS measure and what will be the role of NHRC in implementation. As NHRC is a national ethical body for health research, our aim is to generate the evidence for the policy and planning. So NHRC more than 50 sample tested for the whole genome sequencing, sending the sample abroad as well as doing in country. And we are also doing in parallel for the research purpose. It is a collaboration between the Kathmandu University and Nepal Health Research Council. So in this way, we are collaborating and doing regularly for both surveillance and research. Next question is about second dose.
For the speakers who are on the floor first. So next is Dr. Pradeep Gewali. He has also received a lot of questions.
Thank you, Chair Sage. I have lots of questions to answer. I'll try to answer all the questions. First question was from Tula Ramji. Why we are not suggesting the MEC, Medical Education Commission, to implement the mandatory clinical research project on UG level across the country. So I want to give you a clear-cut message to you that for the undergraduate students, we have already started the undergraduate student clinical research training. So that is the training on good clinical practice. So we have already started GCP training through NHRC. So we had different trainings led by Institute of Biotechnology India. So we have meetings with the team of the Institute of Biotechnology, and they have trained to few of the NHRC staffs, and the training is continuously going on. And planning to just make consortium between Biotechnology of India and the NHRC, and then plan to give the such type of training for the further also. So we have allocated budget to our this fiscal year also. So we are planning to have a mandatory training for the reviewers and the other researchers from this year now onward. Okay. So that's how we plan for the trainings. And we had also the agreements between NHRC and ICMR, Indian Council of Medical Research. So one of the article of the agreement, working together to the EDCD also and NPHL also. And under the guideline of the ministry, we are conducting such type of genetic screening also. And seroprevalence study are being conducted. So one research is led by the EDCD, and NHRC also a part of that study, and one own study from Nepal Health Research Council. So that is the second wave of the COVID CAB study for the medical practitioners in the Kathmandu Valley also. So that's how we are planned. And another question is, do investigators need the trained to do non-clinical trials? From where we can get clinical trial training? So we are already having some non-clinical trial training from our NHRC platform. So regularly, so from our training part of the NHRC, so that is being conducted. So we are planning such type of trainings in an advanced level also. And for the clinical trial, so we have already signed MOUs to ICMR also. So one of the part of the ICMR agreement is the clinical trial also. So we had set meeting to the team of the ICMR for the further clinical trial training and other part of the research works also. And we have also the collaborative activities between the Oxford University and the Wellcome Trust Institute and Harvard Medical School also. So they want to support us for the such type of trainings, clinical research trainings also. And another question. So another question is there are many enthusiastic young students interested in research. Are there good platforms in Nepal for those students to pursue their career in research in Nepal? So definitely. So our capacity building section, Vijayji is already doing such type of great job. So you can contact Vijayji and our training section. You can have such type of platforms there. So, and the last question is, every year in the name of clinical trial, foreign institutions have been taking biological samples, microbiology, for molecular analysis, gene sequencing. What is the role of that NHRC is playing in context to control the outgoing samples and capacity building of human resources in the country? So I want to read few lines from NHRC Act. So you can see our act in www.lawcommission.gov.np also. So there are two articles, 11 number and 12 number. You can see in our website also. So number 11. So requirement of approval to do health-related research. So a person or organization who intends to do research works on the health after the commencement of the trial of this act has to obtain permission of the council. In giving approval pursuant to subsection 1, the council may specify terms as prescribed. The explanation for that is, for the purpose of this section, research means research along with experiment. So in our article, in the law of that section number 12, special powers of the council is written there. So the council may give necessary direction to the person or organization who is involved in research works on health as approved pursuant to section number 11. And if any person or organization does a research work without obtaining approval pursuant to section 11 or does not observe the direction given by the council is in doing research work after obtaining approval, the council may warn such person or organization or restrict such research work for a certain period of time. And in taking action pursuant to subsequent section 2, the council shall give proper opportunity to defend to the concerned person or organization. So that clearly mentioned that if any organization or anybody want to do research, so mandatory approval from the council is there. So I request all to read that things and do accordingly. Thank you very much.
Thank you, Dr. Pradeep, for taking your time and answering all those questions, that many questions within short time, and highlighting the trainings available at NHRC and also giving some highlights on the council's roles and its responsibility. So if there are more questions, they can contact the NHRC. I'm sure that audience have much more questions, the research community, who are excited to do more research, and hopefully this session, the summit, will encourage our future researchers, more future researchers. So we have a few questions for the speakers on the internet. So we have questions for Dr. Diptesh and Dr. Hanifa. First, I'll go with Dr. Diptesh. Unfortunately, Dr. Rustom is not available online, as he said in the beginning of his talk. So for Dr. Diptesh, there's only one question for you. Is there any additional advantage of remap over factorial design? Also, as you have mentioned regarding the sample sizes remap, how will you generalize the findings of remap? So the factorial design of remap and the generalizing the finding of remap. If you are available online, please, Dr. Diptesh. Yeah, please go ahead, Dr. Diptesh.
Yeah. So remap itself is a kind of a factorial design intervention, but there are certain advantages of it removes the like the hassle of waiting till the end of the trial and coming to a negative result sometimes. And the other advantage of remap is like there's a likelihood of patients or the participants being enrolled into a trial which have positive effect. So that's a adaptive response design where the likelihood of getting the positive outcomes is more, like compared to a negative trial. And the way the DREAMApp is designed, like there's a core protocol and there are different domains. So even if a certain domain gets paused or stopped, we can always add another domain to the core protocol, depending upon the problem that needs to be tested, and just carry on with the trial. So this is a very different kind of trial design and has lots of advantages over the
Nepal. Do you have any suggestions regarding the data?
Thank you very much for this question. I'm delighted to work with the researcher. So if they would like to get in touch, and if the registry is participating in the hospital they are based at, then delighted to work collaboratively to help the researcher. So please put them in touch. Delighted to contribute.
Okay, thank you. And for the person who asked the question, I think.
Thank you. Thank you again for this interest. The opportunity is open to everyone. So if people are interested and are seeking further opportunities, the NICRF network, which is happening with NHRC collaboration, is supported by us, and we work collaboratively with those colleagues. So if those people who are interested, if they would like to get in touch with Dr. Diptesh Aryal, or me, delighted to have conversations. I'll give two examples. We are working with two clinicians in Nepal to collaboratively develop their research question to be answered through the registry, which can
for everyone who's taking time and for running this session. And for rest of the questions, I'd request the...
Meanwhile, I'd like to request Professor Dr. Janak Koirala and Dr. Suresh Tiwari to hand over the token of love to our respected presenter. First of all, I'd like to request Dr. Krishna Prasad Paudel to receive it.
He's going with a lot of effort.
Thank you. Similarly, I like to request Dr. Meghnad Dhimal to receive the token of love. Similarly, I like to request Dr. Pardeep Gewali to receive the token of love.
Dr. Pardeep, Dr. Pardeep, photo on करें stick के परेगा. धीरे-धीरे बताइए सर. और मैं presentation कराई. जब सर देखें. जब सर को देखें नहीं. मैंने कैमरा में देख रहा था.
Thank you very much. Again, I like to request the chairman of NHRC, Professor Dr. Gainath Baral, to present token of love to our session chairs, Professor Dr. Janak Koirala. Thank you, sir. I like to request again Professor Dr. Gainath Baral to hand over the token of love to Dr. Suresh Tiwari. Thanks again to all of you, and hope you meet in the next session. And I like to request all the presenter, chairman, and the chairman of NHRC for group photo.
जुन लिङ्क पठाइसक्यो नि भयो सुरु भयो
So, welcome back. We are ready to begin our next session. Namaste and a very good afternoon to you all. Distinguished guests, respected international speakers, national scientists and participants, virtually connected audience and my dear colleagues. It gives me an immense pleasure to welcome you all in this most awaited glorious event and an important session entitled Research Studies on COVID-19 and Health Emergencies, which is one of the major attractions of this summit. Myself, Dr. Suman Pant, affiliated to Nepal Health Research Council in the capacity of research officer, will be the host for this symposium. We have a group of intriguing presentations from eminent worldwide scientist, Professor Dr. Peter Harvey, profound national health research expert, Dr. Sampurna Kakchapati, and outstanding researchers from the country. Now, with this a huge round of applause, it's my privilege to welcome respected Dr. Mahesh Kumar Maske and Dr. Khem Bahadur Karki to join us virtually to chair this session. To introduce with Dr. Mahesh Kumar Maske is a prominent public health expert. His areas of focus and aptitude include perinatal epidemiology, health policy and planning, health system research, and the generation of evidence for health policy formulation on a national and international level. He was a member of Advisory Council for Health Research of World Health Organization Southeast Asia. Between 2006 and 2009, he was the executive chair to the Nepal Health Research Council. Additionally, he has remarkably contributed to design targeted free health services in the district hospitals and primary health care centers and universal free health care services in sub-health post and health post level in Nepal. He has served as ambassador of Nepal to People's Republic of China 2012 and 2016. He is a published author and has presented papers in significant numbers of regional and international conferences. He had been a teaching assistant in epidemiology and biostatistics, Boston University Literature. He worked as executive member secretary for Nepal Health Research Council from 2014 to 2018. He also worked as executive director for a national NGO, namely Society for Local Integrated Development, for over 18 years till date. He was a key person for developing National Health Policy 2014, National Strategy and Custard Action Plan for Ending Child Marriage 2015, ASRS Implementation Guide, and so many other policy documents. He is a national trainer and expert on adolescent sexual and reproductive health and rights, including comprehensive sexuality education. He has an extensive involvement in health-related research projects and has published more than 3 dozens of peer-reviewed papers in different international index journals. With this, I request respected chairs to grant us the permission to start with the presentations. Thank you very much. On to you, chairs.
Thank you very much, Dr. Suman, for this wonderful introduction. And I welcome all the participants and panelists and speakers to this afternoon session. The subject, the theme is very, very important and pertinent for Nepal, the research studies on COVID-19 and health emergencies. We have gone through a very difficult period of COVID pandemic last year, and we have faced first and second wave of COVID pandemic, and many kind of researches within Nepal has also been undertaken. And we are seeing a lot of presentation there, about 8 presentations, different facets of COVID pandemic and health emergencies. And we have very distinguished speakers also. Therefore, because we have time, I think we should go with the first speaker. And I don't know whether my co-chair is present or not right now, because he had some emergency and he may not be joining us.
He is with us now, sir.
He is with us?
Yes, sir.
Okay. So, Dr. Kim, I mean, you can be with us as long as you can be. And thank you for being with us. And when you leave, take...
sorry for all these, participants of this session that I can't continue to stay for a longer time because one of my relatives is critically ill and needs support, and I have to rush for that support. That's how I couldn't stay for this work session. So my teacher and prominent public health expert in Nepal, Dr. Maske, is with us. That's how maybe there is no any kind of hassle or problems. So I would like to request a moderator.
Respected chair. So considering the time constraints, so first we'll be going through Sir Peter Harvey because he has allocated first time to us and he's presenting from the UK. So we'd like to apologize to Dr. Sampurna. We'll be presenting yours after Sir Peter Harvey. So to introduce with Sir Peter Harvey is the Professor of Emerging Infectious Diseases. Dr. Peter has led clinical and epidemiological research on a range of emerging infections for almost 2 decades. He is a director of the Pandemic Sciences Center at the University of Oxford and the executive director of the International Severe Acute Respiratory and Emerging Infections Consortium. He is a member of government's Scientific Advisory Group for Emergencies and chair of the New and Emergency Respiratory Virus Threats Advisory Group. He is a co-lead of the UK randomized evaluation of COVID-19 therapy, COVID recovery trial, the world's biggest randomized control trial of COVID-19 treatments. So on to you, Sir Peter Harvey.
Great, thank you very much. Can I just check that you can hear me and see my slide?
Yes, sir. Yes, sir.
Yes, we can see your slides.
Thank you very much. I'm very sorry, but my video on my computer has broken, so you can't see me, but I can see you, so I apologize for that. And thank you very much for the honor of speaking at your summit. I'm going to talk briefly about the importance of clinical trials in a pandemic. If we go back in time for a call for global action as the outbreak spreads, I'm taking you even further back in time than you might think. I'm taking you back to the 2009 influenza pandemic, which was a pandemic that we were expecting at some point and arrived in 2009. And I want to show you the clinical research response to that pandemic. This was an analysis done by one of my PhD students of the number of patients that were anticipated to be enrolled in clinical trials, randomized clinical trials. So if you look on the clinical trials databases, almost 6,000 patients were anticipated to be enrolled in clinical trials. And the next bar shows you the numbers that were actually enrolled, so far, far fewer, so just over 1,000 patients enrolled. And many of those trials did not complete because they were too small. So the number of patients who were enrolled and the results were published is the third bar, is less than 200 patients. And none of those results were published during the pandemic. So if we talk about epidemic curves, I'd like to talk about the epidemic curve of ambition. There are many, many ideas, but they don't translate into very good protocols, and they enroll very few patients, and they result in no evidence. So we came out of the 2009 pandemic with no new treatments for influenza and no advances in care. So our aim has been to change that curve. So let's be a little bit ambitious about finishing some protocols and getting some evidence, but perhaps a bit less ambitious about the breadth of ideas. We need a smaller number of studies that do complete. So now I'll take you back to this pandemic at the start of last year. And we were in a situation where we knew we would have unprecedented clinical challenge, overstretched health services, huge time pressures, many unwell patients. We also knew that we didn't have many good therapeutic options. There was many candidates, many opinions, most of them not evidence-based, with some uncontrolled case series, inconclusive small randomized trials. So a lot of therapeutic uncertainty. So there was a lot to be done. And this just shows you the epidemic curve in Wuhan, where 2 trials were started, a trial of lopinavir-ritonavir in red and a trial of remdesivir in green as the outbreak increased. But this is what, so 20 days it took us to enroll the first patient in Wuhan. But this is what happened to the epidemic curve in Wuhan. So actually, we missed the bulk of patients. So the trials were too small to give a conclusive answer. So although we started quickly, it was not quick enough. So the recovery trial, the principles were we had to be very quick. So we didn't miss the epidemic curve. It must be big, unlikely to be big single wins. Many trials are powered on an unrealistic expectation of something like a 40 or 50% reduction in mortality. That just is not realistic for drugs. Most drugs have modest benefits. And so you have to power your trial for modest benefits. And it must be simple, because the healthcare staff would be under extreme pressures. And if the trial was complicated, healthcare staff would not enroll patients. So collecting only essential data and unbiased outcomes. So the design of the recovery trial, we made it simple. Randomized controlled trials do not have to be complicated. We had very simple eligibility criteria, hospitalized with suspected SARS, a simple, important, unbiased outcome, mortality, web-based randomization, and a very simple follow-up page, one-page follow-up form with extensive linkage to routine data like mortality data. So if you keep it simple, the chances of success are multiplied manyfold. And so the implementation, just to show you how it worked, we had our first protocol submitted on 13th of March, and just 6 days later, on the 19th of March, we enrolled the first patient. So because the protocol is very simple, it makes the regulatory and ethics approval much easier. And then subsequent amendments were also very quick. So adding drugs just took a few days, and adding children to the protocol just took less than 2 weeks. And this shows you the first epidemic wave in the United Kingdom. And we got the green light from the Ministry of Health to proceed with the trial. And just 9 days later, we enrolled the first patient. The beauty of a simple protocol. And we caught the upswing of the epidemic curve. So in 2 weeks, we had 1,000 patients. In a month, we had 5,000 patients. And in 2 months, we had 10,000 patients. So a big trial that's able to give definitive answers. And this shows you the recruitment in the UK over the last 18 months. And you can see that at the peak of the first wave, we were enrolling 400 patients per day. And at the peak of the second wave, over 500 patients per day. And you can see on the right the number of hospitals involved, over 180 hospitals in the UK. And I'm delighted to say, if you look at the top tab there, we have global GBR, IDN, NPL. NPL is Nepal, and it's a great pleasure that we're now enrolling in Nepal under the leadership of the NHRC and Professor Basnet. And just to show you how simple it is, the system collects data on how long it takes from first opening the web browser to enter a patient's details to getting an answer as to what drug the patient should be randomized to. This shows you the time to randomization, and you'll see on the right that the mean time to randomization is just 8 minutes. So it really is very simple and very easy for the healthcare staff. And so the results so far, because we've been big and simple, we've given some very definitive answers. These are some drugs that we thought might work and were widely used, but we've shown in hospitalized patients no benefit. Hydroxychloroquine, azithromycin, lopinavir, ritonavir, colchicine. These are mortality curves, 28-day mortality curves. And you can see in none of those curves is the red line lower than the black line. And then some that were widely not recommended and we've shown have benefits. So here, corticosteroids, where in those patients on invasive mechanical ventilation on the left or oxygen in the center, giving dexamethasone improves survival. And this has changed treatment practices worldwide. And then tocilizumab, the interleukin-6 inhibitor, again, there was substantial uncertainty as to whether it worked or not. And with a large trial here, 2,000 patients on treatment, 2,000 controls, we showed tocilizumab improved survival on the left there. And that has changed policy. Unfortunately, convalescent plasma, we did not see an overall benefit in mortality. And this is with a very large sample size here. We enrolled almost 5,800 patients on treatment versus a similar number of controls, showing you the importance of large sample sizes. Large sample sizes also allow you to do subgroup analyses, which is also important. And then very recently, we had a result on a monoclonal antibody with almost 5,000 patients on treatment versus 5,000 controls. This time stratified into subgroups by those who are antibody negative at enrollment, the seronegatives on the left versus the seropositives. And you can see in the top two lines, if you don't have antibodies when you get to hospital, giving artificial antibodies at high concentration through a monoclonal improves your survival by about 20%. So again, the importance of a big sample size has allowed us to give a good answer in subgroups. So this is where we're at in the trial. 11 different treatments. We've shown 6 in hospitalized patients to not have a mortality benefit. We've shown 3 do have a mortality benefit, dexamethasone, tocilizumab, and an antibody cocktail. And we are still enrolling to baricitinib, dimethyl fumarate, high-dose steroids, and we will be adding new drugs, particularly now that we are working with international partners. So what's the legacy? I think the legacy is that we don't want trials to be some very highly specialized area. They have to be embedded in routine care, and research should be seen as a routine part of improving patients' clinical care. If you don't know with certainty that a drug works or not, then we should randomize, and that should become a routine part with simple trials. And here you can see an admission board for a intensive care unit in the United Kingdom, where alongside the diagnosis, they've put a new column about which trial the patient is in. So most of the patients are in a trial, and I think that's the way we will improve care quickly. So just a big thank you to everyone involved, particular thanks to all of the healthcare staff who are working on this trial throughout the world, and particularly to all the patients who have agreed to participate in the study. Thank you very much, and thank you for your attention.
Thank you very much, Sir Peter.
So we have 5 minutes more time with Professor Peter Harvey to raise our questions and get along with. And then we'll have the next speaker, sir.
So any of you want to ask any burning questions, you are welcome, So within this time period, he may quickly respond to your question. Well, if nobody has a question, I just want to ask Sir Peter, that you were doing this clinical trial for dexamethasone in early stage from in UK. What about remdesivir? I didn't see it in your chart. So you were not interested in that, or I just missed it?
No, you're right, Professor Maskey. We did wish to evaluate remdesivir, but we could not access the drug. The drug company declined to provide drug for the trial.
Oh, okay, all right. All right, and what is your opinion about the controversy that WHO clinical trial didn't so much effect about remdesivir, but still it's widely used in practice, including in Nepal?
Yeah, I believe we're awaiting additional results from the WHO trial, and also there is a French randomized controlled trial, I think with placebo for remdesivir. I think, to be honest, I think that the efficacy is still unclear, because the US trial was not that big. It did not show a mortality benefit. If they had enrolled maybe 3-4 times as many patients, I think the answer would be much clearer. And I think it's a good lesson there. Many of the trials, even the US NIH trials, have been too small. The US NIH trials of...
Would you be interested in...
I'm sorry, Professor, I can't hear you.
So now the budesonide has been. If there is any question, okay, there's something question about funding and quick response. Can you see the question?
Yes.
It says, can you please let us know how you are able to gain funding to do this work? Okay.
Yeah, very good
Any
question.
take on that?
Yes. We had the funding came from the Wellcome Trust, who were reasonably quick in turning around funding, but not fast enough. We actually had to initially fund the trial from university assets until the money came through. I do think that the funders need to be even quicker and probably have funds, emergency funds available, which they can mobilize immediately.
Thank you very much. Now, Dr. Suman,
yes,
you go for
thank
next speaker.
Yeah, thank you very much, Professor Harvey, for giving us a very impactful presentation and giving us the added value to our summit. And thank you very much for highlighting the trends of the clinical trials over the years and in relation to the epidemic curve and curtailing towards it. The principle of recovery trial is so great that it's pragmatic and it's practical, it's easy, and it's embedded in the regular care by the physicians. We are really privileged to be the part of such a great trial, and maybe it's a game-changing, yeah, and it's a game changer for the discovery of therapeutics to treat the COVID-19 patients, and particularly it's more important in the amidst of this pandemic as we are reeling through, and answering the simple questions whether this drug works or not. And thank you very much, Professor Maske, for thanking our respected Harvey for his presentations. So with its continuity.
Suman, let me just my one request. We have very limited time.
So, yes, sir. So we are reeling to the next presenter, Dr. Sampurna Kaksapati.
Sampurna, the floor is yours.
Working as a research manager in Heart International. My academic background is PhD in research methodology, and I have more than 10 years experience working in research and public health in Nepal and abroad. I am very grateful and thankful to NSRC for providing me the platform to share the further analysis of COVID-19 data in Nepal. So I'll again like to welcome to everybody to my presentation. So let me start my presentation with a topic entitled Spatial and Temporal Pattern of COVID-19 in Nepal. This is the outline of my presentation. I'll talking about introduction and rationale of the study, objective of the study, the method, the static analysis part, result along with discussion and conclusion. So, COVID pandemic is currently affecting the large population, has become a public health issue and public health emergency, and it has made a huge impact in every region of the world, including Nepal, which high number of mortality and morbidity. So the public health officer generally need to evaluate the impact of COVID-19 in area, time frame, and risk groups, so that public health action can be taken place. So basically, this is the method of my analysis. The research method was secondary data analysis. The data source was daily COVID cases by age, gender, and district were compiled from Ministry of Health and Population Portal System website. This is the website where I extracted the data. The data of daily COVID cases are collected through uniform platform across the country through integrated HMIS. In fact, the COVID hospital and public health laboratory and the Ministry of Social Development, all they share their COVID data to MOSP through the IHMIS platform. However, the population for gender, age, and district were compiled from the Central Bureau of Statistics. So for data management analysis, I just compiled the COVID cases data and published data from different sources and make one source in CSV file for the further analysis. This is the diagram of the study, with the variable which I use for the analysis. The variable were gender, age, group, month, province. Gender were classified into 2, male and female. The age group were classified into 3, like below 21 years, 21 to 60 years, above 60 years. So month, there was 11 month used for 2020 because February have no data of COVID-19, so it was excluded. And there were 5 months for 2021 from January to May. The province were 7 provinces as usual, the much COVID cases. So this is statistical model, static analysis part. Since the outcome was continuous numerical, the multiple linear regression was used to investigate the COVID-19 by determinant. The model is expressed as the following. So multi-continuous was also checked whether there was correlation between independent variable, and the study found there was no correlation between the independent variable. And the sum constant was also used to obtain the confidence interval by comparing the access proportion with overall proportion. For statistical analysis, our program was used for statistical analysis and graph. Now I'll move to the result section. So this is the result of bottle fitting showing the proportion of COVID-19 and 95% confidence interval by gender, age, and province. So during the analysis, I combined gender and age into 6 categories. For example, first category was male below 21 years. Second category was male 21 to 60 years. Third category was male above 60 years. Fourth category was female below 21 years, female 21 to 60 years, and female above 60 years. Similarly, the month was also classified into quarters. Like 3 months was 1 quarter. So the first quarter was January to March 2020. The second quarter was April to June 2020. The third quarter was July to September 2020. Fourth quarter was October to December 2020. The fifth quarter was January to March 2021. And the sixth quarter was from April to May 2021. And the province were 7 provinces as usual. The red horizontal line is mean proportion of COVID-19 per 10,000 population. So in my study, it was found that the mean proportion of COVID-19 was 12.1 cases per 10,000 population. So if we see that high proportion of COVID-19 was male 21 to 16 years, followed by the male above 60 years. And the low proportion was of COVID was seen in the male and female below 21 years, lower age group. Similarly, if you see the quarter, the high proportion of COVID cases was seen the last quarter in April to May. In regard to province, the high proportion of COVID was seen in Bagmati province, followed by Gandaki and Lumbini province, and the low province of COVID-19 was seen in province 1 and province 2. So this is the monthly trend of COVID-19. So the trend of COVID-19 increased from May to June, followed by drop in July, again increase in August, followed by drop in March, and from March it increased rapidly to May. If you compare the monthly trend with event happening in the country, it was found that during first lockdown also there was trend in increase in COVID-19. And during second lockdown was also there was increase in proportion of COVID-19. However, the increase in proportion of COVID-19 during May and April was due to the second wave of COVID-19 that was seen in Nepal. And this is the example of third lockdown. And I also like to inform that high proportion of COVID cases in the month of October was due to the national festival, where there was the government also the free the government also the transportation of the public and private vehicle, and it may cause the high number of cases in the October. So now this is the monthly trend of COVID-19 by gender. The black color shows the overall trend of COVID-19. The blue color shows the trend of COVID-19 for male, and the red color shows the trend of COVID-19 for female. So the analysis found that the high proportion of COVID-19, so the analysis found that the trend of COVID-19 was higher compared to the overall trend and compared to the overall trend of female. But in some months, the proportion of COVID-19 was similar for both male and female. This is also the monthly trend of COVID-19 by age. The black color is overall trend. The green color is trend of COVID-19 for age 21 years and below. And the orange color is the trend of COVID-19 by 21 to 60 years. And the blue color is showing the trend of COVID-19 above 60 years. So in this analysis, it was also found that the trend of COVID-19 was higher for the age group 21 to 60 years, followed by the trend of COVID above 60 years. But in some months, the proportion of COVID-19 for 21 to 60 years and above 60 years was nearly similar. And the study also found that the trend of COVID-19 for the age group below 21 years was low across all the months compared to other age group. Now I would like to move to the graph which show the proportion of COVID-19 by district. In the graph, the horizontal dotted line is mean proportion of COVID-19 per 10,000 population. So it was found that about 17 districts have higher proportion of COVID-19 compared to the mean proportion of COVID-19. Similarly, 49 districts has lower proportion of COVID-19 compared to the mean proportion of COVID-19, and the remaining 11 districts has similar proportion of COVID-19 compared to the mean proportion of COVID-19. And we've seen that the proportion and confidence interval are touching the mean horizontal line. So we can conclude that 17 districts have higher proportion of COVID-19, 49 districts have lower proportion of COVID-19, and 11 districts has overall similar proportion of COVID-19. So regarding the district and province, it was found that high proportion of COVID-19 was seen in Bagmati province. Around 7 districts of Bagmati province have high proportion of COVID-19, whereas 4 districts of Lumpini province have high proportion of COVID-19. 2 districts of province 1 and Sudur Pachim province have high proportion of COVID-19, whereas 1 district of Karnali and 1 district of Gandaki have high proportion of COVID-19. But none of the district of province number 2 have high proportion of COVID-19. So based on this classification, where the categorized was based on high proportion, average proportion, and low proportion of COVID-19, the map of Nepal was plotted. This is the plot of map of Nepal showing the district with proportion of COVID-19. There are three different colors. The yellow color is low proportion of COVID-19. The orange color is average proportion of COVID-19, and the red color is high proportion of COVID-19. So it was found that the high proportion of COVID-19 was found in the metropolitan city. For example, Kathmandu, Kaski, Chittagong. So many studies found that the city we have high number of urban density can cause to the overcrowding and can cause to the higher mobility. So that may be reason for the increased number of cases in this district. Similarly, high proportion of COVID-19 was also found to the district which was bordered to the India. For example, Pake, Dang, Kailali, Sunsari, Morang, they are bordered to the India, and they have also the high proportion of COVID-19. The reason may be due to the second wave of COVID-19 that was appeared in India, and that may cause the high proportion of COVID-19 in the border region. So now I would like to move to the end of my presentation. So the study show the increasing trend and explain the special variants of COVID-19. And as you know, that danger and age group difference existing in COVID-19, and now the COVID-19 is increasing in urban city and Tarai region. And the finding is also shown in maps showing the high and low risks of COVID-19. So these maps can be used by public health officers to design the public intervention. So I also recommend to do the further analysis for the to proportion of COVID-19 at sub-national level, like province and district level, so that the province and district level also can also design their program. And also recommended to do the further analysis for the mortality of COVID-19 by special entrant and the social determinants. So thank you so much for NSRC for providing me the opportunity and platform to share the further analysis of COVID-19. So if there is any question, then if there is a question, you can just ask me. Thank you so much.
Okay, Dr. Suman. Can't hear.
Thank you, Dr. Sampurna, for a very interesting presentation on COVID-19. So we are already late with few times, so we'll come back to you with questions and queries from our audiences later. So moving ahead, I'd like to invite Nishant Katwalji for presenting his research entitled Evaluation of On-Site Training Focused on Molecular Methods of COVID-19 Testing in Karnali Province of Nepal. The floor is yours.
Good afternoon, everybody. I'm Nishant Kotwal from Dhulikhel Hospital. I'm presenting on the topic evaluation of on-site training focused on molecular methods of COVID-19 testing in Karnali Province of Nepal. First of all, I would like to thank Nepal Health Research Council for conducting this summit conference where we can present our work. Moving on into the presentation, first I would like to state the background of our study. So as we know, molecular methods are really crucial for diagnosis of any infectious disease that is of public health importance. However, the sophisticated tools and techniques and knowledge that are required for such molecular methods are limited to major areas in Nepal. For instance, out of 85 authorized COVID-19 testing laboratories, only 4 are situated in Karnali province. And proper detection and management of COVID-19 pandemic is actually hindered by this lack of specialized knowledge on molecular methods. Standard operating procedure that has not been standardized in everywhere. Poor quality control measures that would actually cause confusion on false positive, false negative results. Therefore, to eliminate such hurdles, appropriate measures are essential, which actually focuses on intensive hands-on training on site, specialized theoretical networks on molecular methods. For instance, why every step of the extraction is important, or why every step of PCR, master mix preparation, template addition is important, as well as training on the quality control measures to differentiate and to identify any false positive or false negative results that may appear. So our objective was first to provide an intensive training on the theoretical and practical aspects of the molecular detection of COVID-19. After that, we wanted to assess the efficacy of this on-site training, whether it changed the understanding of real-time PCR testing of COVID-19. That included from everything from sample collection to the reporting. So the methodology we opted was, first what we did was we created a course that included 4 modules, and this course was approved by Ministry of Social Development at Karnali Province. This particular course had 4 modules. The first module contained sample collection and transfer. For instance, what are the different ways of collecting samples, what are different samples that could be collected, how properly should the samples be transported, for instance, maintaining cold chain. After that, the module 2 content, what are the different biohazards during the COVID-19 testing, and how to effectively manage them, and how to ensure biosafety measures. The third module was about nucleic acid extraction, how to, what are the different steps in extracting nucleic acid from any sample, focusing on extraction of RNA from COVID-19 swab samples. The last module included information, theory, as well as practical aspects of PCR, as well as appropriate reporting format. This training was focused for Surkhet district and Surkhet PCR lab. So we had 36 trainees, out of whom 8 were lab technician, 4 were lab technologists, 2 were medical microbiologists, and 22 were lab assistants. So the training methodologies that we used was, there were intensive lectures and discussion sessions for each of those modules. After that, there was laboratory on-site training for extraction for PCR and demonstration for sample collection and biosafety and biohazard management. And before every module, we had pre-test, and after every module, there was post-test for evaluation. We also had observational analysis to see how effective the lab is running currently. So the way of our evaluation was creating a pre-post intervention study to determine the efficacy of the training program. So the basic observation or impressions that we had during the training was, currently there was lack of in-depth understanding of nucleic acid extraction and PCR techniques. There wasn't a clear understanding of what the different steps in extraction and PCR actually meant for the result, as well as there was lack of a standard operating procedure to how to effectively manage biohazard waste and create an environment that ensures biosafety measures. And there was lack of standard operating procedure for appropriate reporting and storage of the data. So the results are, out of the total participants, 58.3% were female participants, which was really encouraging to see. So our pre and post test was of total 58 points, out of which we can see that the pre-test score, mean pre-test score was 21.2, and the mean post-test score was 32.3. So we can see after the training session, which included the lectures, the discussion, demonstration, and lab on-site training, the score of the participant had increased by 11.1, so which was really encouraging for us. You can see the same results in pictorial diagram, for instance, the gender distribution of the participants and the test score in bar diagram. So concluding, after the training session, we found that there was increment in theoretical as well as practical knowledge on the molecular methods of COVID-19 diagnosis, which was focused on nucleic acid extraction methods as well as the PCR methods, how to effectively manage biosafety and biohazard, how to create a proper record keeping, and how to report properly in a standard manner. So we can conclude that such in-person theoretical session, practical demonstration, and hands-on lab training are really effective to increase the knowledge on the molecular methods of COVID-19 testing. However, what we do recommend is in current COVID-19 pandemic, where there is social distancing restrictions and travel restriction as well, online training could be an alternative. For instance, we could create an online platform, for instance, in cameras, which is really user-friendly. We can have theoretical sessions there, for instance, recorded lectures, presentations, other extra reading materials. We could also have discussion forums there, where the participants or trainees can post their queries and the instructor can solve them. We can also have quizzes for evaluation, as well as different methods of evaluation that we desire. For instance, any subjective questions or for that matter. So this slide actually contains the team members that were the core part of this particular training, as well as for the analysis of this study. So, which includes myself, Mr. Navin Adhikari, Tech Bahadur Thapa from Dhulikhel Hospital, as well as Dr. Birajman Karmacharya, Dr. Rajiv Srestha, and Dr. Archana Srestha, who are the co-investigator and investigators of this particular project. I would also like to acknowledge Mr. Bikram Adhikari and Ms. Lisa Saporel, who are part of Department of Community Programs at Dhulikhel Hospital, for helping with the training as well as helping analyzing this data. I would like to especially thank Mr. Surendra Kumar Madhav, who is in charge of the microbiology lab at Dhulikhel Hospital, for being part of this training as a trainer. We would also like to thank Ministry of Social Development and Public Health Director at Karnali Province, SSBS, for providing the technical support, as well as all the participants from the Surkhet district came to our training program. This particular slide contains a screenshot of the quizzes that we made. So module 1 actually contained 13 different questions. Module 2, 3, and 4 actually contain 15 different questions each. Moving on to the next slides, actually this slide would contain the images from the training program that we conducted in Surkhet, which was held from 21st of February to 24th of February. You can see the training session being held, the pre-test and post-test examinations being done for each module. The on-site lab training focusing on how to properly aliquot the samples. After that, on-site training on nucleic acid extraction to the participants. Demonstration of biosafety measures. Demonstration and training on how to properly collect the swab samples. Training and demonstration on how to properly wear and doff the PPE, which is really important aspect for personal safety. At the end of the training, we also provided certificates to the participant, which, as you can see in the picture, is being distributed by Dr. Robin Kharka, the Public Health Director at Surkhet in Karnali Province. Thank you for your attention. I know you do have questions related to this particular presentation, which I'm very eager to answer. Thank you so much.
Thank you, Nishant sir, for bringing in very important information. Please stay with us. So moving forward, I'd like to invite Kritika Dixitji to present her topic entitled Barriers and Facilitators to Accessing and Delivering Tuberculosis Services During the COVID-19 Pandemic in Nepal, Experience of Patients and Healthcare Providers. The floor is yours. Thank you.
Research findings on barriers and facilitators to accessing and delivering TB care. TB was the leading cause of death from a single infectious disease until the COVID-19 pandemic in 2020. This pandemic has disproportionately affected the low and middle income countries like Nepal to access the TB services. A modeling study reported that the progress towards the elimination is expected to be rolled back by at least a decade because of this pandemic. And we also have experienced a similar disruption to TB care in the past in the mega earthquake 2015 in Nepal. Therefore, it is very important to understand the effect of these pandemics or emergency situations to repair the damage and rebuild a more resilient TB services for the future. You are also aware of the fact that Nepal has a huge burden of tuberculosis. Like you see in this picture, majority of the people are not able to be diagnosed of the tuberculosis. And even if they are diagnosed, the pathway from diagnosis to treatment is not easy. Many people are unable to complete the treatment because it is difficult for the patients to access the TB treatment. And I will be explaining about these barriers to the TB treatment in my next slides. So this figure is from our previous studies, which we conducted just before the pandemic. And this figure illustrates the barriers and facilitators to TB care in Nepal. So as you can see here, the white areas of this circle, it shows that the burden of tuberculosis is multifaceted. And there are barriers related to accessing the TB, such as inadequate knowledge of tuberculosis, or stigma and anxiety related to the disease, food insecurity or financial burden posed by the disease. And nevertheless, there are geographical difficulties to access the health centers to receive that treatment. Therefore, in our study, we are interested to dig deeper into these barriers in the light of COVID-19 pandemic, and we aim to explore these barriers and facilitators to access the TB care or to deliver the TB care from the patients and from the providers' perspectives. From these results, We aim to collect them and develop a list of recommendations for future emergency preparedness. We conducted these studies in 9 districts of Nepal. These districts were purposely selected where BNMT, a national organizations working in TB program, were actively actively implementing the TB programs in these areas. I would also like to inform you that this is an ongoing study. We employed qualitative methods using longitudinal study design. The data were collected from January to February 2021 using face-to-face in-depth interviews and key informant interviews with 33 study participants, which included people with TB and TB care providers. All these interviews were either conducted at the patient's home or at the health centers, whichever was feasible for the participants. We also took consent to receive, to put the face mask or to conduct the interviews in open areas. Written informed consent were taken from all the participants. From the study findings, we developed the codes, themes, and sub-themes, and we employed thematic analysis using NVivo 12 software. We also received ethical approval from Nepal Health Research Council. So now let me share the results with you. I have here quoted a statement from a patient who shared that she chose a different pathway to access the TB treatment and receive her medicines during the pandemic. She shared that she used to walk every day on foot for 5 hours just to receive her medicines, which she had to take daily. And she was afraid that her neighbors would find out about her disease because she was walking during the lockdown period. And this disease was the disease that was looked down upon in her community. And she was very anxious that anybody would find out disease. Therefore, she chose an alternative pathway. She chose the route of the jungle and walked for 5 hours on foot rather than 1 hour on foot to receive the health centers. Therefore, this shows that the pandemic has amplified the difficulty to access the treatment, has increased the stigma and mental anguish among the patients. Like her, other patients also shared various barriers which we have listed on our left-hand side. The country, as a response to halt the transmission, posed the travel restrictions or lockdown during this period. As a result, patients had to walk for several hours on foot, and which was a key barrier for the patients. They also reported that because of the pandemic, they had to lose their job, and as a result, their financial burden increased also within the families. As a consequence, the whole family, they had to reduce the food frequency. They also shared that they feared the contracting the COVID-19, and also they had the TB-related stigma. As a result, they were reluctant to visit the health facilities. Instead, they chose over-the-counter drugs from the pharmacies to heal their symptoms temporarily. But this was a key barrier to diagnose, and which was a national problem of Nepal. On the other hand side, the providers, despite their willingness to treat their patients, they were unable to do so because they were diverted to a response of the COVID-19 pandemic. They also shared that during the initial period of the pandemic, they had inadequate knowledge to differentiate between the COVID and the tuberculosis disease, because both of the diseases, they presented the similar symptoms such as cough, fever. And any patients who presented the symptoms of fever or cough, they were only tested for the COVID-19. Therefore, many of the patients could be underdiagnosed or they could be mistreated. Now, we also explored into deeper how can these barriers could be addressed. And I would like to quote here a statement from the female community health volunteers. She mentioned that people with TB, they require more cash and food support during this pandemic to cope with the medicines and the treatment. She also shared that if the providers are given the personal protective equipment such as masks, gloves, and sanitizers, they could go to the community and they could find the people with the symptoms of TB and screen them, which is more a patient-centric care. And reiterating what she had just said, many of the patients also mentioned the need of nutritional support and financial support. They also mentioned that they also require counseling on the treatment adherence. Providers also stress the need of the patient-centric care during these pandemics. For example, they could go to the community and conduct the sputum courier services or the screening services, or even deliver the medicines to the people home. So this could reduce the access barriers for the people. And our findings is similar to what the other global studies have also found out that, and this reiterate that the impact of the COVID-19 pandemic has impacted on the access to and delivery of the TB services across the world. Now, before I conclude, I would like to reiterate a key question here. How can we make TB services more accessible? Our studies and global studies have shown the importance of female community volunteers or the healthcare providers to go to the communities, screen and find out the patients in the community, which is a patient-centric approach. In addition to this, we also require more comprehensive programs, such as social protection programs like financial support, nutritional support, integrated psychosocial counseling, or even prompt training on disease management when we have similar pandemics. Now, at last, I would like to acknowledge with thanks the patients, families, and healthcare providers, Impact TB team, National Tuberculosis Control Center, Royal Society of Tropical Medicine and Hygiene, and Fire Foundation for this financial support. Thank you.
So thank you, Kritika ji. So continuing to the session, now I'd like to invite Sawan Kumar Yadav ji to present his presentation in the topic Understanding the Knowledge and Compliance of SMS, Social Distancing, Use of Masks and Use of Sanitizer or SOP, Measures Against COVID-19 among Nepalese of Province number 2. The floor is yours. Thank you.
नमस्ते सबैजनामा म चाहिँ सावन कुमार यादव प्रोभिन्स 2 बाट हाम्रो चाहिँ स्टडीको टाइटल रहेछ अन्डरस्ट्यान्डिङ एन्ड कम्प्लेन्स अफ एसएमएस सोशल डिस्टेन्सिङ युज अफ मास्क एन्ड युज अफ सेनिटाइजर और सप मेजर अगेन्स्ट कोभिड-19 प्रोभिन्स नम्बर 2 हाम्रो चाहिँ अथर हामी चाहिँ 4 जना रहेको थियो मिस्टर फुलियन शाह सावन कुमार यादव अशोक कुमार मण्डल अनि डाक्टर सञ्जीव कुमार यसको चाहिँ ब्याकग्राउन्ड यस्तो रहेछ हाम्रो चाहिँ पब्लिक हेल्थको चाइलेन्ज अनि त्यसपछि यसमा भएको स्टडीहरू चाहिँ ब्याकग्राउन्डहरू अनि अहिले चाहिँ जुन पेन्डेमिक चलिरहेछ त्यस अनुसार चाहिँ युनिसेफले चाहिँ वर्ल्ड वाइड 3 बिलियन पिपल लाइक एन्ड एज इट फेसिलिटेटेड एट होम एन्ड 2 आउट अफ 5 हेल्थ केयर फेसिलिटी लाइक जसमा हामी चाहिँ यो मेन स्टडीको चाहिँ हाम्रो मेन फोकस के रहेछ भने कम्प्लेन्स एन्ड प्र्याक्टिस अनि नलेज चाहिँ कोभिड-19 सम्बन्धित जुन हेल्थ गाइडलाइन छ त्यसको हामी चाहिँ एसेस र त्यसको फाइन्ड आउट गर्नु बारेमा हो हाम्रो चाहिँ अब्जेक्टिभ रहेछ चाहिँ टु फाइन्ड आउट द अन्डरस्ट्यान्डिङ एन्ड कम्प्लेन्स अफ एसएमएस मेजर्स एगेन्स्ट कोभिड-19 इन प्रोभिन्स नम्बर 2 हाम्रो चाहिँ स्पेसिफिक अब्जेक्टिभ रहेछ टु एनालाइज द नलेज प्र्याक्टिस एन्ड कम्प्लेन्स अफ एसएमएस डिस्टेन्सिङ मास्क एन्ड सेनिटाइजर एट इन्डिभिजुअल लेभल अर्को चाहिँ टु कोरिलेट एज विथ नलेज प्र्याक्टिस एन्ड कम्प्लेन्स अफ एसएमएस त्यसपछि टु कोरिलेट जेन्डर विथ नलेज प्र्याक्टिस एन्ड कम्प्लेन्स अफ एसएमएस त्यसपछि अर्को टु कोरिलेसन एजुकेसन लेभल अफ रेस्पोन्डेन्ट्स विथ नलेज practice and complaints of SMS. त्यसपछि जस्तै अर्को चाहिँ डिस्ट्रिक्ट वाइज कोरिलेसन बिट्विन नलेज प्र्याक्टिस एन्ड कम्प्लेन्स अफ एसएमएस हाम्रो चाहिँ स्टडी साइड चाहिँ इच डिस्ट्रिक्ट अफ प्रोभिन्स नम्बर 2 रहेछ त्यसपछि हाम्रो चाहिँ रेस्पोन्डेन्ट चाहिँ हाम्रो स्टडी पपुलेसन 80 इयर्स एबभ रहेछ मेल एन्ड फिमेल त्यसपछि हाम्रो सेम्पल साइज चाहिँ 418 एज अ क्यालकुलेटेड चाहिँ यो फर्मुला हामी युज गरेको थियो त्यसपछि हाम्रो चाहिँ 418 हाम्रो चाहिँ सिम्पल साइज रहेछ त्यसपछि इन्डिपेन्डेन्ट चाहिँ हाम्रो सोसियल डेमोग्राफिक भेरिएबल्स अनि त्यसपछि डिपेन्डेन्ट हाम्रो नलेज प्र्याक्टिस कम्प्लेन्स अनि सोसल डिस्टेन्सिङहरू रहेछ त्यसपछि हाम्रो चाहिँ स्याम्पलिङ टेक्निक भनेको चाहिँ हाम्रो कन्भेन्स स्याम्पलिङ टेक्निक त्यसपछि नन प्रोबेबल टेक्निक्स हामीले युज गरेको थियो हाम्रो चाहिँ इथिकल स्टेटमेन्ट हामी चाहिँ ERB-बाट चाहिँ हामी एप्रुभ भएको थियो एनएसआरसीबाट त्यसपछि हाम्रो चाहिँ म्यानेजमेन्ट एनालाइसिस चाहिँ हामी एक्सेलमा गरेको थियो इन्ट्री त्यसपछि हामी चाहिँ SPSS भर्जन चाहिँ हामी 90 मा चाहिँ यसको एनालाइसिस गरेको थियो त्यसपछि जस्तै हामी चाहिँ 30% अनि त्यसपछि काइस्क्वाड टेस्टहरू पनि अब त्यसमा चाहिँ हामी एनालाइसिस मेथडमा युज गरेको थियो अब चाहिँ हाम्रो रिजल्ट हेर्दा चाहिँ हाम्रो यस रिजल्टमा चाहिँ बढी चाहिँ मेलको सहभागिता बढिरहेको छ त्यसपछि जस्तै म्यारिड अनम्यारिड मध्ये हाम्रो सोसियल डेमोग्राफिकमा जस्तै अनम्यारिड चाहिँ 68.3 रहेछ त्यसपछि यसमा चाहिँ मेजोरिटी चाहिँ 89.7 हिन्दूको रहेछ त्यसपछि यसको चाहिँ हाम्रो अब एग्रिकल्चर बिजनेसमा चाहिँ हाम्रो अकुपेसनमा बढिरहेछ। त्यसपछि जस्तै हाम्रो एजुकेसन लेभलमा चाहिँ बढी भनेको अप्पर अब 10 त्यसपछि +2 लेभलको रहेछ। जस्तै अब एज ग्रुपमा चाहिँ हाम्रो चाहिँ बढी चाहिँ हाम्रो मोर देन के अरे 40 एबभ रहेछ। त्यस्तै अब चाहिँ हामीले चाहिँ स्कोर निकालेको थियो। त्यसपछि प्र्याक्टिस नलेज एन्ड कम्प्लियन्स, यसमा चाहिँ हाम्रो नलेज प्र्याक्टिस अनि कम्प्लियन्सको चाहिँ 10वटा 8वटा र 8वटा क्वेसन भनेर हामीले 3वटा पार्टमा छुट्याएको थियो। त्यसलाई चाहिँ हामी एउटा कोरिलेट गरेर यसको मिन स्कोर के अरे निकालेका थियौँ। त्यसपछि मिन स्कोर चाहिँ हाम्रो नलेजको स्कोर चाहिँ 11.72 रहेछ, जस्तो स्ट्यान्डर्ड डेभिएसन 1.75, त्यसपछि टी भ्यालु चाहिँ हाम्रो 143, त्यसपछि प्र्याक्टिस स्कोर अनि कम्प्लियन्स स्कोर यस प्रकार रहेछ। जस्तै अब चाहिँ अर्को चाहिँ हाम्रो 10% चाहिँ हाम्रो पिटेस्ट कोरिलेसन चाहिँ हामी जस्तै अब अघि चाहिँ हामीले भनेको थियो 10वटा 8वटा र 8वटा क्वेसन चाहिँ हामी नलेज प्र्याक्टिस अनि कम्प्लियन्सको चाहिँ हामीले निकालेको थियौँ। त्यसपछि हामी चाहिँ यसलाई एजमा चाहिँ हामी कोरिलेसन गरेको छौँ। जस्तै अब यहाँ हेर्न सक्नुहुन्छ मेल र फिमेलमा चाहिँ हामीले नलेज प्र्याक्टिस अनि कम्प्लियन्सको यो प्रकार हामी चाहिँ निकालेको थियौँ, जसमा चाहिँ अब नलेज लेभल चाहिँ बढिरहेको छ मेल र फिमेल दुईटामा। जस्तै अब मेलको सहभागिता बढी भएर 70.82 रहेछ, जस्तै अब नलेजको चाहिँ 58.65 रहेछ। जस्तै अब कम्प्लियन्सको चाहिँ अलि लेस रहेछ, नलेज चाहिँ ठिक छ तर कम्प्लियन्स चाहिँ अलि लेस रहेछ। अब अर्को चाहिँ हामी एजसँग चाहिँ कोरिलेट गरेका छौँ। जस्तै अब नलेज प्र्याक्टिस अनि कम्प्लियन्स चाहिँ हामी एजसँग गरेका छौँ। अब जस्तै एजमा हेर्नुहुन्छ भने हामी चाहिँ नलेज एज अब सबै एजमा चाहिँ नलेज बढिरहेछ। त्यसपछि अब हाम्रो कम्प्लियन्स चाहिँ एकदम कम रहेछ। अब जस्तै 40 इयर्स एबभमा चाहिँ 36.48 रहेछ। अब जस्तै सबभन्दा कम भन्नु चाहिँ हाम्रो कम्प्लियन्स चाहिँ रहेछ, त्यसपछि 40 एबभ मात्र रहेछ। नलेजको पनि त्यस्तै हेर्न सक्नुहुन्छ यहाँ। त्यसपछि अर्को चाहिँ हामी चाहिँ एजुकेसनलाई अब कोरिलेट गरेको थियो तिनटैले नलेज प्र्याक्टिस अनि कम्प्लियन्स चाहिँ। अब जस्तै यहाँ मास्टर र पिएचडीमा चाहिँ अलि नलेज बढिरहेछ, त्यसपछि इलेक्ट्रेटमा चाहिँ नलेज एकदम कम रहेछ। अब यहाँ हेर्न सक्नुहुन्छ भने इलेक्ट्रेटमा चाहिँ हाम्रो नलेज प्र्याक्टिस अनि कम्प्लियन्स चाहिँ एकदम कम रहेछ। जस्तै मास्टर र पिएचडीमा चाहिँ हाम्रो नलेज कम्प्लियन्स अनि प्र्याक्टिस चाहिँ बढी देखिरहेछ हाम्रो स्टडीमा। अब त्यसपछि हाम्रो चाहिँ यहाँ अब हामीले चाहिँ डिस्ट्रिक्ट वाइज यहाँ कोरिलेसन निकालेको छौँ तिनवटाकै नलेज प्र्याक्टिस अनि कम्प्लियन्स। अब जस्तै यहाँ अब सिरामा हेर्न सक्नुहुन्छ भने सबभन्दा बढी चाहिँ नलेज अनि त्यसपछि प्र्याक्टिस अनि कम्प्लियन्स रहेछ। अब जस्तै यहाँ हाम्रो चाहिँ महोत्तरीमा एकदम कम देखिएको छ नलेज प्र्याक्टिस अनि कम्प्लियन्स। अब यो सबैमा हेर्नुहुन्छ भने हाम्रो चाहिँ कम्प्लियन्स चाहिँ अब कम देखिएको छ फलोअप गर्नु। अब त्यसपछि हाम्रो प्र्याक्टिसको पनि एकदम न्यून देखिन्छ। अब नलेज लेभल चाहिँ ठिक छ, त्यसपछि हाम्रो चाहिँ कम चाहिँ महोत्तरीमा सबभन्दा कम छ। अब जस्तै हाम्रो चाहिँ सिरामा सबभन्दा बढिरहेछ। त्यसपछि अर्को चाहिँ हाम्रो चाहिँ अब कन्क्लुजनमा चाहिँ हामीले चाहिँ अब यो कन्क्लुजनमा सजेस्ट दैट नेपाली हु पार्टिसिपेट इन दिस स्टडी हैव गुड लेभल अफ नलेज बट द प्र्याक्टिस वाज लेस। यसमा चाहिँ ओभरअलमा हेर्ने हो भने चाहिँ प्र्याक्टिस र कम्प्लियन्सको एकदम लेस देखेको छ। त्यसपछि हाम्रो कम्प्लियन्स विथ नन फार्मास्युटिकल इन्टरभेन्सन, अब चाहिँ इन्टरभेन्सन मेजर आउटलाइन बाई गभर्मेन्ट एन्ड WHO which was necessary for meeting the state of SMS was found to be least compared to the population having knowledge and practice SMS. त्यसपछि अब यहाँ चाहिँ नो रिमार्केबल सेक्सन इन गभर्मेन्ट इफर्ट फर म्यानेजमेन्ट अफ वाटर सेटिस्फ्याक्सन एन्ड अवेरनेस विथ प्रोग्रेस नम्बर 2। चाहिँ वाटर स्टेसन र अवेरनेसको चाहिँ यहाँ हामी चाहिँ कन्क्लुजनमा देखेको छ। त्यसपछि हाम्रो मेजोरिटी फाउन्ड टु हेभ पैथेटिक सिचुएसन वाइल एनालाइजिङ द प्र्याक्टिस एन्ड कम्प्लियन्स अफ SMS। अब त्यसपछि हाम्रो एक नलेजमा अब हाम्रो चाहिँ रेस्पेक्टेड सरहरू हुनुहुन्थ्यो, उहाँबाट हामी चाहिँ टिममा केही कन्ट्रिब्युसन रहेको छ, उहाँहरूको नाम रहेछ। त्यसपछि हाम्रो यति रहेछ। थ्याङ्क यू सर।
So thank you, Sawanji. So moving on, now I'd like to request Dr. Rakesh Gimire to present his presentation entitled Public Understanding and the Response to COVID-19 in Nepal, a population-based study. Thank you.
COVID-19, which was emerged in Wuhan, China at the end of 2019. Since then, it has spread to 200 countries and has been declared a global pandemic by the World Health Organization. The knowledge, attitudes, and the practices towards COVID-19 play an integral role in determining a society's readiness to accept behavioral change measures from health authorities. Namaste everyone, I'm Dr. Rakesh Kimiri. I'm working as an assistant professor in the Department of Clinical Pharmacology, Mahas Medical Campus, Institute of Medicine, Tribhuvan University. The title of my research today is Public Understanding and the Response to COVID-19 in Nepal, a population-based study. So these are the list of my co-authors. The new coronavirus disease, COVID-19 pandemic, has become a major cause of death throughout the world. It spreads through multiple ways: droplets released while coughing or sneezing from an infected person, fecal-oral and direct contact. To control and prevent the infection has become a great challenge for every country in the globe. The best way to prevent and slow down transmission is to be well informed about the coronavirus, the disease it causes, and how it spreads. Hence, the study was conducted with the aim of identifying the public understanding and the response to COVID-19 in Nepal. A nationwide cross-sectional online survey was carried out during the first lockdown. Participants aged 18 years and above and the Nepalese citizens staying in Nepal were included in the study. A total of 3,582 responses were included for the analysis. Convenient non-probability sampling technique was used. Self-administered questionnaire was used, and it was deployed in the Viber group of Ministry of Health and Population. Approval from NHRC was taken prior to the start of the study. A simple descriptive analysis was done, and a Pearson correlation was used to analyze the correlation of knowledge, response attitude, and the practice. So this is the map of Nepal showing the distribution of participants according to the provinces of Nepal. Of the total study participants, that is 3,582, majority were from the Bagmati province and very few were from the Karnali province. So this is the figure showing the age distribution of male and female participants. Of the total study participants, there were more male, which accounts to 73.2%, to the female, which accounts to 26.7%. And the majority of the participants were between the age group of 25 to 39 years. And we looked on the public understanding on the COVID-19 among the public, and the study found that most of the participants knew that hand washing, sanitizing, avoiding touching face, avoiding close contact with sick, disinfecting touched objects, and wearing a general mask helps prevent transmission of COVID-19. Participants had beliefs in common myths as well. Majority of the male participants believed that drinking hot water, gargling, avoiding imports from abroad, or distancing from pets prevents the transmission of COVID-19. When asked for the major symptoms of COVID-19, the study found that almost all the participants had knowledge that fever, cough, and difficulty are the common symptoms of COVID-19. The understanding on the social distancing, isolation, and quarantine was found to be 89.7%, 92.4%, and 83% respectively. So when we asked for their response to self-quarantine and isolate if they have fever, 97% participants were ready to self-quarantine and isolate themselves if they had fever. About 99% participants agree that it's unsafe to travel across or within the country during the lockdown. And this is a figure showing the different how the study participants used to prevent the infection from the groceries. More than a third, about 36% of the participants washed recently brought groceries with warm water before taking inside house in order to prevent the infection due to COVID-19. Some participants kept outside for a few days and some kept in salt water before use. The study found that 15.3% of the participants washed their groceries with soap and water before use, while 15% did not use any precautions. When we asked for the adherence to the lockdown, more than 3/4 of the participants had avoided the lockdown till the study period. So these are the two figures showing the figure number 5 showing the types of marks used, and the figure number 6 showing the used marks management. And when we looked at the types of marks used, more than half, about 52.6% of the participants had used surgical masks, and 2.1% did not use while leaving home. And when you looked at the used mask management, half of the participants had washed masks or kept in the sun and reused. And when we asked the participants' response to government's effort to control COVID-19, participants support these strategies: quarantine everyone returning from abroad for 18 days, suspending the air travel, closing the schools, prohibiting mass gatherings and lockdowns. This is the figure showing the problems faced during the lockdown by the study participants. The problems that the participants faced during the lockdown were difficulty getting daily consumable items, which accounts for 58%, economic burden for not having job, which accounts for 30.6%, mental illness due to fear, which accounts to 11%, and domestic violence like verbal, physical, or sexual, which accounts to 0.4%. When we looked at the mean COVID-19 knowledge, which was found to be 9.74 with the standard deviation of 1.59 out of 12, with an overall 81% correct rate. The mean attitude score was found to be 7.09 with an standard deviation of 0.77 out of 8, suggesting an overall positive attitude rate of 89%. When we looked at the mean practice score, which was found to be 2.70 with an standard deviation of 0.53 out of a score of 3, indicating an overall 90% good practice rate. So this is the table showing the correlation between the knowledge, attitude, and practice. To determine the relationship between the knowledge and attitude responses, knowledge and practice, and attitude response and practice to COVID-19, a Pearson correlation was used. It was found that there was no relationship between the knowledge and attitude response. However, there was a statistical significant positive correlation between knowledge and practice for the prevention of COVID-19. In conclusion, the findings of the study showed that majority of the patients have good knowledge, 81%, positive attitude, which accounts to 89%, good practice, which accounts to 90% for COVID-19 in Nepal. Public are the most important stakeholder for the containment of any outbreak in the community. Public understanding and the response play an important role in preventing the spread of COVID-19 disease in the community. Therefore, adhering to the national guidelines and adopting the universal safety precautions by public can eventually help government to implement different strategies to control COVID-19 pandemic in Nepal. Getting yourself vaccinated, adhering with the SMS guidelines, social distancing, wearing masks, and use of sanitizers, these are the only preventive measures for now. Let's put our hands together to contain this global pandemic of COVID-19. So we would like to give a special note of thanks to Dr. Pradeep Gewali, who is an Executive Chief and Member Secretary of NHRC, and the whole NHRC team for their support to conduct this study. And thank you. Namaste.
Thank you, Dr. Ghimire, for bringing in a very valuable information. So moving on, I'd like to invite Santosh Dulalji to present his presentation on entitled Analysis of SARS-CoV-2 RT-Q PCR Methodologies for Quality Assessment, a COVID-19 Laboratory Internal QA Review. The floor is yours. Thanks.
Greetings and namaskar all from Kathmandu, Nepal. I'm Dr. Santosh Dulal, and it is truly an honor to present in the 7th NHRC Summit. As a presenting author, today I'm giving a talk on the topic Analysis of SARS-CoV-2 Real-Time Reverse Transcriptase Polymerase Chain Reaction for Quality Assessment, a COVID-19 Laboratory Internal Quality Assessment Review, which was conducted at COVID-19 Diagnostic Laboratory, the Leprosy Mission, Nepal, and conducted by the mentioned author. The layout of my presentation is as follows. I would briefly give about the COVID-19 diagnostic laboratory introduction, and then I will provide some research objective, and then provide the methodology on the different assessments, and give the results or finding of this assessment, and finalize with summary and the recommendation. Let me talk about the brief introduction of COVID-19 Diagnostic Laboratory, which is located at Anandaman Hospital of the Southern Lalitpur of Godavari municipality. So it is one of the oldest molecular laboratory in the nation, and the serial TLMN got approval from NPHL and Ministry on the second week of the August 2020. And then immediately we have started the COVID-19 testing. So far we have tested more than 4,700 samples, and then detected 25% of the total samples. And we have been periodically involved on the quality assessment from internal assessment system, NPHL, and World Health Organization system. So let me talk about the objective of this study. So as a general objective, to perform periodic quality assessment of real-time PCR experiment for the optimal performance, which is guided by the MIQE. The meaning of MIQE is minimum information for publication of quantitative real-time PCR experiment, which is also considered as the global standard guidelines for real-time PCR on the diagnosis of SARS-CoV-2 or COVID-19. The specific objectives are to determine the effects on downstream PCR results by comparing manual versus automatic RNA extraction, by sample storage and duration of the sample storage, by PCR efficiency of the reaction, and by quantity of the internal quality control system, and by the different concentration of sodium hypochlorite. So these slides talk about the methodology on different assessment. So we have carried out a simple experiment or the assessment system to compare the final product on the assessment system. So in the first experiment, simple experiment, we did the RNA extraction from the manual IPO system and automated bio extraction system, and we compare the final product on the internal control on the PCR results. And then second results, we store the samples and for 35 days, and then we check the different gene system on the PCR results. And then also we have done the serial dilution of RNA samples on the PCR reaction, and then we check the final results of the different gene system on the PCR results. And again, we have used the different concentration of sodium hypochlorite, which is also used as a disinfectant. And then we check the different genes results on the PCR system. And then we also have done the post-test evaluation, like a re-extraction, re-PCR, and then we check the PCR results of the inconclusive results. So let me start the results of my methodology. So first results, we have shown the automated and manual RNA extraction. This slide shows the CT values of internal control of 23 samples of manually extracted RNA samples compared to the automated RNA extractor samples. So when you see the CT values of the manual samples, you can see the consistent results and not a varied CT values. However, compared to the automated, you can see the inconsistent CT values of the automated RNA extraction and the varied CT values. So we recommend to use the manual RNA extraction if possible, because manual RNA extraction is tedious, but it gives the consistent results. So let me talk about another slide of the results. So this slide shows the comparison between the sample storage of 35 days compared to the immediate sample without storage. So sample storage of 35 days results some impacts on the sample quality. So when you see the red circle compared to the square, you can see the higher CT values of the internal control of 6 samples compare here. So we recommend not to store samples. So without storing, immediately process the samples from this slide or from these findings. So another results, we have serially diluted the RNA sample by 1/2, 1/4, 1/8, and 1/16. And then we have done the standard curve. And then our system showed and revealed the PCR efficiency within a limit, 80 to 100%. So we recommend that when you start your experiment or diagnosis of COVID-19, you need to do the standard curves with serial dilution of RNA samples. And again, if you change the different kits, you need to run the standard curves. So standard curve is always important for the quality assessment. So next slide, we have diluted the internal control by 1/2, and then we have run the downstream process, and then the results of PCR shows that the CT values of internal control of 4 samples shows that higher CT values in 2-fold diluted samples compared to the normal. So we recommend not to dilute the internal control. So always use the recommended internal control in the PCR. So it gives the consistent results and it always meet the quality assessment or quality control. So the another results we have using the different concentration of sodium hypochlorite, and then we have found that normal range and 0.5% sodium hypochlorite do not inhibit the reaction, and it gives the consistent results. However, when you use the 1% and 2% of sodium hypochlorite, it gives the sample inhibition and it gives inconsistent results. So we recommend when you use the sodium hypochlorite as a disinfectant, use very precociously. Otherwise, it can cross-contaminate and inhibit the samples and gives the inconsistent results, which ultimately affect the quality assessment. So we also did the re-extraction samples and we did the post-test evaluation. And then we have found that one sample which detected as a negative resulted as a positive in the after re-extraction. So in confusing samples, you need to do the re-extraction. And then do the post-test evaluation. And another, we have done the post-test evaluation and it always give the confirm of the results. So post-test evaluation is very important and you need to do the post-test evaluation for the quality assessment. So from all these findings, we have concluded that different assessment have done and done for the internal control, and then we have reached to the RT-PCR global standard guidelines. And then another things is elevated curves leading to arbitrary CT values might not always be true indicator of sample positivity, whereas CT values beyond the recommended limit could also exhibit the positivity. So our recommendation is commercial kit must be internally and externally validated periodically for quality control and quality assessment. Nature of amplification curves needs to be precisely investigated for ruling out false positive and negative results. So I would like to acknowledge the NPHL and Ministry of Health for the approval, and then lab colleagues, Anandavan Hospital and the Leprosy Mission Nepal and England and Wales for the support. And thank you all for your attention. And I am happy to accept any question if you have. Thank you so much.
So thank you, Dr. Dulal. So next, we'd like to invite Dr. Sivakumar Saha to present his presentation entitled Obesity and its Association with the Severity of Illness Among Patients with Laboratory Confirmed SARS-CoV-2 in Nepal. So on to you, Dr. Saha.
Namaskar, सबैजनालाई. My name is Sivakumar Saha and I am affiliated with Purvanchal University. Today my research topic presentation is about obesity and its association with the severity of illness among patients with laboratory confirmed SARS-CoV-19 in Nepal. Background is the emergence of COVID-19 in late 2019. It has become a global pandemic and has now become a global threat to human health. Obesity remains among the most common conditions associated with the COVID-19, and indeed, about 40% of the patients with COVID-19 hospitalized in the hospital are obese, and it has been associated with hospital admission, severity, intensive medical intervention, and increased mortality rate. However, this demographic and anthropometric characteristic may differ from setting to setting, like Asian to non-Asian population. Thus, it has become crucial to know this demographic pattern across the region. Importantly, there has been a dramatic rise on the obesity in Nepal in recent years, and thus it becomes crucial to gain insight into understanding the association between obesity and COVID-19 in Nepalese setting. We have conducted these studies with several objectives. The prime objective was to assess the prevalence of obesity and its association with severity of illness among the laboratory confirmed SARS-CoV-19 infection. And also we have conducted this study to determine the association of obesity with socio-demographic and clinical parameters of the disease. And this study was cross-sectional study and was conducted according to the stroke guideline for observational studies. And this study was conducted at APF Hospital between December 2020 to April 2021. For the inclusion criteria, we have included the individuals as 18 years or above who consecutively hospitalized in the hospital. And for the exclusion criteria, since we had only a few number of underweight patients, so we had excluded this from the study because this was not the representative population in our study. And outcome measures, the primary predictors of the study was BMI and was categorized into normal weight, overweight, and obese. And further, this was categorized into presence of obesity defined by BMI over 25 and absence of obesity. For the covariates, we use age, sex, smoking history, alcohol history, comorbidity, including hypertension and diabetes as a covariates. And for the primary outcomes, we used severity of the disease. For the clinical assessment of the disease, we have categorized severity of illness into 4 categories: mild, moderate, severe, or critically ill. And obesity was classified according to the WHO classification. And for the data collection, data were collected from the medical records for the socio-demographic, epidemiology, and relevant clinical information. And where necessary, the patients were interviewed. And for the data processing and analysis, continuous data were presented as mean plus minus standard deviation. And for the skewed data, we use median interquartile range. And we use chi-square or Fisher's exact test to examine the difference in demographic and clinical category and across the different category of the BMI. And we use Wallis test for the numerical values. For a statistical purpose, COVID-19 patients were categorized into 2 groups, non-severe and severe, and univariate and multivariate logistic analysis was done. And this study was approved by the Ethical Review Board of NHRC. Now results. We have analyzed total 154%, and the median age of the patient were 38 years, and male remained the predominant in our study. And as far as comorbidity concerned, hypertension remained the major, followed by diabetes mellitus. Blood group A positive was the predominant in our study. And this is the some demographic, socio-demographic character of the patients. And as far as the clinical parameters, about 70% of the patients were symptomatic, and respiratory symptoms remained the predominant, followed by digestive symptoms. And the patients who had lost the taste or smell accounted for about 26%. Now, prevalence of the obesity. The estimated prevalence of obesity was 48.4%, and about 40.6% were overweight, and about 10% were obese, including class 1 and class 2. Now, association between BMI category and patient characteristics. As you look at the slide, we could see that age, gender, and hypertension was significantly associated with across the BMI category. Similarly, comorbidity and respiratory symptoms and chest smell were significantly associated with the different category of the BMI. Now, association between obesity and symptoms present. As we look at the slide, we can see that prevalence of symptomatic patients were significantly higher in obese patients compared to non-obese patients. With respect to disease severity and obesity, we can clearly see that the prevalence of severe critical ill patients had significantly higher in obese group compared to non-obese group, and the difference is significant. Now, logistic regression analysis of association between BMI category and severity. Each one unit increase BMI was associated with about 10% increase the risk of severity in univariate analysis. However, this was not significant predictor in multivariate analysis. Similarly, obesity defined by BMI over 25, the risk of having severity was 2.1 in univariate analysis. Again, in multivariate analysis, this predictor remained insignificant. And each one unit increase in age was associated about 5% increase the risk of disease severity in univariate analysis and about 4% in multivariate analysis. Similarly, hypertension emerged as a significant predictors in both univariate and multivariate analysis. Finally, this regression demonstrates that each one unit increase is the BMI is significantly associated with disease severity, and we can see that odd ratio increase accordingly as the BMI increases. Now, conclusion. About 10% of the patient had obesity and about 17% had severe illness. And our study indicates that presence of obesity may contribute to the severe severity of the disease and warrants early identification and proper monitoring of these contributing factors, and it becomes crucial to initiate a proactive intervention so as to diminish the severity and improve the therapeutic outcomes of the disease. Acknowledgement. We sincerely thank to the hospital, APF hospital, and the patients whose data were anonymously used in our study. And we also thank to all contributing authors. And finally, we thank NHRC for allowing us and give the opportunity for this presentation. Thank you for your kind attention. Thank you.
So thank you, Dr. Shah. Moving on, I'd like to invite Suvesh Raj Khayastuji to present on his topic, Clinical Experience on Outbreak of Major Tropical Infection in Sudur Paschim Province, 2017.
So this is an institutional-based study which has been carried out in 2 different hospitals of Sudur Paschim Pradesh. And the objective of this study is to know the incidence of common tropical diseases with their various clinical presentation, morbidity and mortality in Sudur Paschim Pradesh. This is a prospective observational study. In this study, a total 425 several cases admitted in the hospital were enrolled, and among them 276, which comprise 64% cases, had tropical disease. This study was carried out in Seti Provincial Hospital and Namabuddha Hospital, a private hospital located at Hungary. Duration of the studies was 1 year, commencing from January to December 2017. History taking, clinical examination, and clinical laboratory tests were used as diagnostic tool for the diagnosis of tropical disease. Scrub typhus. ranked as first common tropical disease in our study. As we know, scrub typhus is an acute febrile illness caused by Orienta susugamusi. The mode of transmission is bite of infected cedar or infected larva, also called trombiculite. The first outbreak of scrub typhus was observed in Nepal on 2015, and in Far West region it was documented on 2015 as well. The scrub typhus comprised 205 cases, that is 74% in our study. The clinical presentation. The clinical spectrum of scrub typhus varies widely from asymptomatic case to mild febrile illness to multi-organ dysfunction, and patient may die with various complications if we are not treated. So the complications will begin after first week of illness. The fever is almost invariable presentation, which is continuous. Relative bradycardia is remarkable in this fever. Maculopapular rash were observed in 13.65% of the cases, which usually initially appear at the trunk and chest, abdomen. Later it will spread throughout the extremities. Suffuse conjunctiva is a remarkable sign. And there is cervical lymphadenopathy, which is discrete non-tender robbery. And scare lesion is the surest sign of scrub typhus. Is characterized by central black area of necrosis surrounded by erythematous red erythematous lesion. You see, these are some important pictures which were taken during our study. This is a maculopapular rash over the chest, anterior aspect of the chest, with sign of delay capillary filling time, which reflects tissue hypoperfusion, and the patient was on the state of shock. This is the heel scale lesion with central necrosis, black area with erythematous rashes, and cervical lymphadenopathy with suffuse conjunctiva, which is very striking feature of scrub typhus. And this is the fresh scale lesion with central necrosis surrounded by erythematous red area with maculopapular rash all over the body. So the meticulous source of scale lesion is very important during clinical examination, as this is a surest sign of scrub typhus. So the clinician should be aware about this lesion, and we have to search meticulously during clinical examination. Say, for example, this is a lady having scale lesion at on her inframammary region. This is a small girl's picture. The scale lesion at the genital area, at the nape of neck, and the heel lesion at right axilla. So sometimes the scrub typhus presents with acute feature of acute abdomen. In 10.73% in our study, the pain is localized in the right upper quadrant of abdomen. It is the acute abdomen is due to portal triaritis. Acalculous cholecystitis was found in 20%, and patients with jaundice sometimes confused with infective hepatitis. So far, the complications are concerned. Acute kidney injury is the most common complication observed in 17%, feature of hepatitis in 11%, and 21% presented with a shock. 0.48% have multi-organ dysfunction. 21.46 cases were managed in ICU, and ventilator support in 1.9% cases, and mortality was observed in 1.95%. So dengue was the next second common tropical disease in far west region. It is a newly emerging disease. Earliest cases notified in Nepal during 2005. Nationally, there was a large outbreaks during 2006 and 2010 in far west region. We noted outbreak of dengue fever since last 2011 till yearly. The cause of dengue is RNA virus, dengue virus. There are 4 subtypes of virus, dengue 1 to dengue 4. The vector is mosquito, and common mosquito is Aedes aegypti, as well as Aedes albopictus. And sound to cartilage are the peak incidence for dengue fever. So this is the clinical spectrum of dengue fever. It is a short course of acute febrile illness, which lasts for about a week, 1 to 7 days. And if you see the diagram, there is a pink color horizontal bar. You see this. The third to fifth day is called critical phase, because, however, during this phase the patient will remain ephemeral. So this is called critical phase because the most of the complications used to observe during this phase, say for example, like thrombocytopenia causing dengue hemorrhagic fever, leaking syndrome, as well as dengue shock syndrome, dengue hemorrhagic fever. These all are commonly observed during this critical phase. And on the laboratory parameters, if you look at this graph, the platelet count will be reduced on third to fifth day, and sixth day onward it will begin to rise. And similarly, the hematocrit will increase during 3 to 5 days because of intracellular leaking syndrome, because of intracellular dehydration, intravascular dehydration. If we look at the serological and virological marker, during initial phase of dengue fever, the antigen test will be positive. Later, after a week, the antibody will appear, the IgM will positive, and later the IgG will positive throughout the life. So, in our study, this was the second common cause of tropical disease in far west region, which comprised 7.6. The classical dengue fever was observed in 95%, and dengue hemorrhagic fever was observed in 4.76%, and dengue shock syndrome was observed in 4.76 to 76%. 2 cases were presented with dengue and scrub co-infection, and dengue fever with scrub diapers with sickle cell disease with splenic sequestration was observed in the patient. Brucellosis was the third most common tropical disease in far west region, 16 cases, which comprised 5.79%. Is benign course of illness. Patients usually have the prolonged history of fever, even 6 to 7 months of fever with chill and sweating. However, the patient will remain ambulatory. History of animal handling and eating of uncooked milk and milk products are invariable, and symptom resolve after 3 to 4 days of institution of treatment against brucellosis. So brucellosis is a multisystemic involvement will be there, and say for example, the eye involvement is common in our study, musculoskeletal to the next, and in literature we usually get CNS involvement cardiovascular involvement, pulmonary involvement, as well as genitourinary involvement, and many other organs are involved in this disease. However, in our study, 18.75% have different ocular involvement, and 6.25% have osteoarticular involvement, and there was no complication in majority of the cases, at around 75%. So malaria in Nepal, currently, the malaria is in elimination phase on the basis of API, that is annual parasitic index. There are 13 high-risk districts in Nepal, whereas 18 districts are moderate risk and 34 districts are with low risk. So during 2017, Plasmodium vivax, we found 1.81% and Plasmodium falciparum 0.36% cases, and the Plasmodium falciparum was imported from India. Kala Azar, 9 cases that comprise 3.26% among the total enrolled. Clinical relapse was observed in 33% cases. So we managed this case with amphoteration, leveragable amphoteration, and responded to treatment was done on the basis of size of spleen, fever, blood count, that is reversion of blood pancytopenia into normal count. Improvement in general condition of the patient was also considered. So in conclusion, tropical fever is common cause of febrile illness. Any fever without localizing signs should be suspected. For tropical fever, most of the tropical infections are curable and preventable. So lastly but not least, we should remember seasonality should be considered while treating febrile illness. Thank you very much.
So thank you, Dr. Kayastha, for depicting the picture of major tropical infection of concerns in Sudur Paschim province. So please stay with us, stay connected with us for the questions from our audiences. So moving on, I'd like to invite Dr. Suveksha Silwal to present on lived experiences of COVID-19 survivors of Province 1 Nepal of phenomenological study. Thank you.
Namaskar and very warm welcome everyone. This is me, Suveksha Silwal, on behalf of co-authors listed here from Adult Health Nursing Faculty, Tribhuvan University Institute of Medicine, Biratnagar Nursing Campus, presenting a research titled Lived Experiences of COVID-19 Survivors of Province 1 Nepal, a Phenomenological Study. Globally, each year, disaster events of pandemic, epidemic, earthquakes, tsunamis are increasing, killing thousands of people. And at present, new public health crisis, that is, coronavirus, is threatening the world with its sudden emergence, rapid spread, and mutant variants. Nepal reported its first case on January 2020, and the country is struggling with second wave of COVID-19 pandemic now. As of 26 June 2021, there are total 70,191 COVID cases in Province 1 Nepal. Studies conducted worldwide have suggested that COVID-19 survivors not only face stigma and discrimination, but also mental consequences like anger, fear, loneliness. Survivor from serious communicable diseases itself is a new hope to life, and survivors may face myriad economic, social, and health challenges. Survivors' reactions are considered severe immediately after a tragic event, but most reactions become more subdued within 1 year. On the other hand, long-term effects of traumatic events reveal that survivors continue to experience effects of trauma 5 to 10 years later even, and have lifelong effects even 25 to 50 years later. Even in Nepal, it was reported that second case of COVID-19 received hate mail and death threats on social media once the case was made public. Objectives of the study were to explore the perception of COVID-19 survivors on familial and social responses at different stages of the disease process. Similarly, to explore the opinion of COVID-19 survivors on healthcare services during hospital stay, and to identify the major post-COVID impacts faced by COVID-19 survivors. Qualitative phenomenological research design was used for this study, and the research setting was set as per survivors' convenience either at home or at workplace. Population where COVID-19 patients recovered and discharged from COVID Kosi Hospital, Biratnagar, Province 1. Based on principles of data saturation, sample size were 10 COVID-19 survivors who were recovered at least 1 month of their infection and were traced from hospital inventory. Purposive sampling method was used for selection of those samples. Similarly, face-to-face, in-depth interview was carried out with semi-structured interview guides, which consisted of 2 parts. Part 1, sociodemographic characteristics, and Part 2, in-depth interview guide. The credibility of the instrument was enhanced with opinion of subject experts, colleagues, and peer feedback. Similarly, the verbatim collected from the participants were transcribed, listening to the audio records and observations like facial expressions, gestures, where memo were also noted down. Ethical clearance was obtained from IRC of TUIOM, and before proceeding with the data, research approval was also taken from a concerned authority. Similarly, the duration of data collection was about 1 month with simultaneous data analysis, and it was collected from January 14th, 2021 to February 14th, 2021. 6 pages of thematic analysis developed by Egyptian 2006 was used for the analysis process. Results, there were finally 5 themes emerged after the thematic analysis. They were Theme 1, key stakeholders in COVID-19 pandemic. Theme 2, mystery of COVID-19. Theme 3, social stigma and discrimination. Theme 4, mass media influence. And Theme 5, safety measures. Moving towards the Theme 1, 5 participants reported that they had acquired infection from their workplace. One was the security guard who reported that, I have no idea how I got infections. I used to stay at the gate. I had to talk at first and contact many visitors. Similarly, 3 also reported that they got contact from social contact. And in Theme 2, 8 of the participants reported the infection as mysterious regarding cause, transmission, and severity of COVID infection. Code 102 ले के एक्सप्लेन गर्नु भएको थियो भन्दाखेरि आई विल एक्सप्लेन नेपाली हस्पिटल आउँदा आफै हिडेर आका कोही हट्टाकट्टा बिरामीहरू पनि अलिक दिनपछि चाहिँ खुब चिच्याएको सुनिन्थ्यो अनि त्यसको 2-4 घण्टामा 3 ठाउँ बाँधेर लगेको देखिन्थ्यो खै के भएको होला अझै पनि बुझ्न सकिएन some said like that. Similarly, Theme 2 social stigma and discrimination. 7 of the participants reported feeling of stigma and discrimination from healthcare workers during hospital stay. When I reached hospital, an elderly patient of about 80 years came to the hospital suffering from corona and was serious. The staff didn't even touch him. I and another corona-infected patient together helped the elderly person to get on a chair and escorted him. During the transport, the old patient died. Then I felt very bad by staff's attitude towards us and disappointed to on decision in admission in hospital, explained by Code 106. Similarly, Theme 4, mass media influence. Few reported that hearing conflicting news provided by media exacerbated anxiety and fear among people. Code 108 reported, मेन त समाचारले नै बिगार्ने हो यतिजना मरे उतिजना मान्छेलाई संक्रमण भयो भनिराख्ने त्यतिकै त बिरामीलाई एक्लै दिन्छ बस्न आफ्नो मान्छे नि छिर्न दिदैन होपलेस भइरहेको हुन्छ त्यही माथि समाचार भनेर पनि रिपोर्ट गर्नु भएको थियो. Similarly, Theme 5 safety measures. Almost all participants reported safety measures as proper hand washing, wearing masks, avoiding crowds to best measures for preventing from the infections. Conclusion, the infection was found to be mysterious with unknown cause and peculiar physical symptoms with individual variants. Similarly, stigma and discrimination was found in workplace and hospital with lack of appropriate health counseling and support. Those survivors motivated हुनुहुन्थ्यो हेल्थ केयर सर्भिस सिक गर्नलाई किन भन्दाखेरि घरमा अथवा आफ्नो फ्यामिलीमा इन्फेक्सन हुन्छ भनेर but even though they were scared of hospitalization due to the fear of being isolated as well as high institutionalized mortality. Implications: the emergent themes might be helpful to reflect the meaning structures of managing, enduring, and surviving the day-to-day experiences of COVID-19 survivors. Similarly, the dissemination research report might be helpful for different stakeholders in understanding the psychological state, identifying and strengthening service of patient in a post-COVID stage of life. Recommendation: as the coronavirus pandemic rapidly sweeps across the world, including our country Nepal, it is inducing a considerable degree of fear, worry, and concern in the population at large, care providers, and people with underlying health conditions. Thus, at present, COVID-19 and related issues are the most important to be studied and addressed. Acknowledgement: we would like to extend our heartfelt gratitude to TUIM Biratnagar Nursing Campus, Biratnagar, for the provision of research grants for developmental research to promote the in-house research culture. And similarly, thanks to NSRC for giving the platform for this oral presentation in this 7th National Summit, NHRC Summit. These references are listed here. Thank you all.
So thank you, Silwal ma'am, for very valuable information. So we are moving towards the last presentation for the session. So I'd like to invite Dr. Tejendra Manandar to present on the topic COVID-19 patients and their management in a tertiary care center in Nepal. So the floor is yours, Dr. Manandar.
Namaste. I am Dr. Tejendra Manandar. The topic for our research is COVID-19 patients and their management in a tertiary care center in Nepal. Along with me, there are other 6 authors: Dr. Pragya Devkota, Dr. Sajala Kafle, Umi Bajracharya ma'am, Dr. Nisha Jha, Dr. Kumud Kumar Kafle, Dr. Milesh Jung Sijapati. All of us belong to Department of Pharmacology except Dr. Milesh Jung Sijapati, who is from Department of Internal Medicine. We all are from KIS Medical College and Teaching Hospital, which is affiliated to Tribhuvan University. Moving on to the background of our research, coronavirus disease of 2019, which is simply known as COVID-19, is a novel infectious disease caused by SARS coronavirus. The common symptoms of this disease include fever, cough, dyspnea, expectoration, headache, myalgia, and fatigue. The least common symptoms include diarrhea, shortness of breath, hemoptysis. Many persons who develop severe disease may also develop acute respiratory distress syndrome and can have multiple organ failure. Many of the patients are also asymptomatic. World Health Organization declared coronavirus disease as a pandemic on March 11, 2020. Many countries have followed different types of treatment guidelines, but they differ among each other, and there is no approved treatment for COVID-19. The management is directed towards the supportive care according to each patient's need. The objectives of this study were to list the clinical features of COVID-19 and to find out the pharmacological and other various measures employed in the management of COVID-19, as well as to estimate and approximate drug costs for the management of the disease. This is a retrospective cross-sectional study which was carried out from the records of PCR positive patients admitted in KIS Medical College and Hospital from 4th June 2020 to 31st January 2021. We use systematic random sampling for selection of cases. Out of 541 positive cases, we chose every 4th case, so the sample size of our study was 136 patients. The total cost of the medicines was calculated from the unit price, which was collected from the hospital pharmacy. And this cost did not include the cost of medicine used for the patient's comorbidity. That means only the cost of the medicines that were used for the management of COVID-19 was considered, and not the cost of the medicines which were used for patients' comorbidities. The results of our study are where 93 patients were male, while 43 patients were female. Most of the patients fall under the age group 41 to 50, which is 38, followed by the age group 31 to 40. Only 2 patients were below 20 years, and 6 patients were more than 80 years. The most common symptoms seen during the study were fever, cough, headache, myalgia. The least common symptoms that were seen were shortness of breath, vomiting, diarrhea, loss of taste, loss of smell, etc. Severity of COVID-19 was mild in case of 101 patient and moderate in case of 21 and 28, while 7 patients had severe COVID-19. Comorbidities were present in 64 patients and were absent in 72 patients. The most common comorbidities were hypertension and diabetes mellitus. The least common ones were like heart diseases, asthma, etc. Out of 136 patients, only 31 patients required supplemental oxygen, while 105 patients did not require oxygen supplementation. Most of the patients, 126 of them, were managed in isolation ward alone, while only 10 patients required intensive care unit treatment, and out of which only 1 patient needed ventilator support. The most commonly used drugs in the management of COVID-19 were vitamin C, vitamin D, and zinc, which were used in 123 patients, followed by pantoprazole and levocetirizine, which were used in 99 and 87 patients respectively. Other medicines like metronidazole, pantoprazole, hyoscine were also etc. were also used in 73 patients. As we can see in the figure, the medicines like paracetamol or enoxaparin or the antibiotics or salbutamol were also used. Remdesivir was used in 21 patients. Out of 136 patients, 127 patients, that is 93.4% patients were discharged. 3.7%, that is 5 patients died, and only 2.9%, that is 4 patients were referred to the higher centers or other centers. The average stay of the patient in the hospital was about 11 days, that is 10.9 days. Total approximate cost of the drugs per patient ranged from rupees 75 to rupees 72,243. Thus, the average approximate total cost per patient was found out to be rupees 9,966.44, which is about 9,000 rupees. So from our study, we can conclude that mild cases of the COVID-19 were higher in number than the moderate or severe cases. Most commonly used medicines were vitamin C, vitamin D, zinc, and pantoprazole. The average cost of medicine, that was about 9,000 rupees, is quite high with regard to per capita income of Nepal, which is about 11,300 per month. In this study, the cost of the medicines were only for the medicine that were used for the treatment of the disease, and it did not included the cost of hospital stay as well as other devices that were used for delivering the medicine. So it was quite high with respect to per capita income of Nepal. Thus, there should be effective preventive measures like use of sanitizers or hand washing techniques, and proper use of masks, as well as maintaining safe distance between persons has to be practiced to control the COVID-19 pandemic. Thank you very much, all of you, for your valuable time.
So thank you, Dr. Manandar. So this concludes the presentation session. So now I'd like to hand over the mic to our respected chair, and to notify, we have Dr. Rakesh Ghimire in person to answer the queries made by the audience related to his topic. Thank you, sir. On to you.
Thank you very much, Dr. Suman. I think we are very hard pressed with time. We have only 10 minutes left as per our schedule. And therefore, maybe we can spare about 5-6 minutes for question and answers, because we have to sum up also. Therefore, what I request is any burning questions, if you have, the audiences, there are almost 330 audiences here still. So it would be nice if you could send some of the questions that you are nagging you. And so then maybe you can have a quick response from the person to whom the question is addressed. So is there any? So there's one question about Dr. Rakesh. How do you define the term good practice? That is one. And another about double mask, significance of double mask. So these are. There was one, I'm not sure who can answer it. It's about vaccination of the children, how important it is. So this may be something when there is a rumor or very likely expectation of third wave, and the rumor is that it may affect children. So this question may be valid for that one. So okay, so Dr. Rakesh, can you answer that?
Thank you. Thank you very much, Professor Dr. Masker, sir. Thank you, the audience, for the question. The question that was asked was, how do you define the good practice? So how did we use this term in our research? So basically, we have asked few questions on to know the practice among the participants. So the 4 questions were, have they breached the lockdown? Have they used the masks while going outside? Have they used any preventive measures when they bring, the groceries for the prevention of the COVID-19? And we have asked for whether they have gone to the crowd or not. So basically, based on these 4 questions, we have tried to evaluate the practice score, and what we found was majority of the respondents followed the recommended approaches for the prevention. And moreover, our study found that there was a very good association between the knowledge and the practice score, and the attitude and the practice score. So that's how we can conclude our research findings, as participants with better knowledge and the participants with positive attitude employed good practices regarding the prevention of this global pandemic COVID-19. Thank you.
Thank you very much, Dr. Rakesh. There's one more question to Dr. Sampurna. Can your research model be used to forecast the COVID cases? Can you answer that? It is from Ashray Manandan.
Okay, thank you for the question. Okay, yes, okay, this model can be used to forecast the COVID cases because multiple linear regression can be used to forecast the COVID cases, but we can also use a cubical spinal function to forecast the COVID cases. But I would like to also mention that the modeling is usually used for interpretation, not extrapolation. Like the model can be also used to forecast the data, but it can be whether predictable or not predictable. That question will be not. It's based on the assumption. So. Moreover, also I would like to address another query that was asked, like whether the spinal, spatial and temporal pattern of COVID can be can have impact on Human Development Index, whether we can do special compact of COVID on Human Development Index of Nepal. So that response is yes. We can also do the special temporal pattern of COVID index based on the Human Development Index of Nepal. For that, we need to compile the data of Human Development Index from Human Development Index reports. For example, Human Development Index, poverty gap, male literacy, female literacy, and we just model the data of with COVID cases, and we can do further analysis, and we can see the result.
Thank you very much. There is one more question maybe related to you.
Okay.
From Satyanarayan Singh, I'm studying PhD in elderly healthcare using GIS application in Nepal in the context of COVID-19. How do we think we can design a spatial framework to improve access for elderly care in poor nations like Nepal?
Like for elderly...
It's a GIS application for a spatial framework.
Yes, like in my analysis also of the map, I use to plot the district of Nepal is using by GIS, and GIS framework can be also used to show the spatial variation of district by showing the map.
Okay.
And for that also, if we can also like separate the age by elderly population and see the COVID trend by elderly population, then we can also create the map using GIS.
Okay, thank you very much. I think these were the questions that I saw in the question answer boxes. Now, to sum up, and I want to thank all the presenters, and particularly our distinguished guest, Professor Sir Peter Harvey, for his excellent presentation, and like showing us how important is the clinical trial, kind medicine that we have been used as a supportive care. Nepal and almost all parts of the world actually came from such trials, that gave us assurance that we can use this medicine when there were no medicine available for treatment or at least supportive care of the COVID cases. And also, I'd like to thank Dr. Pachapati for presenting very comprehensive picture and very large study. And all the speakers. And what I noted was that a very important perspective were brought in these presentations. And for example, when they were talking about molecular testing in Karnali, it was quite different picture than what another person based on Kathmandu and public health laboratory was presenting. You can see the contrast of the capacity of Nepal doing the similar kind of thing. And what Kritika Dikshit highlighted is, in my opinion, is very, very important, because when we are handling with COVID cases, the non-COVID cases are becoming sidelined, and the majority of the problem is sort of not being noticed, either in the government or in the media. That's what it is. And what he's saying is that even for tuberculosis, we may be pushed back for another 10 years in its management because of all the difficulty. Think of lockdown only from one perspective, but if you see the lockdown from those people who have to have directly observed medicine for tuberculosis, how difficult it was for them, and the FCSB's care and everything. So therefore, these are the situations when we go for, we are to justify lockdowns and all, but we also have to think, yes, lockdown, but we have to provide the alternative within the lockdown period so that people's life can be easier. For example, transportation and all this. And similarly, I find that the other implications of these studies, like those varieties of how the tropical diseases which are neglected is become so much of a major problem in those districts explained by Dr. Kayester. And finally, the teaching management also, it was quite interesting, because I believe it was maybe the earlier data that it's about 136 patients Dr. Manandar and team has done. And it shows that only about 10% were needing ICU care of the total number of cases. And only one needed ventilator at that time. So So it seems that if we could do management proper in home care and institutional care before the patient is being hospitalized, many serious critical cases may be avoided or death may be avoided. And probably the high number of serious critical cases and death in the second wave of COVID pandemic is because we have oxygen shortage. So therefore, all our hospital beds and ICU and ventilator and SDUs were affected. Their service were affected because when there were no oxygen, they could not function. So these are the kind of things I think we have to keep in mind when we were preparing. We are preparing for the third wave, and therefore, with these words, because the time is already ceded by ourselves, I again want to thank everybody for this wonderful session, and especially young scientists who are coming up with their researches. And also, I want to thank NHRC to provide and the four.
Thank you, respected Maski sir. I wish to express my personal and on behalf of NHRC family a very sincere gratitude to you for being with us and providing very, very critical appraisals and remarks to our presenters. Now I'd like to request Professor Dr. Gaurav Raj Dhakal, Vice Chair NHRC, to provide token of love to Dr. Rakesh Kimire. So thank you all the presenters for bringing in very comprehensive presentations, streamlining the multiple aspects related to coronavirus and the disease itself. And thank you all to the virtually connected audiences for bearing with us and making the event lively and impactful. And at last, I'd also again like to thank Professor Maske for his time. Thank you all. Please remain connected with us in the next session. Good day. Namaste.
Welcome back. We are ready to begin our next session. Good afternoon and namaste. Distinguished delegates, respected personalities, all the presenters and participants. It's my immense pleasure to welcome you all in this wonderful and insightful session. I am Janaki Pandey, working at Nepal Health Research Council as an assistant research officer and will be a host for this session today on non-communicable disease. I would like to humbly request to Professor Dr. Bhagwan Koirala and Dr. Farindra Baral on the stage to chair the session jointly. I would like to give a brief introduction about our chairs for this session. Dr. Koirala is known for pioneering the open heart surgery program in Nepal since 1997. He also led the Nepal's first heart hospital, Shahid Gangalal National Heart Center, as the executive director. Apart from serving as the executive director at the two national heart centers, Shahid Gangalal National Heart Center and Manman Cardiothoracic Vascular and Transplant Center, executive director of Tribhuvan University Teaching Hospital. Dr. Koirala has also served as the Executive Vice Chair of Health Profession Education HPE Commission formed by the Government of Nepal to draft an HPE bill. He has also facilitated the inclusion of non-communicable disease as the policy agendas in the National Health Policy. He has been awarded with the highest civilian honor for his excellent service and outstanding contribution in the country. He has been awarded with the Suprabal Gorkha Dakshin Bahu Char Birendra Aishwarya Medal for outstanding service in 2001. Suprabal Janaseva Sri 3 from Government of Nepal in 2012. Currently, he holds a position of Head of Department of Cardiothoracic and Vascular Surgery at the Institute of Medicine, Tribhuvan University, Kathmandu, Nepal, and a member of Policy Advisory Committee of the Ministry of Health of Nepal. He also served as a National Co-Chair of Nepal NCDI Puberty Commission and also founding Chairman of Kathmandu Institute of Child Health. Currently, he served as the Chairman of Nepal Medical Council. Similarly, I would like to give a brief introduction about our next chair, Dr. Farindra Prasad Baral. Dr. Baral is a MD in general practice. He is currently working as the Chief of Non-Communicable Disease and Mental Health under the Department of Health Service for 3 years. He has been working for the Government of Nepal under the Ministry of Health and Population in different parts of the country as a district health officer and medical superintendent for 15 years. He also has been honored by the prestigious Prabal Janaseva Sri Medal for his Nobel contribution for the country. We welcome you, sir. In this session, we have altogether 7 presentations and 1 invited talk. In this session, Dr. Sri Karki and Mr. Kiran Paurel will take the notes and Mrs. Uma Kafle will compile the comments. Dear participants, if you have any queries related to this session, please put in chat box. After completion of the presentation, presenter will address your queries. Now, I would like to hand over the session to the chairs.
Thank you, Ms. Janaki Pandey. It's the moderator of these sessions. Good afternoon to one and all present here. I would like to get the session for the non-communicable disease in the 7th National Summit of Health and Population underway. There are a total of 8 presenters, each allotted with a time of 10 minutes. A reminder will be provided for the presenter at 8 minutes. All questions will be entertained at the end of the session for the total of 20 minutes. Now, I would like to request Professor Koirala to proceed further. Thank you very much.
Thank you and welcome my co-chair, Dr. Farindra Baral. Thank you, Ms. Pandey. This is a very important session as the non-communicable disease burden in this country is rising. And there will be 7 very important presentations today. As Dr. Baral outlined the rules for presentation, so we will follow that. And we would start this session by inviting an invited speaker. Very important topic on rheumatic heart disease. And the speaker is no less important. And Dr. Prakash Regmi is the invited speaker for today's session. And I take privilege in introducing him. He was a government job holder for a long time and worked in Beer Hospital as a senior consultant, or chief consultant. For a long time, he worked a very long time in the public health sector, particularly in the prevention of rheumatic heart disease. He led the Nepal Heart Foundation, who has been so instrumental in doing a lot of these preventive works. Dr. Regmi has published numerous papers on rheumatic heart disease and, of course, other non-communicable diseases. And recently, in recognition of his contribution in the work of rheumatic heart disease, World Health Organization Guideline Writing Committee has nominated him as one of the members in the Guideline Writing Committee, which is a matter of honor and privilege for all of us also. So with this short but important introduction, I would like to invite Dr. Prakash Regmi to give a keynote speech on prevention of rheumatic heart disease in Nepal. Thank you, Dr. Regmi.
Thank you, NHRC, for providing me this opportunity. Respected chairpersons, in these 10 minutes, I shall be talking about some aspects of burden of rheumatic heart disease in Nepal. I shall be talking about the introduction, prevalence of rheumatic heart disease in Nepal, the burden in relation to geography and ecological zones, the financial burden. The burden of rheumatic heart disease in Nepal is significant. It still remains a significant public health problem in low-income countries. Children and young adults are affected in their most productive years of life. An estimated 350,000 people die from rheumatic heart disease every year, out of which 133,000 cases are from Southeast Asia. The World Heart Federation has set a goal to achieve 25% reduction in premature death from rheumatic heart disease among individuals below 25 years of age by the year 2025. We call it the goal of 25 by 25 by 25. More than 90% of people living in low-income countries are unaware of the fact that untreated bacterial throat infection may lead to rheumatic heart disease. According to the Global Status Report on Rheumatic Heart Disease, in 2015, rheumatic heart disease was the #1 global cause of cardiovascular morbidity and morbidity in children and young adults. There were more than 32 million existing cases of rheumatic heart disease, with more than 350,000 annual deaths, and more than 500,000 new annual cases of rheumatic fever and rheumatic heart disease. And the dialysis per year was more than 10 million. And the data is also very important that more than 20% of maternal mortality was related to rheumatic heart disease. And today, more than 2 billion children live in rheumatic heart disease vulnerable zone. We call it endemic regions. Well, in Nepal, rheumatic heart disease is the main cause of end-stage heart disease in children. Well, this is the picture of a 13-year-old child admitted in Shahid Gangalal National Heart Center with grossly enlarged heart, damaged valves, and heart failure due to rheumatic heart disease. We see many such children who are fighting with rheumatic heart disease and fighting with death. WHO has described rheumatic heart disease as a neglected heart disease of the poor. In many countries, rheumatic heart disease is neither in the communicable disease list nor in the non-communicable disease list. So it is nowhere in the government's plan and program. In Nepal, it was neglected and still remains a neglected disease. There are no programs addressing the prevention of rheumatic heart disease in Nepal. The government has not included rheumatic heart disease in the NCD plan, as it was advised by the WHO. Well, in Nepal, it is a major pediatric heart problem. Around 1 million existing RSD cases are there in Nepal. An estimated 30,000 people get affected and 3,000 people die prematurely every year from rheumatic heart disease. The prevalence of rheumatic heart disease ranges from 0.8 to 10.2 per thousand children. 10% of all medical admissions are related to rheumatic heart disease. 37% of all cardiac surgeries at the tertiary heart care centers are related to rheumatic heart disease, and 10% of all transcatheter interventions in tertiary heart care centers are related to RSD. More than 1,500 patients go for heart valve surgery every year. Government of Nepal is spending huge amount of money in tertiary care, but there are no programs for rheumatic heart disease prevention. Nepal Heart Foundation, an organization working on RSD, has set a goal to reduce the burden of RSD by 50% by the year 2030 through an initiative named End RSD Campaign Nepal. There are several studies of prevalence of RSD in Nepal, and in Kathmandu, studies shows that the prevalence is declining. In 1990, the prevalence of RSD in Kathmandu Valley was 1.3 per thousand children, and in 2013 it was 0.8 per thousand. So what we see is in the last 25 years, the prevalence went down by 30%. This is the data of Kathmandu city. And the highest RSD prevalence in Nepal, as it has been published, is from eastern Nepal, Sunsari district. The prevalence was found to be 10.2 per thousand school-going children. And this was done by echo-screening method. It was an echo-screening method prevalence, echo prevalence. It is 10 times higher than the clinical screening method. By clinical screening method, the highest prevalence of RSD was found in Jajarkot, which was 7.2 per thousand. So if echo screening was done in Jajarkot, the prevalence would go up to 72 per thousand. So it is very, very high. So what we assume is in Western Nepal, in Karnali zone, that is the most endemic zone of RSD in Nepal. So there is a huge data in process of publication on RSD prevalence. It is a huge national data. It is the data of more than 100,000 school children. The study was done by Nepal Heart Foundation during the duration of 5 years. It covers 25 districts and all 7 provinces and all 3 ecological zones. And the method was auscultation followed by echocardiography, and this study is in the process of publication. This study shows that in district-wide distribution, the highest prevalence was seen in Kalikot, which was 5.47 per thousand, and the lowest was seen in Solukhumbu. Province-wise distribution of RSD, as shown in this study, it was found that the province number 6 was the highest, where it was seen 3.45 per thousand in province 6, which was followed by province 2, and the lowest was seen in province 3. According to the ecological zone-wise distribution of RSD, the study shows that rheumatic heart disease is the highest in Tarai zone, followed by Pahad, and the lowest in Himal. As it is concerned to congenital heart disease, the situation is just a reverse. The congenital heart disease was found to be highest in Himal, which was followed by in Pahad, and the lowest in Tarai. The hospital admission data for RSD shows a declining trend. This is data from Syed Gangalal National Heart Center. The RSD admission is declining, whereas the admission for coronary artery disease is on rise. As far as the surgery for rheumatic heart disease is concerned, it still remains high, and more than 1/3 of the surgeries in these centers are for rheumatic heart disease. The data for mother and child health and rheumatic heart disease is very, very interesting, because we do not have such data. We take data from our neighboring country, India. In India, the situation is 1% of all pregnant women have cardiovascular disease, and out of them, 70% have rheumatic heart disease. More than 20% of all maternal deaths during delivery of child are due to rheumatic heart disease. 35% of low birth weight is attributed to rheumatic heart disease. 7% of preterm births are due to RSD. And we know that low birth weight and preterm birth are major causes of infant mortality and morbidity. This is data from India, and we assume that the similar situation exists in Nepal. So what we see is in mother and child health care, we miss rheumatic heart disease. And this is very important that we should include rheumatic heart disease in the mother and child health care protocol to reduce the mortality of mother and child. The government of Nepal is investing huge amount of money in rheumatic heart disease, especially in the tertiary, in the curative aspect. Heart valve surgery is free of cost in Nepal. This was since 2016 AD. And for a single valve replacement, it is around 250,000 rupees. Government is financing for all sort of surgeries related to rheumatic heart disease, all sort of valve replacement. And PTMC is also free of cost, which costs around 60,000 rupees, and there are almost 500 cases every year. And heart valve surgery, almost 800 to 1,000 cases of heart valve surgery every year. So government is financing more than 60 million rupees annually in RSD treatment only. And even there is distribution of free penicillin V tablet for 1 month to RSD patient. And this distribution of free oral penicillin led to discontinuation of benzathine penicillin G injection. So all the patients who were on oral penicillin, who were on injection benzathine penicillin, which was very cost effective, the patient were switched over to oral penicillin, and this was the beginning of underuse of benzathine penicillin G, which has led to recurrence of rheumatic fever in many cases in Nepal. In Nepal, the government of Nepal doesn't have any prevention program, especially primary and secondary prevention, and there is no RSD registry, which is very, very necessary. To summarize my talk, the burden of RSD in Nepal is very high, causing significant morbidity, mortality, and financial loss. There are no preventive programs at national level to prevent rheumatic heart disease. Initiation of RSD prevention and control program with RSD registry at national level is necessary to reduce the burden of this disease. Thank you. Thank you very much.
Thank you very much, Professor Prakash Raj Regmi, sir. Actually, you have presented very well, excellent presentation on the topic of burden of rheumatic heart disease in Nepal. Now, I would like to invite Mr. Rajaram Dhungana to present on 20 years trend and 5 years projection of hypertension in Nepal.
Everyone, I am Rajaram Dungana with my co-authors Achit Pandey and Nitin Shrestha. We would like to present 20-year trend and 5-year projection of hypertension in Nepal. It was a systematic review and meta-analysis. For next 10 minutes, I will be sharing you about the background, methods, finding, and conclusion of these studies. We are aware that hypertension is the leading and preventable cause of cardiovascular disease and death globally. Worldwide, 45% of death due to heart disease and 50% of death due to strokes are attributable to hypertension. If we talk about the burden of hypertension in Nepal, recent studies reported largely varied finding on hypertension prevalence. You can see in the given figure, the prevalence of hypertension reported in individual studies range from 7% to 39%. Along with that, we don't have any study that provided a relevant estimate on trends of prevalence, treatment, and control of hypertension in Nepal. Therefore, we conducted a systematic review and meta-analysis and systematically sourced the 6 databases, including InVest, Web of Science, CINAHL, and Maryland. We included this study conducted between 2000 and 2020 and applied the random effect model to estimate the prevalence of hypertension in its 5-year interval. Additionally, we used the linear meta-regression analysis to predict the prevalence of hypertension, awareness, treatment, and control for 2025 in Nepal. As you can see in the given figure, we initially screened 2,600 records available in 6 databases, as well as the website of the different government agencies. We went through the different steps of systematic review and finally included 23 studies for our analysis. The pool prevalence of hypertension for 2020 was 32% in overall population. The prevalence of hypertension in male was significantly greater than the prevalence of hypertension in female. If we talk about the hypertension awareness, 50% of those individuals having hypertension were aware about their condition, and less than 1/3 of the hypertensive individuals were taking antihypertensive medication. If we talk about the hypertension control, among those who were taking antihypertensive medication, far less below 50% had controlled blood pressure, and which was around 8% in total hypertensive individual. If we compare the different parameters of hypertension between 2000 and 2020, the prevalence of hypertension was increased by 6% in overall population. The rate of increment in the prevalence of hypertension in male was significantly larger. Likewise, the prevalence of hypertension awareness and hypertension treatment was also increased by around 10% during 20 years period. But if you see the table, the rate of hypertension control was remain unchanged during last 20 years period in Nepal. You can see in the given graph, there is a huge gap between the prevalence of hypertension predicted for 2025 and the target set for 25% relative reduction of hypertension by 2025. If the linear trend exists or continue, then the prevalence of hypertension for male will increase by 1% point each year and will reach to around 47% by 2025. But the targeted prevalence of hypertension for 2025 is around 23%. The trend is similar for both male and female. From this finding, we can conclude that the prevalence of hypertension has increased significantly during last 20 years, and there is a huge gap between the parameter we estimated for 2025 and then the target set for 2025. But the rate of hypertension control remained almost unchanged during last 20 years. From this finding, we would like to emphasize that Nepal should increase the population level in screening of blood pressure so that we can identify and detect the hypertensive individual and enroll them in anti-hypertensive treatment and management. We would also like to emphasize on increasing the adherence of the anti-hypertensive treatment and lifestyle modifications so that we can increase the overall hypertension control rate in the population. So thank you so much for listening.
Thank you very much, Mr. Rajaram Dungana. And he has also presented very nicely regarding the projection of hypertension in Nepal. And now, without further ado, I would like to call upon Mr. Sanju Gautam to present on diabetes among TB patients and its impact on TB treatment in Southeast Asia.
Subhajanatha, namaste. First of all, I would like to thank NHRC for providing me this opportunity to present my paper, Diabetes Among Tuberculosis Patients and its Impact on Tuberculosis Treatment in South Asia, a systematic review and meta-analysis. Now I'd like to move forward, talking about the background. Diabetes is a world 7th leading causes of the death with a global prevalence of 9.3% and Southeast Asia prevalence of 8.8%. According to IDF, in 2019, we had approximately 463 million cases, which is scheduled to be like 700 million in 2045. That's almost an increase. And talking about the tuberculosis, it's also considered as the top 10 causes of death worldwide with a global incidence of 10 million. And it's affecting mostly the Southeast Asia country where are there 44% of the world TB cases. Since diabetes and TB comorbidities has been evolved during the present day, so it's of utmost importance to find out what is the global prevalence in South Asia. The global prevalence has been estimated around 15.3%, whereas the prevalence of diabetes mellitus among TB in South Asia is not explored yet. So since these studies mainly deal with diabetes and tuberculosis prevalence, we are going to examine what is the prevalence of diabetes among Southeast Asia, especially in the South Asian region. And also the researchers have shown that diabetic person have 2 to 3 times higher risk of developing TB. So this study will provide light about what can be done to achieve the in-TB strategies. The objective of this study is to assess the pool prevalence of diabetes mellitus among tuberculosis patients in South Asia, whereas the secondary objective is to estimate the magnitude of the impact of diabetes mellitus on selected tuberculosis treatment outcome. Moving ahead, considering the methodologization, we had searched our studies in 3 databases, PubMed, INVEST, and Sinahal for all the observational studies. We added to PRISMA guideline and PICO framework within our systematic review and meta-analysis. For assessing the bias, we use Newcastle Ottawa scales. Since there was a chances of high heterogeneity in this study, we used random effect meta-analysis model to assess the prevalence of the study and fixed effect meta-analysis model to assess the association between diabetes and tuberculosis treatment outcome. Publication bias was assessed using funnel plot and eager test, and subgroup analysis and sensitivity analysis was further done. Heterogeneity was also assessed in this study. Our results depicted that we had in total 65 studies, including all the studies that fulfilled our inclusion criteria in the prevalence, and we have almost 9 studies that assess the treatment outcome. Moving more ahead in the results sections, out of 65 studies in the prevalence, we have 47 studies from the India, and there were no studies from the Maldives and Afghanistan. The forest plot depicts that the tuberculosis, the diabetes prevalence among tuberculosis patients in South Asia was 21%, ranging from 24% in Sri Lanka and 11% in Bangladesh. It's quite high, the prevalence of Southeast Asia. Also moving forward, we also analyzed the subgroup analysis of prevalence of diabetes in people with tuberculosis to determine whether the prevalence has been affected by the groups or not. While doing the subgroup analysis, we found that the study which took samples as less than 300 has a higher prevalence of 23% compared to the studies we had taken sample size of 300 or more. Similarly, those studies which were population-based has the higher prevalence. Similarly, those studies which has the both population-based and hospital-based has a higher prevalence, 24%, compared to the studies which have taken the hospital-based studies. Also, we can see that the studies including both adults and children have lowest prevalence of 19% compared to the studies which have taken adults only. Since the study has a very high prevalence in the India region, to explore more, we did subgroup analysis within the regions available in the India, and that shows that southern region has the highest prevalence compared to any other regions in the India. Publication bias detected that we had sufficient information to show that the publication bias was in this study, which was further confirmed by the Eiger test and funnel plot. To assess the heterogeneity of the study, we did meta-regression analysis to find out the prevalence of diabetes among tuberculosis patients. Though we take different variables like period of data collection, sample size, country, TB burden in the country, and other variables, we were not able to assess the heterogeneity. However, the diabetes diagnostic methods explored 9.96% of the heterogeneity. Moving forward to the treatment outcome, we found out that tuberculosis patients with diabetes has an approximately 2 times higher odds of mortality compared to the patients without diabetes. It also has a heterogeneity of 19.40%. Similarly, the patients, TB patients with diabetes have a 1.65 times higher risk of treatment failure compared to the patients without TB diabetes. However, our results did not show any significant difference between relapse and multi-drug resistance tuberculosis. Despite a lot of findings, we also had some limitations that would have affected our results. Main limitations was we only included the English language studies in this study, and we could not assess other variables like education, family income, religious and cultural factors, which could have highly affected the prevalence and also the heterogeneity. In conclusion, we can say that we found a very high prevalence of diabetes mellitus among tuberculosis patients in South Asia region. Therefore, further studies with larger sample size can be warranted, and bidirectional screening could be a major breakthrough to find out the cases earlier and do the treatment properly. So here are the author names. Thank you so much.
Thank you very much, Ms. Sanju Gautam. She has already presented diabetes among the TB patients and its impact on the TB treatment in Southeast Asia. As I already mentioned, all questions will be entertained at the end of this session. Now I would like to request our fourth speaker, Mrs. Anju Bhattarai, to speak on her topic, that is knowledge on breast cancer and screening patients among the women.
Namaste everyone, I am Anju Bhattarai. Today I am going to present my research paper on knowledge on breast cancer and screening practices among women in Siddharthanagar municipality of Rupandehi, Nepal. Here is the outline of my presentation. Introduction. With the epidemiological shift from communicable disease to non-communicable disease, breast cancer is becoming one of the most common cancer among women of both developed and underdeveloped countries. And similarly in Nepal, it is also second most commonly caused cancer among women. According to annual report of DOHS, total number of breast cancer cases were 2,033 for the year 2075 and 76. And also the population breast cancer registry has not yet been completed. So the actual incidence rate as well as burden of disease in the country still remains hidden. Even though the incidence rate of breast cancer is high in high-income countries, the mortality is found high in low-income countries, which is depicted in the picture. And for a resource-limited country like Nepal, it is focusing on public awareness and strengthening screening services can help to reduce the burden of disease. There are very limited number of studies undertaken on the knowledge and practice of breast cancer screening among women of Nepal. Rationale for my study, evidences shows that poor knowledge of breast cancer have usually been associated with patient delay in seeking help, making treatment less effective and minimal survival rate. Along with that, increasing incidence and having no established national screening program for breast cancer stresses the greater need for study to assess knowledge and screening practices so that more evidences can be generated for the further planning in the same area. The general objective of my study is to assess the knowledge of breast cancer and screening practices among women in Siddharthanagar municipality of Rupandehi. The specific objectives of my study are to assess the knowledge on risk factor, symptoms, and treatment of breast cancer, to assess knowledge on screening methods of breast cancer detection, and to find out the practice of breast cancer screening. Methodology used for the study was descriptive cross-sectional, study method was quantitative, and study area was Siddharthanagar municipality of Rupandehi, Lumini province, and my study participants were women of age above 20 years. Here is my sampling framework where 4 wards out of 13 wards were selected of Siddharthanagar municipality using simple random sampling. Population proportional to size sampling was done for the selection of population within each ward, and systematic random sampling was done for the household selection for interview. Sample size calculation was done using a formula n equals to z square pq by d square, where with the 95% confidence interval, 50% estimated proportion in the population, and 7% margin of error, sample size was 196. Sample size was calculated for finite population since there were only 31,810 female of age above 20 years in the Siddharthanagar municipality of Rupandehi, and after adding 10% non-response rate, the final sample size was 213. Data collection was done using face-to-face semi-structured interview, and the tool used was a self-developed questionnaire through various references. For the validity and reliability of the questionnaire, it was developed after intensive literature review and references from previously conducted studies was taken, and the developed tool was reviewed by the supervisor as well as expert for the validity of the questionnaire. Preliminary testing among 10% sample in similar setting of non-study area to test reliability and clarity of the instrument was also done to avoid information bias. Objective of the study was clearly explained to the participants, and researcher herself was involved in the data collection and analysis. Data management and analysis, data entry was done in Epidata version 3.1. Data analysis was done using IBM Space's statistical version 20. Descriptive analysis of the data was done. Ethical consideration, ethical approval was taken from Institutional Review Board of IBM. Respondents were clearly informed about the aims, objective, and purpose of the study. Written informed consent was also taken from respondent before taking interview, and privacy as well as confidentiality of the participant was maintained. Moving toward results, majority of my participants were from age group 20 to 40 with mean age of 39.09 and standard deviation of 12.92. 83.6% of the participants were married. Moving toward ethnicity, 37.1% of them were from Brahmin ethnicity, while 22.1% were from Madhesi ethnicity. Talking about religion, 87% of the participants followed Hinduism. Occupation, slightly more than half of the participants were housewife, while 20.7% were self-employed. Moving toward educational status of the respondent, nearly a quarter of them were from had attended higher secondary level of knowledge, and 15.5% had attended primary level of knowledge. Family type, 54.5% belong to joint family. And this shows the socio-demographic characteristics of the respondent. Now moving toward knowledge, out of total 7 participants, only 75.6% had ever heard of breast cancer. And the source for information for 45.4% of the participant was friends and relative, while for 18.1% it was radio and television. Knowledge on breast cancer was assessed using questions about treatment methods, risk factors, and screening methods available. The maximum attainable score was 18, and people who scored 0 to 9 were considered to have poor knowledge, 10 to 13 were considered to have satisfactory knowledge, and 14 to 18 were considered to have good level of knowledge. From the analysis, so it was found that 85.7% of them had poor level of knowledge and only 1.9% had good level of knowledge about breast cancer. Here are some of the response of the participants. Moving toward breast cancer screening, out of 75.6% who had heard about breast cancer, only 16.8% had ever heard about breast cancer screening. Now, the knowledge of screening was assessed using questions regarding methods of screening and their techniques. The maximum attainable score was 8. People with score 0 to 4 were considered to have poor level of knowledge, 5 to 6 were considered to have satisfactory level of knowledge, and 7 were considered to have good knowledge. From the analysis, it was found that 48.1% had poor level of knowledge, while 40.7% had satisfactory level of knowledge. Here are some response of the participants. Moving toward practice, 16 out of 18 people were found to be practicing breast self-examination. 3 out of 22 people who knew about clinical breast examination were found to be practicing clinical breast examination. And talking about mammography, only 7 out of 11 people were found to be practicing mammography after the age of 40 years. And those who were practicing it, the reason behind it was health personnel recommendation and their own initiative for 42.9% of the participants. And those who were not practicing mammography stated the reason behind it to be not having any problem in the breast by 62.7% and not having knowledge about it by 37.3% of them. Conclusion, knowledge on breast cancer and screening as well as screening practice was found low among the participants. Recommendation, it would be necessary to include screening mammography in the recently commenced National Health Insurance Scheme as is practiced in developed countries. The participation of non-governmental and charitable organizations in creating awareness about breast cancer will also be helpful in solving these problems. Here are my references. Thank you.
Thank you, Anju. I think we will move on with our schedule. The next presenter is Pragya Shrestha. She will be presenting on treatment adherence among patients undergoing hemodialysis of selected hospitals of Rupandehi. So go ahead, Pragya Shrestha, please.
नमस्कार सबैजनालाई स्वागत छ आजको प्रेजेन्टेसन्समा मेरो टपिक रहेको छ ट्रिटमेन्ट एडरेन्स एमोङ पेसेन्ट्स अन्डरगोइङ हेमोडायलासिस अफ सेलेक्टेड हस्पिटल अफ रूपन्देही नेपाल द अथर्स फर दिस स्टडी आर myself Pragya Shrestha and Neelam Shrestha, Icha Rana. We are from the Universal College of Medical Sciences, Bhairua, Rupandehi. In background, chronic kidney disease is a worldwide public health problem. In Nepal, patients with CKD are increasing. Around 30,000 people are suffering from kidney failure in Nepal. About 3,000 new patients are added each year. There are nearly 39 dialysis centers in Nepal. Out of these, 24 services are outside Kathmandu Valley. It is estimated that the prevalence of CKD is around 10.6% in urban areas of Nepal, and the three most common causes for CKD in Nepal are diabetes mellitus, glomerulonephritis, hypertension. According to Department of the Health Services record, majority of the patients utilizing the services were the CKD patients. In the fiscal year 2072-73, total 11,648 patients received free hemodialysis service. Expect of them, 148 received support from kidney transplantations, 818 received peritoneal hemodialysis. Globally, 10% of the population is affected by CKD and millions die each year because they don't have access to affordable treatment. Worldwide, the estimated prevalence of CKD varies from 7% in South Asia, 8% in Africa, 11% in North America, 12% in Europe, 13% in Canada and Australia, 14% in USA, 16% in UK and Singapore, and 17% in Germany. The CKD entails significant changes in the patient's life. Adherence to treatment plays a role in the management of the CKD. In developed countries, approximately 50% of the patients with CKD follow treatment. In developing countries, poor treatment adherence threatens to any efforts of effective management of CKD. Non-adherence to hemodialysis treatment is common in leading to considerable deteriorations of the disease prognosis and enhanced healthcare expenditure. Promotions of adherence is one way to prevent consequences of the illnesses and to enhance patients' quality of life and to reduce costs on medical treatment. As for adherence is the crucial factor in determining the morbidity and mortality of hemodialysis patients. Hemodialysis schedule, food restrictions, diet restrictions, and medicine adherence are four important areas to find out the level of adherence. As for the study was conducted to find out the level of treatment adherence among hemodialysis patients and to find out the association between treatment adherence and socio-demographic characteristics and patients' clinical informations. The clinical informations includes comorbidity, durations of the hemodialysis treatment, frequency of the hemodialysis in a week, and durations of the hemodialysis in a session. Now we are going to discuss on methodology part. A cross-sectional descriptive study was conducted to find out the hemodialysis adherence among 118 hemodialysis patients of Universal College of Medical Sciences Teaching Hospital and Crimson Hospital, Rupandehi. The enumerative sampling was used. There were 90 patients in UCMS TS and 35 patients in Crimson Hospital under hemodialysis. The total number of the patients were 125. The patients who had completed dialysis session at least 3 and more than 3 months were included. The semi-structured interview schedule was used. It was developed based on in-stage renal disease adherence questionnaire and literature review. It included questions related to socio-demographic characteristics, general clinical information, hemodialysis schedule, dietary restriction, food restriction, and medicine adherence. The data was collected from June 16 to August 2nd, 2019. Only 118 patients were included for the study due to the death of the 7 patients during data collection period. Ethical approval was obtained from Institutional Review Committee of Universal College of Medical Sciences with reference number UCMS IRC 127-19 Administrative approval was obtained from UCMS, TS, and Crimson Hospital when written informed consent was obtained from voluntarily from each respondent by clarifying the objectives of the study. The data was analyzed by using descriptive and implicit statistics with SPSS software version 16. Now we are going to discuss on results. The table 1 shows patient socio-demographic characteristics. 44.9% of patients were in the age of the 40 to 59 years. 61% patients were male, and 57.6% patients were from rural area, and 50.8% patients were from nuclear family, and 33.1% of the patients were educated in basic and secondary educations. 82.2% patients were living with spouse, and 97.5% patients were unemployed. And 62.7% patients had inadequate family monthly income for hemodialysis expenditure, and 97.5% of patients had availability of the transportations to reach hemodialysis center. 87.3 patients had durations of the had less than 2 hours to reach the hemodialysis center, and 80.5% of patients had caretaker to reach the hemodialysis center. Now table 2 shows patient general clinical informations. 89% of the patients had comorbidity, and 48.3 patients had less than 12 months as the durations of the hemodialysis treatment. And 82.2% patients had 2 times hemodialysis in a week. 94.1% of the hemodialysis patients had taken 4 hours in a session. Now table 3 shows the patient's hemodialysis adherence, and generally 56.8% patients were adherent to hemodialysis treatment. 43.2% patients were non-adherent. In hemodialysis schedule, 62.7% patients were adherent, 37.3 patients were non-adherent. In diet restrictions, 77.1% patients were adherent, and 22.9% patients were non-adherent. In food restriction, 74.6% were adherent, 25.4% were non-adherent. In medical applications adherence, 48.3 patients were adherent, and 51.7% patients were non-adherent. In overall, the 77.1% patients were adherent, high adherent in diet restrictions. Now table 4, it shows association between hemodialysis adherence and socio-demographic characteristics. Age and sex were not significantly associated with the hemodialysis adherence. The p-value were 0.500 and 0.117 respectively. Education's level was statistically associated with the hemodialysis adherence. The p-value is 0.020. The marital status and current employment status were not significantly associated with the hemodialysis adherence. The p-value 0.319 and 0.406 respectively. Adequacy of the family monthly income for hemodialysis expenditure was statistically associated with the hemodialysis adherence. The p-value is 0.007. The durations of the time to reach the hemodialysis center was not statistically associated with the hemodialysis adherence. P-value is 0.160, but the presence of the caretaker to reach the hemodialysis center was statistically associated with the hemodialysis adherence. The p-value is 0.057. The comorbidity and frequency of the hemodialysis in a week were not statistically associated with the hemodialysis adherence. The p-value is 0.412 and 0.532 respectively. Durations of the hemodialysis treatment was also not statistically associated with the hemodialysis adherence. And in conclusions, based on the results, the hemodialysis adherence among the patients is good in general. The adherence to the hemodialysis schedule, diet restrictions, and food restrictions are also found good, but medicines adherence among them is need to be considered to make good. The hemodialysis adherence is influenced by education, adequacy of family monthly income, and presence of the caretaker to reach hemodialysis center. It is not influenced by the age, sex, marital status, employment status, time durations to the hemodialysis center, comorbidity, durations of the hemodialysis, and frequency of the hemodialysis in a week. The study emphasized on educating patients to follow hemodialysis schedule and medicines as prescribed. The study on the assessment of the associated factors for medicine adherence among hemodialysis patients should be conducted in a small or large scale. Thank you.
Thank you. I think we went little over time here. So next time I would like to request our timekeepers to be more accurate on timekeeping. Let me invite next speaker, Nirjala Lakshmi Madhikarmi. She is going to talk about the effect of osmotic fragility on oxidative stress and perceived stress scale, status of diabetic individuals. Nirjala Lakshmi, please.
Namaste, one and all. I am Dr. Nirjala Lakshmi Madhikarmi, and today I will be presenting the effect of osmotic fragility on oxidative stress and perceived stress scale status of diabetic individual. And this is my abstract. So I, along with Professor Madhav Gautam, we both have contributed for this article, and this is the abstract. So now let us know about the diabetes. And diabetes, we all know that it is one of the most prevalent and the non-communicable disease worldwide. And this disease, it is characterized by the hyperglycemia, and the hyperglycemia that it results from the defect both or might be or from the insulin secretion or from the insulin action, or both we say. And the chronic hyperglycemia, generally they are associated with number of diseases, both microvascular and the macrovascular complications, and it affects various organs, for example eyes, kidneys, then nerves, heart, blood vessels. So the cell membrane injury. So now let us know about the cell membrane injury, how the diabetes causes. So cell membrane injury, it is also an important mechanism for the pathophysiological changes which occurs in diabetes. And in this paper, we have done work in both in the osmotic fragility, then perceived stress scale, as well as the antioxidant and the free radical parameters. So during the hyperglycemia, the osmotic fragility of erythrocyte, they are increased. And this is the slide which shows the global diabetes data report from 2010, and it is also projected till 2045. And here you can see this, this is the map of India, and nearby India, we can see the map of Nepal. And the data, WHO data, shows that the 2019 data, so 88 million people in 2019, they suffered from diabetes. And in the 2030, so 115 million people, they have been, they have projected that 115 million people, they might suffer from diabetes. And in the year 2045, it is expected to be increased by 135 million. So the increase ratio, it is, the increased percentage, it is 74% overall. And it is expected that 1 in 5 adults with the diabetes, which lives in this area, that is Southeast Asia, and 1 in 4 live births, they are affected by the hyperglycemia in pregnancy. So now let us know about the stress. So stress, we all know that they have affected throughout our life, and it is an important reference point in all the health studies, and it is also related with an individual's general health status as well as different illnesses, which includes mental disorders, cancer, cardiovascular diseases, drug abuses, and chronic diseases. And in our study, we have assessed the stress through the Cohen's perceived stress, which includes the question, which includes 10 different questions. So a questionnaire was given to our patients as well as the healthy controls. And according to the Cohen's stress scale, there are they have divided the scores into 3 categories. So 1 is to 13 if they score, so that falls under the average stress, whereas the stress scale 13 to 20, it is in the medium stress. And suppose if the scoring, it is more than 20, it says that the person or the individual, they might be suffering from high stress. So now let us know about the osmotic fragility. So what is osmotic fragility of the erythrocytes, which we are interested in? So the osmotic fragility test, it is for measuring the erythrocyte resistant to the hemolysis when they are exposed to various level of dilutions of the sodium chloride or the saline solution. That is, they are done from 0.1% to the 0.9% of NaCl concentration. So in the normal healthy individual, the osmotic hemolysis, it begins at about 0.48% and it ends at about 0.36% of sodium chloride solution. And the stress, it affects the deformability and the fragility of RBC, which in turn affects both macro and the microcirculation. Now, this is the slide which shows the various here. Free radical, FR stands for free radical and AO stands for antioxidants. Since our study, it also revolves around the free radical antioxidants also, apart from the osmotic fragility and the Cohen stress scale. So in this figure, you can see the free radical ratio or the amount, it is higher. So here the oxidative stress, it is disbalanced. And here in the right figure, we can see that the free radical, the amount here, it is lesser than the antioxidant supplemented here. So this shows the balance between the free radical and the antioxidant amount. So we can say that oxidative stress, it is the condition or it is defined as the imbalance which is formed because of the formation of the free radicals or the reactive metabolites, oxidant, and their elimination by the protective mechanism, which is also known as the antioxidant system. And this is a slide which shows the various free radicals. So there are a number of free radicals found in nature as well as in our body. So example of free radicals, they are superoxide anion, hydroxyl ion, hydrogen peroxide, nitric oxide. And the free radical, these are an atom or an ion or the molecule which possesses an unpaired electron in an outer orbit, and they are so reactive that whatever comes in between, they makes them as a free radical. Suppose if they react with our biomolecule, they can convert various biomolecules into free radicals so that a chain reaction occurs. And the free radical, they can alter the lipid, proteins, carbohydrates, or DNA and have been implicated in diabetes as well as several other human diseases. And now let us know about the antioxidant system in our body. So there are a number of antioxidant system, antioxidant enzyme, non-enzymatic antioxidant, the nutritional supplements here. So these are various enzymes here. These are the various antioxidant, non-enzymatic antioxidant, and these are the endogenous factors which are present in our body and they act as an antioxidant. Coming to our objective, we have number of objectives. So to categorize the perceived stress using the Cohen stress scale is number 1 objective. Number 2 objective is to determine the osmotic fragility using 0.1 to 0.9 sodium chloride solution, and also to estimate the lipid peroxidation by using the thiobarbituric acid reactive substances, then lipid hydroperoxide and the nitric oxide. And nitric oxide, it is estimated in 2 forms, that is NO2 and NO3, nitrite and nitrate form. And also we have estimated the antioxidant vitamins, both the hydrophilic and the hydrophobic, both the vitamin C and vitamin E have been estimated in the diabetic as well as the healthy individuals. And this is the materials and methods section. And we have included, our specimen was whole blood because for the osmotic fragility, we required the anticoagulated blood, that is EDTA anticoagulated blood we require, as well as for the various antioxidant and free radical parameters, we require plasma. And the T-bars, that is thiobarbituric acid reactive substances, or we can also say the lipid peroxidation. So it was assessed by Satoho method, and lipid hydroperoxide was assessed by Jiang method. And the nitric oxide, that is NO2 and NO3 both was estimated by Cortas and Wakid method. Similarly, the antioxidant vitamins, that is, the vitamin C was assessed by Nettleson method, vitamin E was assessed by the Baker and Frank method, osmotic fragility was assessed by the Parpart et al. Method, and it was the NaCl solution 0.1 to 0.9% were estimated. Similarly, the statistical analysis was made using the MS Excel. We had entered our data in the MS Excel for the safe purpose, and the estimations or the analysis was done using the SPSS. And our study design was the case and control, since we have a diabetic case and the control had the controls. And the study population was diabetic patient. And the diabetic patient, it included all the cases, whatever the 150 patient we had collected. They were not the old cases or the fresh cases. So whatever patient had come to our hospital, Kantipur Dental College and Teaching Hospital, General Hospital. So we collected all the patient sample, and the sampling method was, it was a random sampling method. So sample size is 150 diabetic case and 150 healthy control. So according to the various estimations, we did the antioxidant system, then various lipid peroxidation parameter, then we did the osmotic fragility, and we also gave them a questionnaire of Cohen stress scale. So we found that both the osmotic fragility as well as perceived stress scale, it was increased significantly in the diabetic individual when we compared with the healthy subject, and the raised osmotic fragility of erythrocyte and perceived stress scale, the oxidative stress was increased significantly, and it also showed the diminished antioxidant status in the diabetic subject. Now, this is a table which shows the various parameters here. These are the antioxidant C and E, vitamin C and E, then these are the lipid peroxidation parameter T bars, that is high barbituric acid reactive substances, or we can also say malondialdehyde or lipid peroxidation, and this is lipid hydroperoxide, then these are the nitric oxide, NO2 and NO3, and this is the Cohen.
Thank you. I think we need to keep up with time anyways. If they cannot produce video in time, then I think it's a limitation anyways. So let me move on with the next topic. This will be a study of factors associated with health-related quality of life among outpatients with type 2 diabetes mellitus. The presenter will be Rojina Tanukar. Go ahead, please.
Namaste and warm greetings to all. Respected Executive Member Dr. Pradeep Kewadi sir, Chief Research Section Dr. Meghna Dhimal sir, and Senior Research Officers Dr. Vishnu Marasini sir and Bihanga Mr. sir, and all the respective staffs of the NHRC and all the participants and attendees who are presented virtually in this summit. I would like to welcome you all in my presentation. Now, I hope you'll enjoy my presentation. The title of the presentation is Study of Factors Associated with Health-Related Quality of Life Among Outpatients with Type 2 Diabetes Mellitus. The authors are Rojina Tanukar and myself, and the co-authors are Professor Dr. Nilambar Jha, Associate Professor Dr. Rajendra Karki, Assistant Professor Dr. Khemra Sharma, and the affiliation is School of Public Health and Community Medicine, BPKHS, Taran. These are the outline of the content. Outline of the contents. Background: diabetes is a major health issue that has reached an alarming levels. Today, nearly 500 million people are living with diabetes worldwide. It is estimated that 463 million people have diabetes, and this number is projected to reach 578 million by 2030 and 700 million by 2045. It is a major public health problem that is approaching epidemic proportions globally. It is accompanied by marked reduction in patients' quality of life (QL) and leads to higher disability-adjusted life years and most years than most diseases. Diabetes is increasingly growing metabolic threat in this contemporary era, and it is a serious health problem that has threatened the quality of life of patients and can lead to acute and chronic complications. It is also one of the leading causes of mortality and morbidity among non-communicable diseases in Nepal. It is a demanding disease, so it can affect our life in many ways. Health-related quality of life (HRQOL) is an important outcome used in a wide variety of medical research to certain aspects of well-being in settings of health and disease. The objectives of the study: general objective, to assess the factors influencing the health-related quality of life of outpatients with type 2 diabetes in Diabetic Thyroid and Endocrinology Care Center, Kupandol, Lalitpur. The specific objectives are to find out association between the socio-demographic factors with health-related quality of life and to identify association between complications of diabetes and health-related quality of life. Methodology, materials and methods. Cross-sectional study design was used in the study. Population and participants. Patient diagnosed with type 2 diabetes mellitus more than 10 years was included in the study. Methodology, study area. The study was conducted at Diabetes, Thyroid and Endocrinology Care Center, Lalitpur, and the study period was conducted over a period of 6 months from 1st September 2019 to 29th February 2020. Sampling technique. Purposive sampling technique was used to select the respondents, and the clinic was also selected purposively. Data collection tool and techniques. WHO QOL brief instrument was used to collect the data on quality of life. This tool was rated in Likert scale ranging from 1 to 5, and data was collected with aid of face-to-face interview. Data management and statistical analysis. Data handling. The data obtained was entered and coded in Epidata version 3.1 and then transferred into statistical package for social sciences 11.5 version for the statistical analysis. Numerical coding list was prepared before entering the data. Monitoring. Data were entered after every day work and was entered. The data was cross-checked in every day entries. Statistical methods used. The data were presented in percentage, median, and interquartile range. Data were summarized using the frequency distribution tables. Bivariate association was applied to assess the association of the outcome variables in various independent variables using Mann-Whitney test, Kruskal-Wallis test. For the calculation of the sample size, it was calculated by taking the mean and the standard deviation from the study done by Mishra SR et al. 2015. The mean and the ST of the physical health domain was 50.74 with standard deviation 11.83 using the formula Z square, sigma square, and E square. Sample size was calculated. The calculated sample size is 263 considering the margin of error plus minus 1.5 and 10% non-response rate. Validity and reliability. To ensure validity and reliability of the study, questionnaires were prepared under the strict supervision of my study supervisor, and the questionnaire were translated in Nepali and from English under the supervision of guides and experts. Validated Nepali version of WHO BREF questionnaire were used. Ethical consideration. Ethical clearance was taken from the Institutional Review Committee, BPKSS Dharan, and the approval number is IRC 1550019. Informed consent was taken from each of the respondents. All of the information about the respondent in the study was kept confidential. The participants were assured of the confidentiality and they were free to withdraw themselves from the study at any point of time. Now moving towards the result section, table 1 showed the socio-demographic characteristics of the respondents. The mean is 64.09 with standard deviation 10.22. Gender. The ratio between the number of male and female were found to be similar. Most of the respondents followed Hindu religion with 76.8%, followed by Buddhist, Christian, and Muslim. Most of the respondents were of Newar ethnic group, that is 58.2%. Majority of the respondents lived in an urban area, 93.5%, and most of them were married, followed by widow, unmarried, and divorced or separated. Most of the family respondents lived in a joint family. Coming towards the education status, 1/4 of the respondents, total respondents, have no education. The mean of the family income is 1,20,804.56 with standard deviation 2,50,362 plus 0.10. In occupation, most of the respondents were found to be the homemaker, that's 41.8%, followed by self-employed 24.4%, followed by retired, government employee, non-government, and unemployed. Now, table 2 shows the disease profile of the respondent. The mean duration of the duration of the disease is 15.93 with standard deviation 5.86 years. Among the total respondents, 3/4 of the respondents had chronic diseases present, and those were hypertension, depression, heart disease, kidney disease, and cancer. Among the respondents who had chronic disease, 39.2% had complications present, and they were diabetic retinopathy, diabetic nephropathy, diabetic neuropathy, and neuropathic foot. Now, Table 3 shows the quality of life domain scores among the respondents. There were 4 domains in quality of life. They were physical health, psychological health, social relationship, environment, and among them, the highest score was found to be in the environmental domain, that is 100, and the least was in the psychological health with 30. The median of the total quality of life is 64.58 with interquartile range 8.45. Table 4 shows the WHO QLBREAD score with all sociodemographic characteristics, and this is a bivariate association which shows that age, similarly gender, similarly marital status, family type, educational status, and employment status was found to be significant with outcome, that is quality of life. Now moving towards next table, that is WHO QLBREAD score domain of with respondents with presence of complication. It was found that presence of complication was significantly associated with the quality of life. And when in the respective complication were respective complications such as diabetic retinopathy, similarly diabetic nephropathy, and neuropathy were found to be not significant with outcome of the study, that is quality of life. Now this is a multivariate linear regression of WHO QLBREAD scores. In this we can see that gender, similarly educational status, and presence of complication were found to be significantly associated with the outcome, that is quality of life. Now conclusion, as age is one of the important risk factors for type 2 diabetes mellitus, but the study didn't show significant association. The gender of the respondent has significant association with the quality of life. In the same way, educational status and the presence of complication found to be associated with the total score of quality of life. The findings of the study can be used further by the policymakers to identify and implement appropriate interventions for better management and ultimately improving quality of diabetes patients. And these are the references. Thank you.
Thank you.
Thank you very much, Mrs. Rojina Tandukar. She has presented very well and is in the exact in time. And lastly, I would like to invite Mr. Alka Ale to present on exercise adherence and its associated factors in individuals with leading NCDs.
Namaskar, my name is Alka Ale. I'm a cardiopulmonary physiotherapist, lecturer and consultant, Kathmandu University School of Medical Sciences, Dhulikhel Hospital. The topic of my presentation today is exercise adherence and its associated factors in patients with leading non-communicable diseases visiting Dhulikhel Hospital. It is a cross-sectional study. Coming to the background, non-communicable disease are not passed from person to person, are of long duration and generally slow progression, also known as chronic disease. Non-communicable disease is currently one of the major health challenges, with 71% of death globally. In 2014, NCDs account for 60% of total annual death in Nepal. According to WHO, the major NCDs are number 1, chronic respiratory disease, number 2, cardiovascular disease, type 2 respiratory diabetes, and cancer. According to a study done in Nepal in 2014, chronic respiratory disease accounts 43%, in which COPD and asthma are leading. Cardiovascular disease accounts up to 40%, out of which hypertension and stroke are more prevalent. Type 2 diabetes accounts to 12% of prevalence, and cancer has 5% prevalence. Exercise is considered important for primary and secondary prevention and treatment of non-communicable disease and has shown to significantly reduce the risk of disease. Exercise being a modifiable factor, exercise has reduced the risk by 40% in cardiovascular disease, 35% in type 2 diabetes, and 34% in COPD. Physical activity reduces diabetes, hypertension, coronary artery disease, depression, stroke, colon and breast cancer, according to a report by WHO 2014. In this report, they say that physical inactivity is directly linked to obesity and non-communicable diseases. According to WHO, the extent to which a person's behavior corresponds with the agreed recommendation from a healthcare provider is known as exercise adherence. It is usually associated with a person agreeing to do exercise in a proper way and completion of the exercise. Exercise adherence is affected by demographic, ethnicity, economic status, socio-cultural factors, knowledge towards exercise, and self-efficacy. Long-term benefits has been obtained with long-term adherence to exercise, but non-adherence rate is high, ranging from 40 to 60% globally. Nepal, being a diversified country, geography, ethnicity, economic status, and culture, it is crucial to determine the level of exercise adherence and to determine the factors associated. Non-adherence has been directly linked to poor treatment outcome. Coming to objectives. My general objective is to investigate the prevalence of exercise adherence and factors associated with in patients with NCDs. Specific objectives to investigate prevalence of exercise adherence in patients with leading non-communicable disease, to determine the factors associated with exercise adherence in patients with non-communicable disease. Coming to methodology, ethical approval was taken. After that, approval was taken from the concerned department of Delhi Hospital. 93 participants were screened for inclusion and exclusion criteria and 80 were included in the study. 13 excluded patients, out of which 10 was over and underage, 3 had cancer. Then, a written consent was taken from each participant before prescribing condition-based home exercises. In the home-based exercises, simple aerobic exercises, flexibility exercises, and resistance exercises, according to ACSM, American College of Sports Medicine guideline, was given. Each participant was given an exercise diary to be maintained at home. The administration of Nepali exercise adherence rating score questionnaire was done in 2 and 4 weeks. Each data sheet obtained from the participant was signed by the researcher. Only 38 participants came for follow-up in the second week. Data was recorded and analyzed and was done using SPSS version 21, and the result was disseminated. Coming to the outcome tool that I use, exercise adherence rating scale. It is a self-reported questionnaire. The questionnaire consists of 3 sections. One is prescribed exercise questionnaire, exercise adherence rating scale, reason for adherence and non-adherence. It is a 5-point Likert scale. Nepali version of EARS has been validated to assess the exercise adherence in non-communicable diseases. Its psychometric properties are internal consistency is 0.81, construct validity is 70%, and test-retest reliability is 0.94. This is the Nepali version of EARS questionnaire. Then I proceed to results. Actually, the statistical analysis was done using SPSS version 21. Baseline characteristics were analyzed using descriptive statistics. Chi-square tests used to assess association between variables and exercise adherence. Now, 38 participants in total were recruited. Out of this, in this chart, figure 1, 55.30 were given exercises daily, 34.20% were given 4 to 6 times a day, 4 to 6 days a week, 10.50 were given 2 to 3 days per week. When the patient had come for follow-up, 50% of the patient did exercises once per week, 21.10% did 2 to 3 times per week, 15.80% did 4 to 6 days per week, out of which 5.30% did not do exercises at all and 7.90 did exercises every day. The exercises that were given was 65.8% were given multi-type of exercises, 23.7 were given regular exercises, and 10.50 were given individualized exercises. Then the total number with 38 participants. In 38 participants, 27 patients did not adhere to exercises and 11% adhere to the exercises. The mean adherence rate is 28.95, which suggests that the exercise adherence rating is low among individuals with non-leading communicable diseases visiting Dulikhel Hospital. Then coming to the table, this is a table that shows factors that hinders exercise adherence. Minimum of patient agreed to do exercises regularly, and maximum of patient did not do exercises regularly. There are some of the factors that were associated with patient were time, pain, patient were not confident to do exercises, and then patient had other business to do for which they could not perform the exercises. Now, looking at the association of exercise adherence with different socio-demographic data, then exercise adherence has significant association with age group, ethnicity, and education level. It did not have any association with gender, type of condition, or duration of the condition. Now, coming to the conclusion of my study, even though exercise is very important and it is one of the major modifiable risk factors, the exercise adherence rate is low among individuals with leading non-communicable disease visiting Dulikhel Hospital. The socio-demographic data such as age, ethnicity, and educational level are associated with exercise adherence. Effective physiotherapy intervention need to be personalized based on individual needs, which can be achieved only by exploring the factors enhancing exercise adherence, an effective way to combat the barriers to exercise. Limitation of the study was the self-reported exercise diary could not be collected as most of the participants did not bring the exercise diary along with them during the follow-up session. The 4th-week follow-up data could not be assessed as most of the participants did not turn up for the follow-up session even after being reminded or being called through a phone call. These are some of my references.
Thank you very much, Ms. Alka Ale. She has presented very well over here regarding the exercise adherence and its associated factor in individual with leading NCDs. Now, I would like to open the floor for any questions regarding the presentations.
Are you ready to respond if there are questions? Speaker, generally we don't, bring questions. But if there are very important comments or suggestions or questions to our keynote speaker generally does not answer questions, okay? But today, if there are very important, because the topic is of national importance, I would invite questions or comments. At least we would make notes of those if you have any. If you don't have, I have 3 questions already registered, and then I'll read it out and I ask the presenters to respond. Looks like there is really nothing we can discuss with our keynote speaker on the side table. The first question is for the speaker 4, Anju Bhadrai. Is there any specific study conducted on genetic factor in any specific community in South Asia that is related to the presentation 4, knowledge of breast cancer and screening practice among women in Siddhartha Nagar? Anju Bhattrai. Can you respond to that?
Can you repeat the question, sir?
All right. I think the question here is, it's not necessarily directly related to your presentation, but you may want to respond to that. That is there any specific study conducted on genetic factor for cancer of breast in any specific community in South Asia? So are you aware that those genetic studies are being done here in South Asia?
Thank you for the questions, but I'm so sorry. I'm not very aware about such study. I think there must have some studies related to genetic factors of breast cancer.
Okay, thank you. Shall I read out others? There are two other questions, okay? So there are two other questions. I will read out the next question again to speaker 5, that is Pragya Shrestha. What are the major reasons of non-adherence to medication among CKD patients? I think she spoke about that. I think that was the whole presentation, but there is a question here. So what are the major reasons of non-adherence? And how did you measure the adherence to medications? And what are your key recommendations? Pragyan, please.
Thank you so much for the questions. I think in total in my research, when I just interview to the patients and just interact with patients, and I think I just non-adherence, the factors for the non-adherence to the medical adherence is mostly like sir, for their I think income expenditure to the hemodialysis treatment. I have in that time I had questions about the monthly family income and also monthly expenditure to the hemodialysis treatment, and 82 just a minute, sir. 82.2% patients had 10,000 to 30,000 monthly expenditure for the hemodialysis treatment. I think in annually expenditure, it means at least per month 10,000 is 1,20,000. If maximum range 30,000 per month equal to in annually, it means 3,60,000. It is a huge amount for the hemodialysis treatment. So most of the patients may be not adherence to the medicine schedule.
Well, thank you. The last question that I have is to speaker 6, Nirjala Lakshmi Madhikarmi. The question is sent by Sushila Dangal. The question is, how was the random selection of samples done in your case? Second question is to you is, what is the significance of healthy controls and how was it selected? So first question, how was the random selection of samples done? Can you respond
Yes,
to
sir.
that?
Namaste one and all. So according to Susila ma'am's question, so whatever patient we had here in our college, so whatever samples we have collected from pathology department, so the diabetic patient, they might be from the fresh cases, they might be from the 1 year cases, they might be like very old cases, like they have been suffering from diabetes from last so many years. So we did not categorize our patients. So randomly patients were selected. So whoever came in between our 6 months study, so we had collected our 150 sample likewise. And the healthy, and she had also asked what about the healthy control? So healthy control, we had selected for the age and gender matched our patient. So, and level of significance, we had done like P less than 0.05. Yes, sir.
Okay, thank you, thank you. I think that sums up the question and answer session. There are no more questions from any audience or from the floor. So I would hand it over to my co-chair to wrap up the session, make some comments, and we can end the session. Thank you.
Thank you very much, Professor Koirala. Before conclude these sessions, I would like to say it's obvious non-communicable disease has been a cross-cutting issues for a long period of time. But in case of Nepal, it has only been a few years since it has come into the limelight. Lately, there have been multiple researches conducted for the betterment of situation of NCDs in Nepal. The burden of disease and steps survey conducted in 2019 also have highlighted the alarming conditions of Nepal, NCDs in Nepal. To address the burning issues, Nepal has already taken steps for development of the separate division under the Ministry of Health and Population dedicated only to the NCDs. So, at last, I would like to thank all our presenters for marvelous presentations and thank all of you for being such a wonderful audience. Now, I would like to hand this mic over to Professor Koirala to say something at last.
Thank you, Dr. Phanindra. I think this session was interesting, although it's kind of awkward to finish up in virtual fashion. We're conventionally used to in-person presentations. But the presentations were of fair significance, and some of them were, very, very important for our understanding of non-communicable disease and their control. Let me first thank Dr. Prakash Rigmi, who spoke on the very significance of the numbers of rheumatic heart disease in Nepal, and this is one of the major contributor to the NCD burden in Nepal, and specifically when you talk about the impoverishment impact of non-communicable disease to people because of the out-of-pocket expenditure until recently. And he highlighted the weaknesses in our system. Let me just correct some of the facts that I think Ministry of Health now has started the initiation on the prevention program. So we can discuss that on a separate limelight. But yes, focusing on tertiary and not focusing on primary care does not look natural. So I think it's already being corrected. And Dr. Phanindra himself is a chair of the director of this is the NCD division. And he will be leading those initiatives in coming days, and they will be in the next program and budget of Ministry of Health. So I think we're seeing some change. And I congratulate our keynote speaker for the huge study that he's coming up with. And we would really like to see the results. I think that will be probably one of the biggest number series that we would see in rheumatic heart disease if that gets published in peer-reviewed journal. That's good. And I would like to thank other presenters which also did pretty good job. Some did not keep up with time, but by and large, the session went pretty organized and the messages were very clear. Let me thank everybody who participated, who listened to the talks, and my co-chair, speakers, and the officials of NHRC and our support team. Thank you very much. We end up the session here. Well, can we give this now? We're already wrapping up the session. Let me see. Well, I would, there is a question. How reliable is WHO QOL, Quality of Life Breath tool? Well, let's not debate that now. We're already up in the time. We're finishing up. But I will ask Rojina Tandukar to reach out to Kamal Ranavat and answer his question on outside this room. Thank you very much, and have a good day.
Thank you so much, Professor Dr. Bhagwan Koirala and Dr. Phanindra Baral, and our guest speaker, Professor Dr. Prakash Raj Regmi, for your valuable time for this session. I also want to give a thanks to all the presenters and participants who are joining with us via different medium. Now I am moving forward to the Token of Love distribution program. I would like to request to Professor Dr. Koirala and Dr. Baral to present a token of love to our guest speaker. Professor Dr. Prakash Raj Regmi. I request to Dr. Regmi to receive a token of love from our chairs.
Thank you so much. It was a great talk. Thank you.
Thank you so much, chairs. Likewise, I would like to request to Professor Dr. Gehenath Baral, Chairman of Nepal Health Research Council, to present a token of love to our one of the chair, Professor Dr. Bhagwan Koirala. Similarly, I would like to request jointly Professor Dr. Gehenath Baral and Dr. Pradip Gewali, and Executive Chief of Nepal Health Research Council, to present a token of love to our next chair of this session, Dr. Farindra Baral. Dr. Baral, request to please receive a token of love. Thank you so much, all of you. After this session, Mrs. Sailaja Gemire will continue the next session on the topic of health system and policy research. Thank you so much. Bye-bye. 10-minute breaks.
session. Namaste to all the distinguished delegates, ladies and gentlemen. I hope you all have had a delightful session so far. It is my immense pleasure to welcome you all this in the session titled Health System and Policy Research. Myself, Shailaja Gimire, Research Officer at Nepal Health Research Council, and will be moderating this session. I would like to invite Dr. Gunaraj Lohane and Dr. Bhojraj Adhikari to the session this year. Dr. Gunaraj Lohane will be present physically, whereas Dr. Bhojraj Adhikari will be present virtually in this session. Before we move on, let's welcome our chairs with a big round of applause. We have Dr. Lohane, who is at the Ministry of Health and Population as the Chief of the Policy Planning and Monitoring Division. He is also a coordinator for Incident Command System under the Health Sector Response to COVID-19. Similarly, he served as the Director General of the Department of Health Services and also was a former Executive Chief here at Nepal Health Research Council. Likewise, we have Dr. Bhojraj Adhikari, who is a consultant physician and chairman of Bharatpur Hospital. He was former vice president at Nepal Health Research Council and an associate professor of National Academy of Medical Sciences. He is an enthusiastic researcher and has published various research papers. His special area of interest covers the domain of diabetes and endocrinology. He is also a chief health advisor of Bharatpur Metropolitan City. Let's welcome our esteemed chairs once again. In this session, we'll have 3 invited talks and 6 presenters. I'd also like to welcome our presenters. This is for your kind information that question and answer session will be at the end of the session. I'd like to request participants to drop their queries at Q&A box, which will be addressed accordingly. Now, without further delay, I'd like to hand over this session to the chairs.
Thank you very much. Good evening, namaste, everyone who is here physically in this room and who are with us virtually in this session. First of all, I would like to wish the grand success of this National Summit of National Health Research and National Health and Population Scientists of this year. As we know that this is the last session of today, and this is a long day. So without delay, I would like to start the session. So first, we have 9 speakers, 3, as already mentioned, that invited talks. So I will start with first talk by Dr. Suresh Tiwari. Topic of this talk is health policy and financing in Nepal. Are we reducing out-of-pocket expenditure? He is going to have is gain experience in his life to our people. So he is a public health man of Nepal, I would say, like in short. He is a public health and public financial management professional with national and international experiences in formulating the public policy, national strategic plan, and policy evaluation. His area of expertise is on epidemiologic research, demand-side financing, social protection, performance-based financing. He has also been involved in developing COVID-related policies, modeling, developing health insurance policies, and implementation modalities, and conducting citizens' budget analysis. He is also a visiting professor of the University of Technology, Sydney, New South Wales University, and also Thamset University of Thailand. So I will say that the floor is Dr. Suresh Tiwari. Please, sir. I think we have time of
10 minutes.
10 minutes. Okay, thank you.
Project गर्नुपर्ने होला हैन? Okay, thank you.
की कन्ट्रोल तपाईले नै गर्दिनु.
Thank you, respected chair, for a nice
introduction. He feels better inside heart somewhere. Thank you for that. So I would like to request all of you to listen me rather than going through the slides themselves, because look at this. The first slide itself is quite messy. The intention of showing this slide is what we refer to policy, what we mean by policy. Look at this one slide itself, and if you want to complete the health-related policies, strategies, frameworks, plan, guidelines, I need 5 of those slides in here. So my 10-minute, my 90-minute will go explaining what policies and what are the intention of those policies. But despite having many policies, regulation, guidelines, act, and finally the constitution, the similar line, all the policy telling us is to bring the positive health outcome of Nepali citizens, ensure the equitable distribution of public purse that is being used in the name of annual work plan and budget. How we deliver that. So I'm giving one example here, that the policy we have developed. One, the policy was the maternity incentive scheme in the year 2005 we designed. And if you look at this graph, when we designed the program, the institutional delivery in the country was not great. And the maternal mortality in the country was off the hue and cry, especially in the research book and international symposiums and country critical debates also. So as a result, we have designed the program, and one policy can really bring the intended changes. Here we started with maternity incentive scheme, change up to the Safe Delivery Incentive Program, SDIP. Then we said, okay, let's Nepalize this rather than more of the English word. Let's talk about Nepali, make it AMA program. So we, in the 2009-10, we make it AMA program, then add the merge AMA program and 4 ANC incentive in 2012, and then again merged with the AMA, 4 ANC, and Sikh newborn care program. So this trajectory tells that the policy with the right evaluation and policy update really help bringing the positive change, intended change. And that's why every policy requires the financing. Financing without the policy doesn't really help. So as a result, this slide itself looks okay, a little bit clumsy, but the message out of it is because of this practice, Nepal has received the Resolve Award, which is a global innovative health financing award Nepal has received because of our initiation, not only initiation, our commitment to change the policy, update the policy based on the evidence. This is what we practice. And while saying so, that was the good story I was telling to you. And we have dived down a little bit with one policy and say there are 2 graphs here, stack bar there. So one is facility delivery, other is 4 ANC. Where we are in terms of equity, because we wanted to bring the positive changes with the equity, not only our service, because this AMA program is a blanket program. Is it really supporting poor people to utilize the service, or it is really benefiting more rich than poor? What is this? Both stack bar says that the blue stack bar tells you the inequity. So over the year, the inequity reduced. And in the facility delivery, institutional delivery, more increasing number of poorer people are being benefited from our scheme. Rather than the message of this this slide is a universal program can help in bringing equitable change. You don't really need to target. In health sector, the message is, in health sector, if you have the universal coverage, ultimately, who going to benefit out of it is the poor people. That's the message of this slide. So this is how where we claim that the AMA program is an equitable program, despite it's a universal program. This is what we claim to the global community. As a result, we received the Resolve Award. And so look at this also. It's reducing the inequity, that's fine, but it's still, if you dive down a little bit more, look at the total picture is who comes to the for the institutional delivery. Obviously, richest people, about 90% richest people practice the institutional delivery. Out of that, 75% utilizes the AMA program, free delivery program. So obviously, big chunk of the public purse is going to serve the richest people, if you do the critical analysis of it. If you look at the poorest people, how many of them are coming and visiting institutional delivery? Not many. Around 32% are poor are visiting institutional delivery. The question of this slide is, are we really thinking now to shift, make the paradigm shift and say, okay, now time has come to redesign AMA program and make it targeted rather than universal? The question is, why we need to pay for the rich is a question here. Then the final question, I'm coming, not many slides are there. Total expenditure is a concern of any country. If you read the book and article related to health financing globally, the country like US, Europe, today the concern is their total health expenditure is increasing like anything. The prediction of US itself that the proportion of the GDP against GDP in terms of health expenditure has been increased in US, and which, if they don't stop this total health expenditure, trend of total health expenditure, large proportion of GDP in health sector will go in US. Look at that, similar message. Nepal also practicing increasing total health expenditure. And if we don't regulate our health practices without having the clinical protocol, without expanding the social health protection, social health insurance program, we are going the similar direction that the many capitalist countries are now going. So that's why question to all of us, and we have signed the universal health coverage. We have our constitution enshrined the free basic health services. At the same time, total health expenditure is going. The concern is, we need to revitalize the financing strategy now. If we don't revitalize our health financing strategy, I think, look at this, 57. If I go and spend in the health institution 100 rupee, I had to pay 60, nearby 60 rupee from my pocket. Will that serve? I have given you one example of AMA policy, AMA program, which has contributed in reducing the disparity. But there are many programs in health. They are not equitable. They are regressive. As a result, this country is facing huge volume of out-of-pocket expenditure. So you may ask me, what is the acceptable range of out-of-pocket expenditure? Many Nordic countries practicing 20 and below %. It's a long way for Nepal to go to practice the 20% out-of-pocket expenditure. We are nearby 60%. Time has come, really revitalize our thinking, be brutal. They really, unless revitalizing, unless revolutionizing health system, we may fail to really achieve what we are aiming, what we are committed, and what we are planning in the policies. This is my last slide, Mr. Chairs. That's why the way forward is we have many policies, many acts, regulations, standard operating procedures, systems, implementation plans, protocols, many. They are not integrated. And they are, rather than creating the efficiency, they are contributing in increasing the THE in a wrong way, not the efficient way. So if we if we harmonize them, I think we can save a lot of money, a lot of financial resources, human resources, by bringing those resources into the harmonized platform. This is the number one. And second is One Health. I think time has come, really think about One Health and One Health. Yeah? Thinking about human is not a solution. We must think about animal. We must think about our environment. Without having the proper environment and the animals, we are not going to be safe. And our health agenda cannot be achieved in this country. Let's start this movement from the Himalayan country, Nepal. And I think we have capacity to think and deliver on this. Universalism and the proper healthcare delivery system. Which one is our choice? Are we going for a universalism? Are we ready to say that all hospitals should be government controlled and whoever go with the card gets the free care? Is that the plan we are thinking about? If this is the case, can 1.17 billion rupee help answer the question? Answer is no. The current resource allocation is not sufficient to answer this question of universalism. And still we are promoting the private sector. Unless we stop promoting the private sector, the equity cannot be achieved. Any country, this is the basic science. Let's fix the basic in our policy debate. Resourcing health sector, we need to think about. We have talked about value for money, agenda of capitalist country always. What is our agenda? Is it value for money or is it value-based care? Which one we are debating? Our policy maker, if our minister is listening me, I think this is a message for you, Honorable Minister. Let's think about what kind of health policy, what kind of health programs, what kind of health institutions we are creating. And then the social health insurance or mixed insurance. We have written that this is the social health insurance. But how many people are coming as a member of social health insurance? How many of today's listener here are the member of Nepal health insurance program? Maybe not many. So without bringing all the people into the national health insurance system, the private sector insurance will keep flourishing, I mean. We heard from the media that this year in the budget, government of Nepal wanted to take the entire health insurance board into the Bima, so-called Bima Samiti. This is a grave deviation of thinking. This will not bring Nepal towards the, socialism type of care, I mean. So this kind of very rough thinking, deviated thinking in the high-level ministries will really bring us in a regressive mode. This is not the criticism. I'm telling you the data. If you are not honest with the data, finding evidence, I think country will remain without evidence, without science, and the progress that we are expecting, that we are committing in our policy, plan, and international commitment remains unchanged. Finally, the National Health Resource Development Plan health human resource development plan has to be there. What kind of services that we are aiming? Vision for the health education. So I heard that the Nepal Medical Education Commission, right, has decided to brought down the MPH curriculum to 2 years. If you don't have 2 years MPH curriculum, you are not allowed to practice public health in Nepal. What is this? So are we practicing 21st century scientific debate? Or because I have a chair, I make the policy? This is kind of golden policy. If you are a rich, you make your policy. So this kind of non-scientific, non-rigor based decision, chair made the decision, we must stop this kind of practice. It is happening because we don't have national health human resource development plan. In the absence of that, our institutions are being biased. And as a result, intended healthcare delivery system with the quality of care, with the equity, this agenda will always be in the low priority, low key, and always be in the shadow. It's why I am bringing this critical debate here is many of young scientists are listening me, and I'm already stepping into 50. So listen my frustration, listen my questions. And there are the solution if you stand, if you listen carefully, I think solutions are there. I didn't want to create the confusion. I really did want it to ignite the debate in the country so that healthcare delivery system can be progressive, can move forward, forward-looking and equitable. Thank you for bearing with me.
Thank you, Dr. Saab. You have highlighted our thinking paradigm must be shifted. You mentioned in the last that chairmen should not decide. It's very difficult to me decide, but this is given responsibility for the time being. So I would like to continue, and I would like to ask to my chair, Dr. Bhojaraj, to continue the session.
To co-chair this session along with eminent personality Dr. Luhani. Thanks NHRC for organizing such a wonderful 7th National Scientific Summit and continuing the tradition of generating the evidence by research in the midst of such a pandemic of COVID-19. It was wonderful to listen Dr. Suresh Tiwari on health policy and financing in Nepal. And without delay, it's time to invite our second eminent speaker, Dr. Savitri Sapkota, who is the Director of Research at Possible. She is presenting on an integrated RMNCH, that is Reproductive, Maternal, Newborn, Child Health Intervention by Community Health Workers in Rural Nepal, that is Type 2 Hybrid Effectiveness Implementation Study. There is no need of much explanation about her. She brings more than 2 decades of experience in research, training, monitoring, evaluation, and evidence to policy. She had overseen international collaborative research projects and led the implementation of large mixed methods research studies on behavioral and implementation science in low and middle income countries, including Nepal. Currently, she is serving as Director of Research for Possible, a non-profit organization focused on research and innovation based in Kathmandu. By training, she is a public health graduate. She had done MPS from Melbourne University, Australia, and PhD on reproductive health from Hiroshima University, Japan. We would be delighted to listen her, and her time allowed is 10 minutes. Madam Dr. Savitri Sabota, please proceed for your presentation.
Thank you so much, Dr. Adhikari, for that great presentation. Great introduction. I would like to start by thanking NHRC and then the summit organizer for allowing me to present this research in this great platform. This study has been conducted in collaboration with, let's see. This study has been conducted in collaboration with the Ministry of Health and Population, Nyaya Health Nepal, and Possible. I'm presenting today on behalf of the partnership and then the whole team involved here. I'll just be covering, a very standard format of the presentation. Just to start with, I would like to say, after Dr. Tiwari's presentation, I don't have to talk much about the background of this study, but just to kind of touch up on in low and limited resource setting country like Nepal, every day many women die from childbirth-related causes that could have been easily prevented. Pregnancy-related maternal mortality ratio, institutional birth rate, and under 5 deaths haven't changed much between 2016 and 2006 and 16, despite a lot of policies that Dr. Suresh has talked about in the earlier presentation. These deaths are not just because they are not preventable, nor there does not exist any intervention to address them. I think Dr. Suresh has also addressed that there are plenty of evidence-based intervention protocols and then the measures to do that. Especially in the rural areas, it's more because of the gap in implementing those evidence-based intervention. Part of those implementation gaps, there is a shortage or unfair distribution of health workforce and performance challenges, I would say, which hinder us in achieving universal health coverage. World Health Organization has recommended community health workers as an important cadre in achieving universal health coverage and sustainable development goals in low-income settings like Nepal. What we did was, in collaboration with the Ministry of Health and Population, we built an integrated intervention aligned with WHO guidelines on optimizing community health programs. This study was conducted with this question in mind, to assess the effectiveness of the intervention and also at the same time if this can be adopted at a scale. Before I go into the detail of the study, let's briefly look into the intervention components. It really integrates 5 evidence-based approaches to improve RMNCH outcomes. The first one is continuous surveillance of all women of reproductive age group, pregnancy, and children under 2. Similarly, other component comprises of home-based antenatal care and postnatal care counseling and care coordination. The other one is community-based IMNCI, group antenatal care, and also the balanced counseling strategy for contraceptive uptake. Then the question comes around, who are these community health workers and how do they work? So these are different than female community healthcare volunteers. They are full-time, salaried, trained, supported and supervised female community health workers. They are from the local community with the minimum of 10th education. They use mobile-based platform which is known as ComCare for care coordination, counseling and referral. They collected the real-time data part of the program using mobile phones within the ComCare platform. We had 3 major objectives in mind when we conducted this study. It's a part of the implementation study to analyze the impact of the bundled intervention delivered by community health workers on institutional birth, postpartum contraceptive prevalence, and under 2 mortality rate. We also wanted to assess the implementation process of implementing this intervention using the REAIM framework, that's a IS framework. We also wanted to conduct a costing analysis of the interventions. I won't be able to go through all of these objectives and their respective findings today in this presentation in the interest of time, but I'm hoping to cover the primary outcomes of this intervention and also covering some of the cost analysis findings of the intervention. So just a quick overview of the methodology. I don't think we need to introduce these two districts, Acham and Dolakha. These are the districts, like, in Province 7 and Province 3. As shown in the slide, you can see the health indicators are not that great, and access to health services, not mentioned about the quality of care, was very limited at the time of implementing this study. We used this type 2 hybrid implementation study, which evaluates both the implementation process and also the effectiveness of the interventions at the same time, giving equal importance. We looked at the primary effectiveness indicators, institutional birth rate, postpartum contraceptive prevalence rate, and under 2 mortality rate pre and post implementation of those interventions. We used mixed method analysis, mixed method data collection and analysis to understand the implementation process indicators using that REAIM framework. REAIM stands for reach, efficacy, adoption, implementation, and maintenance. The participants enrolled and followed up in this study that comes from the almost four-year timeline between February 2016 and March 2020. Thus, the data comes from that timeline. Let me briefly touch upon the implementation, how it was implemented. The integrated implementation, those 5 key components of RMNCH, they were implemented in a stepwise fashion, both in Acham and Dolakha, across 7 different hubs. The hubs here are defined as clusters of about 2 to 14 wards. Quickly, just briefing about how the data analysis was conducted. We looked at the primary outcome using the mixed effects Poisson regression model, assessing the change in IVR pre and post intervention, looking at the data between February 2016 and March 2020. Similarly, we also conducted a retrospective analysis using demographic, programmatic, and financial data for the period between July 16, 2017 and July 15, 2018, basically covering 1 full year. And not to mention, we have such support and approval from Ministry of Health and Population and in the local government prior to the implementation of this study. We also obtained NHRC ethics approval. And most importantly, before we implemented this program, we also obtained the informed consent at household and individual level. As I said earlier, in the interest of time, I'll just be covering primary effectiveness indicator, which is IVR, and then some of the costing analysis. If you look at this table, out of the total enrolled families, 35% were from Dalit and Janajati groups. The median monthly household expenses at baseline across the hubs range between 4,000 and 12,000 rupees. The baseline IVR were also different across the hubs that range between 51% and 78%. This is at the time of baseline. We first look at the unadjusted institutional birth rate by intervention time period. We had also looked at from other variables as well, but I just wanted to share this one in the interest of time, not covering everything. The box plot here in this slide shows observed IVR by intervention time period. This shows some potential association. I'm saying potential association between the outcome and then the intervention. This also suggests an increase in IVR almost immediately, 1 year after the intervention, and the intervention effects seem to sustain over the years of the intervention. This is the main finding slide of the presentation when we describe the outcome on IVR of this study. We run the mixed effects Poisson regression model, adjusting for districts, intervention time period, and random effects of hubs to assess IVR pre and post. The regression analysis resulted the rate ratio estimate of 1.3, which suggests statistically significant association between institutional birth rate and the intervention. On average, I would say there was a 30% increase in IVR post-intervention as compared to pre, holding other variables constant. Then coming to the costing part, we covered the data of a year period. As I explained earlier, the analysis came from a catchment area of 60,000 population area with 19,000 direct beneficiaries from 2 hubs in Assam. personal, as well as other direct and indirect program costs were included in the analysis, excluding the leadership cost that comes from the district and then the national component. We had looked at the cost per capita, cost per service delivered, and cost per programmatic design elements and administrative cost. But again, in the interest of time, I won't be able to cover all the cost. I'll just be touching upon the cost per capita. Without going into the details of this slide, I would like to highlight the cost per capita for implementing this intervention is 318 rupees. But what we did was we also kind of modeled it into different scenarios. Since the question is also around if this can be adopted at scale, we projected the cost per capita modeling on 3 different scenarios: minimum wage scenario, municipality governance, and integrating what does it look like if we integrate it into the PHC facility. What we found was the cost per capita would be further reduced up to 112 rupees per capita if we can integrate this in the current government structure. Besides cost, however, what you need to be very careful here is each of these models has pros and cons, and that needs to be considered if planning for adoption of this model. More details about this costing and then the results has already been published, and it can be found in the link given here. So coming to the discussion slide, integrated RMNCH intervention delivered by local, full-time, salaried, and supported community health workers more likely to result in increased institutional birth rate. But I would like to acknowledge some of the limitations of this study. This is a quasi-experimental trial design. We adopted this design of quasi-experimental because of ethical and what can be implementable or acceptable in the context that we worked. It is difficult to establish the causality between the intervention and IVR without a randomized trial. Having said so, what I would like to highlight is when we use the regression model, we attempted to control for secular and development trends, just to kind of control any additional confounding. But what we assume is there may be other unknown confounders that we may have omitted in the model. So therefore, we need to be a little careful here.
You have 2
there
minutes
are other
more.
limitations. I'm coming to the end to my slide, just in case if the time is the restriction. If you look at the costing, per capita cost for the intervention is only NPR 313. That shows potential to integrate this to the Nepal government program with further lower per capita cost. In this slide, in this implementation races, besides the RMNC's integrated components, community health workers had provided care coordination, counseling, and referral for other prioritized areas. For example, NCDs, mental health, chronic care follow-up. What I would like to highlight here is the impact may go far beyond with the community healthcare model. We also need to look at the implementation process indicators, which I haven't showed it in this slide, and understand how it has actually implemented, its facilitators, and challenges during the implementation time. This is the last slide of my presentation. Before I end, I would like to pose these 2 very important questions that has a policy implications. The first one is, can this model be expanded and improved to make progress towards achieving universal health coverage and health-related sustainable development goals? How does this look like when translated and implemented by the local government? That's what we want to do it. We want to scale up and adopt it at the national level. Well, we have some initiatives that has already been taken to understand this question. A good example I would like to cite here is Ramarosan Rural Municipality in Assam. Ramarosan Rural Municipality has been implementing this model, hiring their own community health workers and taking full ownership of this program with support from Nyaya Health Nepal. I'm sure there will be some learnings from this model of implementation for further adaptation. We're also actively sharing these findings with
Dr. Bhojraj, would you please continue?
It will be They have been good for progression of NHRC where it exists today for the last decade. They are presenting on the topic of Nepal burden of disease in 2019, key findings and policy implication. As we know, Dr. Dhimal is currently a Chief Senior Research Officer at Nepal Health Research Council. His area of expertise is on environmental, climate change and health. He is visiting lecturer of environmental health on different universities in Nepal. He has been awarded with PhD Scholarship Award from German Academy Exchange Service and Young Scientist Award 2015 by Nepal Academy of Science and Technology. He is the member of different national and international academia and organization. He had published number of research articles in national and international journals. And we have another joint speaker, Krishna Orelji, who has a PhD in public health and has more than 10 years of experience in the health sector of Nepal, primarily around health system strengthening through use of evidence in policy making, planning, and decision making. Earlier, he was as the chief of research section of NHRC. Currently, he supports the Ministry of Health and Population on monitoring and evaluation, evidence generation, and evidence of decision making in part of NHS's implementation through UKID and MEOR project. And he's also the editorial board member of the Journal of NHRC. And being in NHRC itself, he has been contributing to strengthen the evidence base around burden of disease in Nepal. And today's topic is one of my favorite topics since we used to discuss regarding the top 10 disease and their scientific basis in Nepal. Now they are highlighting on the burden of disease in 2019. I request the speakers to proceed on.
Thank you so much, Dr. Saab. A very good evening to you all, and good afternoon to people in other part of the world. A very beautiful introduction, and at last Dr. Bozraj mentioned about how interesting it used to be when we used to discuss about burden of disease and its implications, as well as how it came across and how we have reached till here in estimating burden of disease and supporting decision making in health sector with regards to its use of evidence. On behalf of Dr. Dhimal as well as the team who does this task, I am presenting on key findings of the burden of disease 2019 for Nepal. Moving ahead, I'd like to start with background of burden of disease, how it developed, and how we have crossed the journey of burden of disease estimation in Nepal. In 2006, NHRC started the process of burden of disease estimation by carrying out several primary studies here, and the publications from these primary studies have come out already in terms of mortality statistics that has contributed a lot in refining the estimates of burden of disease in Nepal. Later on, while looking into the global group of people who have been working on burden of disease estimates and getting proper estimates for each country across the globe, IHME, the Institute for Health Metrics and Evaluation at University of Washington, visited the country in 2014 with the purpose of a scoping exercise on how Nepal's burden of disease estimates could be further improvised, further improved in terms of getting closer estimates of the country. And hence, NHRC and Ministry of Health and Population signed an MOU with the Institute for Health Metrics and Evaluation in 2018 to further work closely, collaboratively together to refine the burden of disease estimates of the country. And as a result of that, in 2020, using the data of burden of disease 2017 from Global Burden of Disease Study 2017, we produced a report, first comprehensive report on burden of disease in Nepal, highlighting the issues around what kind of diseases are affecting the country, what kind of disease conditions are causing the most deaths, most dialysis, etc. As a continuation of that, this burden of disease report 2019 also comes using the Global Burden of Disease 2019 data. I'll not take much time in the background component of what Global Burden of Disease study is. However, this round of Global Burden of Disease Study 2019 comes with the joint effort of Institute for Health Metrics and Evaluation and World Health Organization, which has more detailed disease and injuries list in it, more risk factors included in it, more data sources included in it, and it basically provides us the results for broad three different categories as well as subcategories within those, including non-communicable diseases, communicable maternal, neonatal, and nutritional diseases, and injuries. Again, I'll not go into detail of this slide, but basically just to show that this is based on a lot of data sources across the globe. And if we want to look into the data sources that has gone into the estimates for Nepal, there are 402 data sources from Nepal itself in the estimates. And what does it measure? What does it basically measure? It gives us overall mortality, like how many people die in a country or a particular geographical region. What do people die from? Looking into the causes of death. What makes people sick? Not just the causes of death. It gives us information about non-fatal health outcomes, and it also gives us about what are the risks for health loss, that is risk factors. And with those measures, we get these kind of outputs. Basically, in broader terms, in an overall term, it's the disability adjusted life years, which captures both years of life lost and years lived with disability, giving the measure of causes of premature death as well as causes of disability. And using those data for Nepal from the global data set, we extracted the data for different outputs in terms of deaths, in terms of disability adjusted life years, and risk factors attributing to deaths and disabilities, and have generated this report in the form of Nepal Burden of Disease 2019. When we look into the life expectancy, it has given us that we Nepalese born in 2019 are expected to live 13 years longer than those born in 1990. That means our life expectancy has increased. However, when we look into the healthy life expectancy chart, we can see that not all those additional gained years will be healthy ones, where healthy life expectancy is almost 10 years below the lower than the life expectancy. Looking into the overall mortality in Nepal, while looking into the three broad categories of the causes of deaths in Nepal, we can see that a staggering 71%, nearly 1/4 of the total deaths, are due to non-communicable diseases. And when we combine injuries into that, it becomes almost 80%. That's 8% of the total deaths are due to injuries, and the remaining 21% of the deaths are due to communicable maternal, neonatal, and nutritional diseases. Going further, diving a little bit deeper, where we can see that in terms of sex-wise distribution of mortality in Nepal, non-communicable diseases equally are affecting both groups of population. However, when we look into injuries, more men die due to injuries, but in terms of women, it's communicable maternal, neonatal, and nutritional diseases that kills more of our Nepalese women. And coming to the another facet of burden of disease, which is disability adjusted life years, which gives a composite measure of years of life lost and years lived with disability. We can see that NCDs have contributed 61% of total DALYs in 2019, and similarly CMN and disease, the communicable category of the diseases, has contributed 29% of total DALYs, and injuries contributed to 10%. And on the right side, we can see the sex-wise distribution of that, where again it's more or less similar in both categories, unlike in the deaths results. Looking at how we have come across from 1990 to 2019, on the left-hand side, when you look at the overall all-age mortality, there we can see that the NCDs are rising in the orange color, communicable diseases are decreasing, the death rates are going down, but much of that is due to the age distribution. And when we adjust that age distribution, we can see that NCDs have more or less remained same in terms of the rates. However, the overall proportion attributing to deaths is quite high, and the age standardized rate for communicable diseases have gone down significantly, and the injuries remain more or less same when we compare it with 1990 and coming across through till 2019. Similarly, a same kind of picture is seen in terms of overall burden of disease, that's the daily rates, both all age as well as age standardized. When we adjust the age, we can see that the NCDs have remained more or less same in terms of rates, but still presenting a higher proportion of daily rates for Nepal. And diving a little bit further into what disease conditions cause most deaths in Nepal in 2019, looking into some specific causes of deaths, we can see that cardiovascular diseases was a number one cause of death in 2019, and then followed by that were chronic respiratory diseases and neoplasms, and this followed a similar pattern both in male and female. We can see that respiratory infections and TB, digestive diseases, and in the sixth number, maternal and neonatal disorders are still on within top 10. And that highlights the earlier two presentations that those still are the priority areas where we cannot take our focus out of that. And then this picture shows the changes in the standardized mortality rates, how it has changed over years from 1990 to 2019, looking into the specific categories, where you can see cardiovascular disease and chronic respiratory disease on top, and similarly respiratory infections still making within the top 10, and maternal and neonatal disorders as well within the top 10 in terms of rates, and then the change over the years. This is a similar picture in terms of overall DALYs, that's looking into specifically the causes of overall causes of DALYs, specifically with different conditions. Here in the yellow highlights, I wanted to show that in cardiovascular diseases is definitely contributing to the top cause of DALYs in the country. However, you can see maternal and neonatal disorders coming to number 2 in terms of DALYs. That means when we combine both deaths and disabilities, maternal and neonatal disorders still contribute a lot in terms of DALYs in the country. And so does the mental disorders and musculoskeletal disorders, and which also highlights the need for focusing on conditions like that, and policies and programs to control or to prevent and manage mental disorders as well as conditions such as musculoskeletal disorders, which are causing a huge proportion of disabilities in the country, leading to big years lived with disabilities. And this shows the change in the daily rates for specific disease conditions, where you can see still the cardiovascular disease and chronic respiratory disease has gone quite up from 1990, but even though slightly decreased, maternal and neonatal disorders, respiratory infections and TB still remain within top 5. This is another important facet of burden of disease estimates, which I think is most important slide for us here today listening in this presentation. We looked into the impact, and we looked into different rates. Sure, sir. We looked into different rates of deaths as well as DALYs. Here we can see that the top risk factors that's causing deaths in Nepal are smoking, high systolic blood pressure, and their change rate, they have gone quite high. Household air pollution decreased, but still claiming or attributing a lot of deaths in the country. And similarly, the ambient particulate matter pollution, as well as fasting plasma glucose. And I also wanted to highlight this slide along with that. When talking about risk factors, if we look into the top 5 smoking, blood pressure, air pollution, both household and ambient, that comprises a huge chunk of attribution to deaths. And those all we know are very much preventable, and we can have very low cost interventions to prevent people suffering from the outcomes of these risk factors. So it's very much important in terms of disease prevention and control. Coming to the last 2 slides, where we have seen across the presentations that NCDs are overwhelming primary disease burden in the country. Primary care prevention program, we know that Dr. Faninda also has come over here just now, as well as Bhagwan Daksab is here. We know that it's still in very infancy stage, and with the increasing proportion of chronic diseases, chronic conditions, the chronic care burden to the country is rapidly increasing. And thus it has funding implications as well in terms of how we manage our financing, also relating again to the first presentations by Dr. Tiwari. And equity issues in communicable diseases still remain, where he has quite nicely showed in his first slide about how it has been over years, and how we want to go further in terms of maternal health. Local level is very much important, as discussed in second presentations, this is another important another area where we need to act from local level governments. And global evidence still reiterates, shows the importance of multi-sectoral collaborations, which we cannot deny. Finally, adaptation of the health systems to address the shift in the disease burden is very much important in terms of policy, and that may include gradually capacitating the local level governments, local level health facilities for the care of chronic diseases, addressing health beyond health sector, and of course, One Health comes as it has come earlier. Multiple risk factors go beyond health sectors, and managing them that needs intersectoral collaborations. Sustaining progress in communicable diseases, which is very, very important. We cannot just deprioritize the focus on communicable diseases as we move into the need for prioritizing the non-communicable diseases. Preparing for a transition to a sustainable financing mechanism, and thus is very important in terms of increasing needs of resource to deal with the non-communicable diseases, and the coupling with the development assistance. That's like we can see that may be declining or which is stable, the development assistance. So it's very important that we need to increase resources for this. And then gradually expanding the coverage of health insurance could be one of the options. Supporting local government, as I highlighted in the previous slide, for evidence-informed, locally tailored interventions is important. And addressing additional data need, that is also very crucial for more precise estimations and sub-national estimations, which will help further to improvise our prevention and control programs. Thank you so much, and this is my last slide where we wanted to show the collaborative effort from us.
Thank you, Dr. I think we might have questions, but we will have a question and answer session at the end of session. So I will request you all, if you have any queries, to write it down, and we will discuss it at the end. So I would like to invite another speaker, Anita Bosnet. Topic of presentation is utilization of basic health services at primary health care facilities during COVID-19 pandemic in urban municipality of Bagmati province, Nepal. Time is yours.
Hello everyone, greetings from Anita Bosnet. I feel privileged and honored to present on 7th National Summit of Health and Population Scientists in Nepal, organized by NHRC. So I would like to thank NHRC for this wonderful opportunity. So moving ahead for my presentation on the research paper, the purpose of the study, the title of the study was Utilization of Basic Health Services at Primary Healthcare Facilities during COVID-19 Pandemic in an Urban Municipality of Bagmati Province, Nepal. The authors of this research paper are Anita Bosnet, myself, Suraj Busar, and Professor Dr. Kedar Prasad Baral. All of the authors are affiliated to School of Public Health, Patan Academy of Health Science, Lalitpur, Nepal. As we are very aware that COVID-19 infection has spread all around the world in a short span of time. So during this pandemic, there is battle between the COVID-19 infection and providing the basic health services meanwhile. So this task is very critical and challenging. From this chaotic situation, the direct mortality from COVID-19 and indirect mortality from other conditions has increased. So many evidences shows that major health gains achieved during the past 2 decades has been wiped out in a short period of time. So strong primary health care system can be a first line of defense to keep people healthy and safe, and meanwhile fighting against the pandemic. So our research aim to find out the facilitator and barrier of basic health service utilization at primary healthcare facility during COVID-19 pandemic. Moving ahead for the methodology, cross-sectional qualitative design was conducted on the Bidur municipality of Nuwakot district, Bagmati province, for the period of 6 months. All of the participants of 18 years and above, were selected by judgmental sampling, and 25 interviews were conducted from diverse background, where 14 in-depth interviews with the health service users were conducted, 4 KII with health service provider, 3 with health administrator, and with the elected representatives. Validated interview guidelines was adopted from the expert opinions and supervisors. A telephone interview was conducted for a minimum of 20 minutes, and socio-ecological model was selected by the researcher, and all of the researchers selected the participants judgmentally, whom the researchers thought they will contribute for the socio-ecological model. For the data analysis, audio recording was done, and it was translation was done, and data analysis was done by RKDA package. Intercodal reliability was done, and for the IQ intercodal reliability of is independent of two independent coders was obtained as 74.50. This table shows the positive percentage agreement at each thematic area, where in each thematic area the positive percentage agreement has crossed more than 60%, and at organizational and community and policy level it has crossed more than 80%, which shows the IQR is good for this study. For data analysis, for the member checking was done after the interview. Thematic analysis was done using the Brown and Clark six steps methods. यसमा चाहिँ अब आरकेडिए प्याकेजको स्क्रिनसट चाहिँ आरकेडिए प्याकेजको कोडिङ एन्ड थीमेटिक क्याटेगोराइजेसन देखाइएको छ. इथिकल एप्रुभल पास आइआरसीबाट लिएको थियो. Approval from concerned municipality was also taken, and anonymity, informed consent, privacy, confidentiality were maintained during the whole process. Moving ahead for the result section, this table shows that diverse age group were selected for the study from 22 years to 80 years. So, and male and female population were selected proportionally. All of the wards of the Bidur municipality were covered. This diagram is the main findings of our research study, where at the interpersonal level, trust to the traditional healer, preference for the home remedies was found as a barrier for basic health service utilization during pandemic. At individual level, low socioeconomic status, fear of acquiring a COVID-19 was found as a barrier. Whereas moving ahead for the organizational level, at the organizational level, shortage of health workers, the mental stress among the health workers, motivations for the mental stress among the health workers, shortage of health workers was found to be a major barrier for utilization of basic health service during the pandemic, whereas motivation for the health workers was found as both barrier and facilitator. Shortage of drugs and commodities was found as a barrier. At the community level, unavailability of transportation facilities, social stigma was found as a barrier for utilizing the basic health services, whereas community solidarity was found as a facilitator for utilizing the basic health services during this pandemic. Moving ahead for the policy level, at the policy level, the extended lockdowns, minimal municipal supports, inadequate coordinations between three tiers of the government were found as a major barrier for utilizing the basic health services. So moving ahead on each thematic areas, findings on each thematic area. The major cross-cutting factors was found as a lower socioeconomic status. अब यसमा चाहिँ अर्को भनेको चाहिँ सर्भिस युजर्सहरुमा देखिएको फियर्स प्लस सर्भिस प्रोवाइडर्सहरुमा देखिएको फियर पनि एउटा मेजर फ्याक्टर थियो. सर्भिस युजरमा देखिएको फियर भनेको उहाँहरुलाई चाहिँ सर्भिस अथवा ट्रान्समिसन हुन्छ गएर तर अथवा इफ दे आर डायग्नोज्ड विथ द कोभिड-19 स्टिग्माटाइज्ड हुन्छ कि सोसाइटीबाट भनेर उहाँहरु चाहिँ बेसिक हेल्थ सर्भिसेस लिनलाई लिमिट गरेको छु भन्ने खालको कुरा आएको थियो. अनि सर्भिस प्रोवाइडरहरुमा पनि आफ्नै नोबल इन्भाइरोमेन्टमा काम गर्नलाई अथवा आफूले त्यो भाइरस बोकेर मैले परिवारलाई संक्रमित बनाउँछु, साथीभाइलाई संक्रमित गराउँछु, स्टिग्माटाइज हुन्छु भन्ने खालको चाहिँ फियरहरु भएको कारणले उहाँहरुलाई इफेक्टिभ हेल्थ सर्भिस डेलिभरमा चाहिँ एफेक्ट गरेको देखिन्छ, विच इज सपोर्टेड बाई द भर्बाटिम्स। अर्गनाइजेसनल लेभलमा चाहिँ स्ट्रेस एउटा प्रमुख कारण थियो मेन्टल एमङ द हेल्थ वर्कर्स। अर्को भनेको चाहिँ डिफिकल्टिज अन रनिङ द बेसिक हेल्थ सर्भिसेस बिकज अफ मिनिमम सपोर्ट्स अफ ड्रग्स एन्ड कमोडिटिज होइन। कमिटी लेभलमा सोसल स्टिकमा चाहिँ मेजर फ्याक्टर देखिएको थियो। पोलिसी लेभलमा हेर्नु पर्दाखेरि चाहिँ एक्सटेन्डेड लकडाउन्स जसले गर्दा चाहिँ डेट्रिमेन्टल इफेक्ट्स अन बेसिक हेल्थ सर्भिस युटिलाइजेसन देखिएको थियो। त्यसै गरी सर्भिस प्रोभाइडर र एडमिनिस्ट्रेटर्सहरूले चाहिँ रिपोर्ट गरे अनुसार चाहिँ दे हेभ बिन रिसिभिङ द मिनिमल सपोर्ट फ्रम द म्युनिसिपालिटी अफिस अथवा स्थानीय सरकारबाट हामीलाई चाहिँ सक्दो सहयोग भएन भनेर चाहिँ उहाँहरूले चाहिँ रिपोर्ट गर्नुभएको थियो। जसले चाहिँ अब यो भर्बाटिम्सले जुन चाहिँ सर्भिस प्रोभाइडरले दिनुभएको भर्बाटिम्स जुन चाहिँ उहाँहरूले बारम्बार एसेन्सियल ड्रग्स कमोडिटिज ह्युमन रिसोर्सहरूलाई चाहिँ उहाँहरूले रिक्वेस्ट गरेको बट दे आर नट रेस्पोन्डिङ भन्ने खालको चाहिँ देखिएको छ। अर्को भनेको पोर कोअर्डिनेसन्स बिट्विन 3 टायर्स अफ गभर्मेन्ट होइन, जुन चाहिँ स्थानीय सरकार अथवा इलेक्टेड रिप्रेजेन्टेटिभ्सहरूले भन्नुभए अनुसार चाहिँ दे हेभ बिन रिसिभिङ मिनिमम पावर एन्ड अथोरिटी एन्ड रिसोर्सेस फ्रम हायर लेभल अफ गभर्मेन्ट, जसले गर्दा चाहिँ उहाँहरूलाई इफेक्टिभ सर्भिस डेलिभरीमा चाहिँ अनि पेन्डेमिक म्यानेजमेन्ट प्लान बनाउनलाई चाहिँ एफेक्ट गरेको छ र त्यही साथसाथै बेसिक हेल्थ सर्भिसेस दिनलाई पनि एफेक्ट गरेको छ भन्ने कुरा चाहिँ देखिएको छ। अब कन्क्लुजनतिर जानु पर्दा चाहिँ आवर स्टडी सोज द बेसिक हेल्थ सर्भिसेस वाज सिभियरली कम्प्रोमाइज। गुड एजुकेसन लेभल, डेडिकेसन्स अफ हेल्थ वर्कर्स, community solidarity, coordinations was found as a barrier, whereas low socioeconomic status, trust to traditional healers still in this 21st century, unavailability of transportation facilities, social stigma was found to be the major barrier. So for this, the enhancement of digital technologies can be a promoting factor. So from this study, I would like to acknowledge the School of Public Health Patern Academy of Health Science, all of the faculties from there. I will appreciate the efforts of Dr. Suman Rimal from Institute of Medicine. My sincere thanks to participants and IRC of the past. This is all my references and this is all from my side. All your suggestions, feedbacks are welcomed. Thank you so much.
Thank you very much. I would like to request another speaker, Kiran Nakarmi. The presentation topic is identifying hospitals in the Nepal for acute burn care and stabilization capacity development, location, allocation, modeling for strategic service delivery. Kiranji.
Hello, I would like to thank NHRC for the opportunity to share this project with you. I'm Dr. Kiran Nakarni. I'll be sharing our team's geospatial analysis work to identify hospitals in Nepal for acute burn care and capacity development in order to maximize service delivery. There are no disclosures. Burn injuries are a leading cause of death and disability globally, and at least 11 million people get injured annually. It's estimated that 90% of death and disability occur in the lower middle income countries. Nepal has the highest incidence of flame burn injury globally, which has multiple causes as shown in the picture. Community survey shows high burden of unmet surgical need. Kirtipur Hospital has been serving as the main tertiary referral burn center in Nepal from all over the country and neighboring parts of India. Difficult terrain and lack of organized ground or air medical transport leads to recurring pattern of delayed presentation in major burns, leading to frequently minimal to no resuscitation prior to our arrival. For burns more than 40% total body surface area, mortality rate approaches 100%. About half of the roadways are paved and 25% of the population live 4 hours walk from the nearest all-season roads. There are multiple factors to consider in ongoing health system development. After 2015 earthquake, the government is decentralizing healthcare and has ongoing major road infrastructure development. Furthermore, our team in Kirtipur Hospital routinely participate in outreach with peripheral hospitals and working towards developing burn stabilization points, which was the impetus for this work. We envision burn stabilization points would be general hospital with specific training in acute burn care assessment such as ABC, wound assessment, and resuscitation prior to transport. Therefore, our objective was to use geospatial analysis to identify the 3 versus 5 hospital model in Nepal that would optimize population level geospatial access to acute burn care if their burn stabilization capabilities were strengthened. These analyses will directly inform the ongoing ground level efforts to develop geospatial burn stabilization points for care prior to tertiary care centers. We first identified the hospitals that would serve as candidate hospitals for the model. These were 29 general hospitals which referred patients to the tertiary burn center. Next, we developed a population density grid for Nepal using NASA's estimated population density grid. Then using the OpenStreetMap and Google Maps program, along with expert validation, we developed a model road network of Nepal, which includes all roads and their speed limits. Lastly, by combining all of the above, we conducted our cost, distance, and network analysis in ArcGIS. We created models of 3 additional and 5 additional hospitals for each of the patient travel time within 2, 6, and 12 hours. The baseline model demonstration demonstrates the current levels of access to burn care for the population of Nepal within 2, 6, and 12 hours. You will see that only 20% of the population has only 20% of the population has access within 2 hours, and it's really centered around Kathmandu Valley and where the burn center is located. Large proportion of population does live within the valley as well as the southern border. We can see population cover does increase as we increase the travel time threshold, but even modeling with patients reaching the burn center within 12 hours, less than 75% has access to burn center, with entire portion of country that are lacking in coverage. Here are the models with 3 additional stabilization points. You can see in the leftmost picture, in order to maximize access within 2 hours, all of the chosen hospitals are clusters along the southeastern border. Then as travel time is increased to 6 hours in the middle figure, for the first time we see hospitals even chosen in the western part of the country. This leads to a jump in population access from 45% to nearly 90%. Similarly, as we increase the time threshold in 12 hours, we have a hospital chosen by model in both northern and southern areas of West Nepal, leading to access for nearly 100% of the national population. Lastly, we have our model with 5 additional stabilization points. Here, for access within 2 hours, the model chose hospitals all along the southern border from east to west. Next, for access within 6 hours, you see small shifts in the chosen hospitals, and each hospital has a larger catchment area, which would likely to increase access for semi-urban and rural population for nearly 95% coverage. Lastly, for 5 additional hospitals, giving patient access within 12 hours, you see coverage of essentially the entire national population, including further rural areas. Let's take a moment to compare between the models. First, we notice for both 3 and 5 hospital models that we are able to achieve nearly 90% population level special access to burn care within 6 hours. Next, let's compare across the different travel time models. We see there is increased population access to around 90% for both 3 and 5 hospital models when we go from 2-hour model to 6-hour model. But after that, there is only pretty marginal increase in population level access from 6 to 12 hours. Here is Here is one last representation of the maps next to each other. Feel free to pause and take a closer look. With the models of 3 and 5 additional burn stabilization points, we saw that both were able to provide population level spatial access at nearly equivalent levels, particularly within 6 and 12 travel hours. Next, when looking at travel times, both 6 and 12 hours scenarios provided similar level of access for both 3 and 5 additional stabilization centers. This loads us to different options that may work for health system planning, like choosing a model such as B provides access to nearly 90% of the population within 6 hours by strengthening 3 hospitals. These models and methodology do have their limitations. Firstly, the road network data is derived, so it may not entirely reflect the on-the-ground realities, such as travel adjustment for adverse road conditions. There are also patient-sided barriers to access, which are not accounted for in these models. These include access to transport, financial capacity, health literacy, knowledge of how to access burn care, etc. Additionally, these models do not reflect or address issues of equity. Those may be partially vulnerable population whose needs are not addressed by these models. Lastly, the models currently do not consider or reflect the ground level realities about human and facility capacities and resources available. However, despite these limitations, as you can see, it is useful to understand current population level special access to burn care. It helps in planning burn care outreach for the initial burn resuscitation and stabilization. It helps with national health system for planning efforts and evaluate them. Financial support for this research is through University of Washington Office of Global Affairs, Global Innovation Fund, and NIH Poverty International Center. Thank you.
Thank you, Dr. Nakarmi. Now I will invite next speaker, Menuka Bandari. The topic of presentation is professionalism among nurses working at the different government and private hospitals of Province 1. Menuka ji.
Namaskar. I'm Menuka Bandari, working as a lecturer at Biratnagar Nursing Campus. Now I am going to proceed my research paper presentation. The title of the research study is Professionalism Among Nurses Working at Different Government and Private Hospitals of Province 1. Our research team includes 3 persons. I am Menuka Bandari, Tulasa Dahal, and Jyoti Keshi. Now moving on the background, professionalism is characterized by the degree of dedication displayed by the individuals regarding the values and behavioral attributes of a specific career identity. Professionalism indicates attitudes that represent high level of identification and commitment to a specific profession. Professionals are generally defined in terms of a particular body of knowledge obtained through formal education, an expanded level of skills, some type of certification to prove entry to the profession, and a set of behavioral norms known as professionalism. Continuing the background, according to Ishar and Karadag, the professional standards of behavior required of nurse executives are very important to the development of professional nursing everywhere. Therefore, as leaders, nurse executives need to become actively involved in the ongoing development and improvement of professional standards of behaviors and conduct in their field. Professionalism includes application of knowledge, skills, carrying out standards activities, leadership, self-disciplines, professional commitment, and social values. The reasons behind this study was there were very limited research conducted in nursing related to professionalism in Nepal yet. In Nepal, there are various issues and problems related to professionalism, that is satisfactory salary, role of professional organization, autonomy, public recognition, sense of calling. As a result of frequent collective bargaining and protest has been noted in time to time with professional organization and Nepal government. Therefore, this study was conducted to address the gap in research by exploring the attitude of nurses toward the attributes of professionalism. Now, I am going to describe the research objectives. The general objectives of this study is to find out professionalism among nurses working at different government and private hospitals of Province 1. The specific objectives are to assess 5 attitudinal attributes of professionalism among nurses working in government and private hospitals, to identify the level of professionalism among nurses working in government and private hospitals, and to identify the association of professionalism with selective demographic variables. Moving on to the methodology section. The cross-sectional study design was used to examine the relationship of selective demographic variables with 5 attitudinal attributes of professionalism and the degree to which they were present currently. The study area was selected purposely considering the geographical and population representativeness, and 7 governmental and 4 private hospitals were selected purposely. The population of this study was all the nurses completing PCL or above who were working as a staff nurse or holding leadership position as a ward in charge and nursing administrator in their hospitals. The sampling methods was total enumerated sampling for the government hospitals, and for private hospitals, samples were selected randomly because there were almost staff nurses or above level. The sample size of the study was 316 nurses, among them 156 nurses from government hospitals and 160 nurses from the private hospitals. The self-administered questionnaire was used for data collection. The first part consisted of socio-demographic variables of the study, where age, marital status, level of education, working experiences, position of nurse, workplace, type of employment, job satisfaction, membership in NAN, training opportunities, and monthly salary. Hall's professionalism inventory scale was used to identify 5 attitudinal attributes of professionalism. Total score for the professionalism scale was ranges from 25 to 125, with higher scores indicative of professionalism. Descriptive statistics was used to find out frequencies, percentage, means, standard deviation, and ranges. Inferential statistics was used for multiple regression analysis. A 0.05 level of significance was established for all hypothesis testing. What we found in this study, I'm going to describe the results. Based on what we found in this study, I'm going to describe the results. The main score of the total professionalism was 87.54 with standard deviation 7.99. The sub-scale score where lowest in autonomy was 15.64 with standard deviation 2.60. Public services was 16.80 with standard deviation 2.90. In self-regulation was 17.80 with standard deviation 2.54. Professional organization was 18.32 with standard deviation 2.26. And the highest score was attitude towards sense of calling, that is 18.86 with standard deviation 2.66. The current study found that those who had achieved master degree in nursing education had high autonomy than those only had PCL and bachelor level of nursing. I have kept the level B value in the bracket. The position of the nurses, that is matron and senior nurses, had positive association with autonomy than those only staff nurse. The professional organization as a major reference of professionalism, only the senior nursing position, positive job satisfaction, and marital status were positively associated with professional organization. Present study revealed that only 35.75% were life member of Nepal Nursing Association and 64.24% were not taken the membership of association. The nurses who were the member of Nepal Nursing Association had positive relationship with self-regulation. Also, the current salary of senior nurse, nursing officer, and the matron were positively associated with self-regulation. Continuing on the result section, those nurses who had more than 16 years of experiences had more dedicated attitude than those of less experienced nurses. Current position of the nurses also seen to be associated with sense of calling. That is, matron had high positive attitude towards sense of calling. Senior nurses also had high sense of calling to their profession. In relation to the employment type, permanent nurses have seen high sense of calling than the contract type. High salary scale was also seen positive association with the sense of calling. Those nurses whose salary scale was more than 40,000 had high sense of calling. Belief in public services means that an individual's profession is essential for the society. Those nurses who had bachelor or master degree education had seen positive attitude toward the importance for public services. In regard to the position, nursing officer had more positive value towards public services. The study demonstrated that nurses involved in this study had not shown low level of professionalism. 93.4% or 295 of the respondents scored moderate level of professionalism, value ranging from the 51 to 100, and only 6.6% or 21 of the respondents scored high level of professionalism, ranges from 101 to 125. This was based on the total analysis. Now, I want to conclude my study. The present study concluded that higher education degree, high position, good salary, sufficient working experiences, membership in professional organization, adequate training and job satisfaction are the most important factors of professionalism for nurses. And most of the nurses had found moderate level of professionalism, and a few number of nurses deserves the high level of professionalism. This indicates that the nurses of Nepal should get adequate opportunities to develop professionalism by various ways in coming days. Thank you very much. I want to acknowledge NHRC for this golden opportunities. And at the end, I want to say that if there is any query, I am ready to answer them. And once again, thank you very much and namaskar.
Thank you, Menuka Bhandari, for your nice presentation. I will request another presenter, Resam Khatri. The topic of presentation is updating known and exploring unknown towards universal coverage of quality maternal and newborn health services in Nepal, a mixed method investigation. Resamji.
मेरो थेसिसको फाइन्डिङलाई प्रेजेन्टेसन गर्न गइरहेको छु। मेरो थेसिसको टपिक रहेको छ, थेसिसको टपिकबाट आएको चाहिँ फाइन्डिङहरू यहाँ प्रेजेन्ट गर्न गइरहेको छु। यो मेरो प्रेजेन्टेसनको आउटलाइन हो। मेरो थेसिसको मेन आर्गुमेन्ट पोइन्ट चाहिँ एक्सेस इम्प्रुभ भए पनि किन चाहिँ म्याटर्नल न्युबर्न हेल्थ आउटकम इफेक्टिभ रूपमा देखेको छैन भन्ने थियो। यहाँनिर चाहिँ दुईटा डेटा देखाउन खोजेको छ। इन्स्टिट्युसन डेलिभरी बढेको छ टाइम ओभर द टाइम पिरियडमा भने त्यही अनुसार म्याटर्नल मोर्टालिटी घटेको छैन। केही रिसर्चहरू अगाडि पब्लिस भइसकेका छन् जसले चाहिँ नै लोकल बर्थिङ सेन्टरहरूसँग पुवर इन्फ्रास्ट्रक्चर छ र तिनीहरू चाहिँ यदि चाहिँ सर्भिस एभाइलेबल छ भनेदेखि तिनीहरू युज भइरहेका छैनन् र आमाहरूले सर्भिस बाइपास गरेका छन् भनेर देखाएको छ। र संस्थामा सहरी स्वास्थ्यमा जाँदाखेरि बढी मात्रामा चाहिँ सर्भिसहरू कमर्सियलाइज छ, इभन रुटिन सर्भिसेसहरू छ, धेरै चाहिँ प्राइभेट सर्भिसहरू बिजनेसमा लिएका छन् भन्ने देखेको। जस्तो यहाँनिर चाहिँ नै सिजरियन सेक्सनको डेटा देखाउन खोजेको छ। यो चाहिँ मेरो डेटा सोर्स हो। मैले 3टा डेटा सोर्सबाट चाहिँ रिसर्च तयार गरेको हो। कभरेजको कुरा गर्दाखेरि चाहिँ नै 2 या 2 भन्दा बढी सर्भिस यदि चाहिँ नै डिसएडभान्टेज छ भनेदेखि कभरेजहरू कम छ र यदि चाहिँ एडभान्टेज छ 2 या 2 भन्दा बढी भनेदेखि उहाँहरूको चाहिँ सर्भिस कभरेज चाहिँ बेटर भएको चाहिँ देखाएको छ। यदि आमाको केयर हेर्ने कन्टिन्यू केयर हेर्ने हो देखि एएनसी देखि पिएनसी सम्म चाहिँ कभरेजहरू उहाँहरू डिस्कन्टिन्यू भइरहेको देखिन्छ। सर्भिस यदि चाहिँ नै रुटिन सर्भिस रुटिन हेल्थ भिजिटमा चाहिँ उहाँहरू चाहिँ इफेक्टिभ इन्टरभेन्सनहरू लिनुभएको छैन भन्ने देखाउँछ। जस्तो एएनसी भिजिटमा जाने बेलामा चाहिँ आमाहरूले पर्याप्त मात्रामा एएनसी एन्टिनेटल केयरको इन्टरभेन्सनहरू कम लिएको देखिन्छ डेटाबाट। र स्वास्थ्य संस्थाहरूको तयारीको अवस्था हेर्ने हो भनेदेखि पनि स्ट्रक्चरल क्वालिटी पनि कमजोर छ, विशेष गरिकन स्टाफ र गाइडलाइनमा। र स्वास्थ्य क्षेत्रको टेक्निकल डेलिभरीको पर्सपेक्टिभ हेर्ने हो भनेदेखि पनि स्टाफ र गाइडलाइन्सको डोमेनहरू र मेडिसिन इक्विपमेन्टको डोमेनहरूमा चाहिँ त्यो पनि कम भएको देखिन्छ। र विशेष गरिकन लोअर सोसियल स्ट्याटस भएका महिलाहरू, डिसएडभान्टेजेसका महिलाहरू, लो एजुकेसन भएकाहरू, धेरै मल्टिपल फङ्सन मान्छे भएका महिलाहरूमा चाहिँ सर्भिस कभरेजहरू कम भएको देखिन्छ। प्रोभिन्स 6 का प्रोभिन्स 2 पेरिफेरल लेभलका फेसिलिटीहरूमा चाहिँ कम क्वालिटी अफ केयर चाहिँ पुवर छ। त्यस्तै गरिकन यदि चाहिँ स्वास्थ्य संस्थाहरूमा हायर लेभलबाट सुपरभिजन भयो मोनिटरिङ भयो भनेदेखि त्यहाँ काम गर्ने स्टाफहरूले बेटर क्वालिटी सर्भिस डेलिभर गरेको देखाउँछ र ती स्वास्थ्य संस्थाहरूको एक्सेस महिलाहरूको एक्सेस र कभरेज डेलिभरीको कुरा गर्दाखेरि माथिल्लो लेभलका सिस्टमभन्दा बाहिरका हेल्थ सिस्टमभन्दा बाहिरका हेल्थ सिस्टमको कन्ट्रोलभन्दा बाहिरका फ्याक्टरहरूले चाहिँ असर गरेको देखिन्छ जस्तो यो डेटा चाहिँ नै क्वालिटी स्टडीको फाइन्डिङ हो macro level ma corruption, poor accountability system प्रति informal governance, poor digital governance, poor utilization, politicization of health workforce, multi-party trade unionism, unregulated private sectors. यी factors हरूले system को delivery, system को functioning मा problem भएको देखिन्छ भनेदेखि decentralization को अथवा federal health system को perspective बाट पनि अहिले चाहिँ अझै पनि डिसेन्ट्रलाइजेसन प्रपर डिसेन्ट्रलाइजेसन प्र्याक्टिस भएको छैन र सर्भिस डेलिभरी गर्ने पोइन्टमा सर्भिस युजर्स र प्रोभाइडर्सको मा चाहिँ एउटा किसिमको सोसियो कल्चरल डिस्क्रिमिनेसनको प्र्याक्टिस अझै पनि छ र डिसएडभान्टेज पपुलेसन ग्रुपको पार्टिसिपेसनहरू भोइसहरू हर्ड भएको देखिँदैन यहाँनिर केही इक्जाम्पल्सहरू दिन खोजेको छ कसरी चाहिँ प्रोभिन्सियल हेल्थ फेसिलिटीलाई सेन्टरले चाहिँ डिसिजन लिएर आफ्नो कन्ट्रोलमा लिन खोजेको कसरी चाहिँ प्राइभेट हेल्थ सेक्टरमा हेल्थ सेक्टरको चाहिँ कस्ट अफ केयर इमर्जिङ हाई भएको कसरी प्राइभेट हेल्थ पब्लिक सर्भिसले चाहिँ पब्लिक हस्पिटलले पिपुललाई चाहिँ प्राइभेट सेक्टरमा जान बाध्य बनाएको करप्सन सेक्टरको यी फ्याक्टरहरू जुन चाहिँ पोलिटिकल सिस्टमबाट पोलिटिकल सोसियो पोलिटिकल फ्याक्टर्सले असर गर्छन् त्यसले गर्दा ओभरअल सिस्टममा चाहिँ असर गरेको छ र यी माक्रो लेभलका फ्याक्टरहरू इन्स्टिट्युसनलाइजेसन र यिनीहरूले तल्लो लेभलका संस्थाहरूमा असर गरेका छन् र डेलिभरीलाई कमजोर बनाएका छन् भन्ने व्याख्या गरिएको छ त्यसै गरिकन सर्भिस युजर्सको पर्सपेक्टिभमा बाट हेर्ने हो भनेदेखि पनि रिमोटनेस पुअर ट्रान्सपोर्टेसन सिस्टमले संस्था र कम्युनिटी बीचको डिस्कनेक्ट छ उनीहरू सर्भिस लिन सकिरहेका छैनन् यहाँनिर के फिगरहरू देखाउन खोजेको छ कस्तो छ हाम्रो जियोग्राफी ट्रान्सपोर्टेसन सिस्टम कसरी मान्छेहरू एक प्रकारको गरिबीसँग जुझ्नु परेको छ र उनीहरूले आफ्नो हेल्थलाई केयर गरेका छैनन् त्यसका साथसाथै पुअर हेल्थ लिटरेसी आफ्नो सर्भिस के सर्भिस चाहिन्छ र सर्भिस कहाँ एभाइलेबल छ भन्ने कुराहरू पनि उहाँलाई लिटरेसीको अभाव छ त्यस्तै सिस्टमप्रतिको कन्फिडेन्स पनि छैन र त्यसकारण पनि उहाँहरू सर्भिस लिन आउन सक्नु भएको छैन यी फ्याक्टरहरूलाई बेटर कम्युनिकेसन बेटर डेभलपमेन्टल सेक्टर एप्रोचले नन सेक्टरको इन्टरभेन्सनबाट चाहिँ पिपुलको लिभिङ र वर्किङ कन्डिसन इम्प्रुभ गरेर सर्भिस डेलिभरीलाई चाहिँ बेटर बनाउन सकिन्छ र एक्सेस इम्प्रुभ गर्न सकिन्छ भन्ने एउटा पर्सपेक्टिभ दिन खोजेको छ र विदिन द हेल्थ सिस्टमभित्र केही फ्याक्टरहरू छन् माक्रो लेभलमा र मेजर लेभलमा भनेको प्रोभिन्सियल लेभलमा पनि एक्ट गर्छन् र लोकल लेभलका डेलिभरी संस्थाहरूलाई चाहिँ उनीहरूले असर गर्छन् जस्तो विक म्यानेजमेन्ट विक हेल्थ सिस्टम म्यानेजमेन्ट इन टर्म्स अफ हेल्थ प्लानिङ एन्ड फाइनेन्सियल म्यानेजमेन्ट लजिस्टिक सप्लाईको प्रब्लम छ ह्युमन वर्कफोर्सको प्रब्लम छ त्यस्तै गरिकन एभिडेन्स युजहरू हुँदैन प्रोभिजन अफ डेलिभरी अफ पुअर क्वालिटी एमएल सर्भिसेस ओभरअल फ्याक्टरले गर्दाखेरि चाहिँ तल्लो लेभलमा चाहिँ डेलिभरी गर्न प्रब्लम हुन्छ र यी फ्याक्टरलाई एड्रेस गर्नको लागि दुईटा डोमेनबाट एड्रेस गर्न सकिन्छ एउटा हेल्थ सिस्टम स्ट्राटेजी गर्ने जस्तो मोर फर्म्स अफ डिसएडभान्टेज भएको आइडेन्टिफाई गर्ने कन्टिन्यू केयरको एसेसमेन्ट गर्ने इफेक्टिभ डेलिभरीहरूको एसेसमेन्ट गर्ने त्यस्तै गरिकन स्ट्रक्चरल क्वालिटी टेक्निकल क्वालिटी संस्थाहरूको पत्ता लगाउने र त्यही अनुसारको चाहिँ इनपुट दिने सिस्टम इनपुट दिने हो भनेदेखि सिस्टम हेल्थ सिस्टमबाट इम्प्रुभ गर्न सकिन्छ साथसाथै लोकल लेभलमा मल्टी सेक्टर स्ट्राटेजी एप्लाई गर्न सकिन्छ जस्तो हेल्थ सेक्टर नन हेल्थ सेक्टर र सोसियो पोलिटिकल फ्याक्टर्सहरू जो चाहिँ रुरल म्युनिसिपालिटी लेभलमा आउनुहुन्छ उहाँहरूसँग मिलेर काम गर्ने हो भनेदेखि धेरै रिसोर्स डिस्ट्रिब्युसन पार्टिसिपेसनको सेक्टरमा इम्प्रुभ गर्न सकिन्छ र म्याक्रो लेभलमा गुड गभर्नेन्स द मेन फङ्सन सिस्टम फङ्सनिङको लागि चाहिँ मेन हो त्यो म्याक्रो लेभलबाट सुरुवात गर्नुपर्दछ यहाँनिर एउटा फ्रेमवर्क दिन खोजिएको छ म्याक्रो र मेजर लेभल सर्भिस डेलिभरी लेभल म्याक्रो लेभल म्युनिसिपालिटी लेभल भनेदेखि यतातिर डोमेन नन हेल्थ सेक्टर डोमेन स्ट्रक्चरल डोमेन र हेल्थ सिस्टम डोमेन तीनटा डोमेन हेल्थ सिस्टम डोमेनको लिस्ट इफेक्ट हुन्छ, तर त्यसलाई चाहिँ स्ट्रक्चरल डोमेन सोसियो पोलिटिकल फ्याक्टरले असर गरेको हुन्छ। सोसियो पोलिटिकल फ्याक्टर्सले डेभलपमेन्ट सेक्टरलाई पनि असर गर्छ, जसले गर्दाखेरि डेभलपमेन्ट सेक्टर इम्प्रुभ भयो भनेदेखि एक्सेस डिमान्ड्सको सर्भिसको डिमान्ड बढ्छ, हेल्थ सिस्टमको इम्प्रुभ भयो भनेदेखि सप्लाईको बेटर हुन्छ, र त्यसलाई ओभरअल स्ट्रक्चरल डोमेन गुड गभर्नेन्स सोसियो पोलिटिकल फ्याक्टर्सहरूले डिसेन्ट्रलाइजेसनलाई गभर्न गर्छ यी दुईटै डोमेनलाई। र एट द सर्भिस डेलिभरी पोइन्ट म्याक्रो लेभल हाम्रो कन्ट्रीमा भनेदेखि रुरल म्युनिसिपालिटी लेभलमा तीनटै डोमेनहरूका एक्टर्सहरू तीनटै डोमेनका पोलिसीहरूलाई चाहिँ होरिजेन्टल लेभलको इन्टेग्रेसन गर्न सकिन्छ, जसले गर्दा सप्लाई डिमान्ड र त्यसको ओभरअल गभर्नेन्स इम्प्रुभ गर्ने हो भनेदेखि त्यसको आउटपुटको रूपमा सर्भिस एप्रोचेबल हुन्छ, सर्भिस एफोर्डेबल हुन सक्छ र सर्भिस एभाइलेबल हुन सक्छ। त्यसले गर्दाखेरि यदि तीनटाको कम्बिनेसन भयो भनेदेखि सर्भिस युटिलाइजेसन बढ्छ र इक्विटीको प्रब्लमलाई एड्रेस गर्न सकिन्छ, र त्यसले गर्दा ओभरअल हेल्थ सिस्टम हुन सक्छ र सिस्टमप्रति कन्फिडेन्स र इकोनोमिक बेनिफिट हुन सक्छ। यो ओभरअल फ्रेमवर्कले चाहिँ हामीले चाहिँ तीनटै डोमेन र तीनटा लेभलबाट हामीले इम्प्लिमेन्ट गर्यो भनेदेखि यो चाहिँ इक्विटीको हेल्थ इक्विटी चाहिँ गेन गर्न सकिन्छ भन्ने देखाउन खोजेको छ। फर्दर रिडिङको लागि फुल थेसिस एभाइलेबल छ, एउटा पेपर पब्लिस भइसकेको छ भनेदेखि अरू पेपरहरू अन्डर रिभ्यू र ड्राफ्ट स्टेजमा छन्। धन्यवाद।
हस्, धन्यवाद रेशम खत्रीजी। Now I request another speaker, Bhola Rai. Topic of presentation is active case finding reduces patient cost in pre-treatment phase. Most probably will be in the TB area. Bhola Rai ji.
Namaste everyone. I am Bhola Rai. I worked in Virat Nepal Medical Trust as a project manager. And today I would like to do a presentation on active case finding reduces tuberculosis patient cost in pre-treatment phase on the behalf of BNMT team. And I would like to start from the burden of TB in Nepal. According to the National TB Prevalence Survey 2018-19, it shows that 69,000 people developed new TB in 2018. And त्यसै गरी 1.6 times higher than previously estimated, जुन पहिलाको रेशियो भन्दा चाहिँ 1.6 times higher देखाएको छ। र त्यसै गरी 54% people were undiagnosed of TB, उहाँहरु चाहिँ मिसिङ केसेसहरु छन् 54% केसेसहरु। त्यसै गरी हाम्रो चाहिँ एज ग्रुपमा हेर्ने हो भने 65 एबोभमा चाहिँ बढी देखेको छ TB, त्यो चाहिँ 37% छ। र त्यसै गरी 25 to 34 एज ग्रुप जुन प्रोडक्टिभ एज ग्रुपमा चाहिँ कम देखेको छ, त्यो चाहिँ 7% छ। र अनि मेल र फिमेलको रेशियोमा हेर्ने हो भने चाहिँ बढी मेलमा चाहिँ टिबी भएको देखाएको छ, त्यो नेशनल टिबी प्रिभ्यालेन्स सर्वेले, त्यो चाहिँ 67% छ भने फिमेलमा चाहिँ 33% छ। र अनि हाम्रो स्टडीको मेन अब्जेक्टिभ भनेको चाहिँ हामीले कम्पेयर कस्ट बिट्विन एक्टिभ केस फाइन्डिङ एन्ड प्यासिभ केस फाइन्डिङ। यो भनेको चाहिँ एक्टिभ केस फाइन्डिङ भनेको चाहिँ हामीले बिरामीलाई आफै चाहिँ खोज्न जान्छौँ, हामी शंकास्पद बिरामीलाई फिल्डमा, र उनीहरुको स्पुटम हामी आफै लिएर आएर चाहिँ स्वास्थ्य संस्थामा टेस्ट गराउँछौं र त्यसरी डायग्नोसिस हुन्छ एक्टिभ केस फाइन्डिङको बिरामीहरु। र प्यासिभ केस फाइन्डिङ भनेको चाहिँ बिरामी आफै अवेयरनेसको कारणले गर्दाखेरि उहाँहरु स्वास्थ्य संस्थामा आउने र अनि टेस्ट गर्ने र डायग्नोसिस हुने, र त्यो कस्ट कसले बढी खर्च गर्यो एक्टिभ केस फाइन्डिङ र प्यासिभ केस फाइन्डिङमा भन्ने चाहिँ हामी इभ्यालुएसन गर्छौं, हाम्रो त्यो पनि एउटा अब्जेक्टिभ हो। र त्यसै गरी सोसियो इकोनोमिक इम्प्याक्ट पनि हामी मेजर गर्छौं एक्टिभ केस फाइन्डिङ र प्यासिभ केस फाइन्डिङको बिरामीको। र अनि हाम्रो मेथोडोलोजीको कुरा गर्नु पर्दा चाहिँ हाम्रो स्टडी चाहिँ लङचुनल स्टडी हो। यो लङचुनल स्टडी भनेको के हो भन्दा यसले 3 टाइम्स हामी एउटै टिबी पेशेन्टलाई हामी इन्टरभ्यु लिन्छौं हाम्रो फिल्डमा, र पहिलो इन्टरभ्यु हामीले चाहिँ 2 महिनाको पिरियडमा लिन्छौं इन्टेन्सिभ फेजमा, भने सेकेन्ड इन्टरभ्यु हामीले कन्टिन्युएसन फेजमा लिन्छौं बिरामीको, र थर्ड इन्टरभ्यु चाहिँ एट द एन्ड अफ द ट्रिटमेन्ट लिन्छौं हामी बिरामीको। र अनि कन्सेन्ट फर्म नलिकन हामी बिरामीको इन्टरभ्यु कहिले पनि लिदैनौं फिल्डमा, कन्सेन्ट फर्म भरिसकेपछि मात्रै बिरामीको इन्टरभ्यु लिन्छौं हामी। र त्यसै गरी हामीले चाहिँ WHO पेशेन्ट कस्ट क्वेसनर युज गरे हो, र अनि हामीले फिल्डमा चाहिँ हामीले अलरेडी यो पाइलट इन्टरभ्युज लियौं, र त्यसमा चाहिँ केही फ्यु चेन्जेसहरु हामीले गर्यौं त्यो क्वेसनरमा। र अनि मेनली यो क्वेसनरले के कभर गर्छ भन्दा प्री ट्रिटमेन्ट फेज र ट्रिटमेन्ट फेजमा भएको कस्ट यसले कभर गर्छ। प्री ट्रिटमेन्ट फेज भनेको चाहिँ बिरामीलाई टिबीको लक्षण सुरु भयो र उले चाहिँ स्वास्थ्य संस्थामा चाहिँ गएर चाहिँ टिबीको लागि भनेर उपचार नगरुन्जेलसम्म, किन भन्दाखेरि बिरामीलाई डायग्नोसिस हुनको लागि चाहिँ उले विभिन्न स्वास्थ्य संस्थामा जाने र उपचार गर्ने, जस्तै निजी क्लिनिक, निजी अस्पतालहरूमा जाने र त्यहाँ खर्च गर्ने, र त्यो खर्च गरेको कस्ट पनि यो क्वेसनले कभर गर्छ। र त्यसैगरी ट्रिटमेन्ट फेज भनेको चाहिँ बिरामी चाहिँ अब उसले डायग्नोसिस भयो, त्यसरी ऊ चाहिँ अब फर्दर साइड इफेक्टको कारणले गर्दाखेरि अनि त्यसरी कहिलेकाहीँ चाहिँ त्यहाँ चित्त नबुझेको कारणले गर्दा फर्दर ट्रिटमेन्ट गर्न जाने, त्यो कस्ट पनि यो क्वेसनले कभर गर्छ। र त्यसैगरी WHO पेसेन्ट कस्टिङ टुलले मेन कभर गर्ने भनेको 4टा छ, जुन चाहिँ डेमोग्राफिक एन्ड सोसियो इकोनोमिक प्यारामिटर्स। अब यसमा चाहिँ बिरामीको चाहिँ इन्कम, एजुकेसन, अकुपेसनहरू पनि यो क्वेसनले कभर गर्छ। र त्यसैगरी डाइरेक्ट मेडिकल कस्ट, नन मेडिकल कस्ट एन्ड इन्डाइरेक्ट कस्ट। यो भनेको डाइरेक्ट मेडिकल कस्ट भनेको के हो भन्दाखेरि चाहिँ बिरामीले चाहिँ स्वास्थ्य सेवा प्रदायकलाई चाहिँ एज अ कन्सल्टेसन फी, रेडियोग्राफी, ल्याब टेस्टको आधारमा चाहिँ उसले तिर्छ बिरामीले स्वास्थ्य सेवा प्रदायकलाई। र त्यसै गरी नन मेडिकल कस्ट भनेको चाहिँ बिरामीले चाहिँ अब डायग्नोसिस हुने बेला अथवा उपचारको क्रममा ऊ अब कहिलेकाहीँ चाहिँ एज अ ट्रान्सपोर्टेसन वेमा पैसा तिर्ने, एकोमोडेसनलाई तिर्ने र फुडिङलाई पैसा तिर्ने, यो चाहिँ नन मेडिकल कस्ट भयो। र इन्डाइरेक्ट कस्ट भनेको चाहिँ टाइम एन्ड इन्कम लस। अब बिरामी भइसकेपछि उसले काम गर्न सक्दैन र उसले काम गर्न नसकेपछि उसले आफ्नो इन्कम पनि लस गर्छ, उसले टाइम पनि लस गर्छ। र कोपिङ मेकानिजम्स भनेको के हो भन्दाखेरि हाम्रो स्टडीमा के देख्यौँ भन्दाखेरि बिरामीलाई चाहिँ डायग्नोसिस हुनलाई चाहिँ उसले चाहिँ अब कसैसँग लोन लिएको होइन, त्यस पछाडि चाहिँ अनि अब आफ्नो अब जग्गाहरू बेच बिरामीले चाहिँ कोपिङ गरे हुन्छ हामीले देख्यौँ त्यो स्टडीमा। र त्यसै गरी टिबी पेसेन्टलाई चाहिँ एकदमै फाइनेन्सियल र सोसल इम्प्याक्टमा चाहिँ यो टिबीले चाहिँ एकदम असर गरेको चाहिँ हाम्रो स्टडीले देखाएको छ। र अब रिजल्ट्सको कुरा गर्नु पर्दाखेरि चाहिँ हाम्रो सुरुमा चाहिँ म सोसियो इकोनोमिक क्यारेक्टरिस्टिक्स अफ टिबी पेसेन्ट्स डायग्नोज थ्रु एक्टिभ केस फाइन्डिङ एन्ड प्यासिभ केस फाइन्डिङको बारेमा चाहिँ एक्सप्लेन गर्न गइरहेको छु। र हाम्रो चाहिँ स्टडीमा चाहिँ मोस्ट अफ दि वेयर मेल, 70% चाहिँ मेल नै थियो हाम्रो स्टडीमा, बोथ एक्टिभ र प्यासिभमा होइन। र त्यसै गरी एक्टिभ केस फाइन्डिङ र प्यासिभ केस फाइन्डिङको कम्पेरिजनमा हामीले के देख्यौँ भन्दाखेरि चाहिँ अलिकति एक्टिभ केस फाइन्डिङमा चाहिँ बिरामीहरू चाहिँ अलिक इलिट्रेसी हाई भएको देख्यौँ, जुन हामीले यहाँ हेर्न सक्छौँ। र त्यसै गरी बेसिक स्कुल एटेन्ड गर्ने पनि अलिकति एक्टिभ केस फाइन्डिङकोमा चाहिँ कम देखेको छ प्यासिभ केस फाइन्डिङमा। र त्यसै गरी सेकेन्डरी स्कुल एटेन्ड गर्ने पनि एक्टिभ केस फाइन्डिङको बिरामीमा चाहिँ कम देखेको छ प्यासिभ केस फाइन्डिङको तुलनामा। र त्यसै गरी हामीले एक्टिभ केस फाइन्डिङमा चाहिँ के देख्यौँ भन्दाखेरि मोस्ट अफ द टिबी पेसेन्ट दे आर वर्किङ इन द डेली वेजेस होइन, त्यो त्यसमा चाहिँ अब ज्याला मजदुरीमा काम गर्ने देखेको छ एक्टिभ केस फाइन्डिङमा भने प्यासिभ केस फाइन्डिङ अलिकति कम देखेको छ। र त्यसै गरी प्यासिभ केस फाइन्डिङ र एक्टिभ केस फाइन्डिङको कम्पेरिजनमा चाहिँ एसेट्स जस्तै मोबाइल फोन, रेफ्रिजरेटर, टेलिभिजन चाहिँ प्यासिभ केस फाइन्डिङको टिबी पेसेन्टको चाहिँ उहाँहरूको घरमा चाहिँ बढी भएको देखेको छ, हाम्रो स्टडीले त्यो देखायो। र अनि कस्टको कुरा गर्नु पर्दाखेरि चाहिँ अब हामीले हाम्रो स्टडीमा चाहिँ 111 एक्टिभ केस फाइन्डिङ र 110 प्यासिभ केस फाइन्डिङ चाहिँ हामीले इन्क्लुड गरेका थियौँ। र अनि हाम्रो स्टडीले के देखायो भन्दा एक्टिभ केस फाइन्डिङ रिड्युसेस द डाइरेक्ट मेडिकल कस्ट, डाइरेक्ट नन मेडिकल कस्ट, देन द प्यासिभ केस फाइन्डिङ इन द प्री ट्रिटमेन्ट पिरियड। अब हामीले यहाँ हेर्न सक्छौँ जस्तै अब एक्टिभ केस फाइन्डिङमा चाहिँ डाइरेक्ट मेडिकल कस्ट $41 छ भने प्यासिभ केस फाइन्डिङमा $50 छ होइन। र डाइरेक्ट नन मेडिकल कस्ट पनि एक्टिभ केस फाइन्डिङमा चाहिँ $7 छ भने प्यासिभ केस फाइन्डिङमा चाहिँ $18 छ। यो चाहिँ एकदमै एक्टिभ केस फाइन्डिङले चाहिँ प्री ट्रिटमेन्ट फेजमा चाहिँ प्यासिभ केस फाइन्डिङको तुलनामा चाहिँ एकदमै कस्टहरू चाहिँ डाइरेक्ट मेडिकल कस्ट र डाइरेक्ट नन मेडिकल कस्ट चाहिँ घटाएको देखाएको छ हाम्रो स्टडीले। र त्यसै गरी नट ओन्ली इन द प्री ट्रिटमेन्ट फेज र ट्रिटमेन्ट फेजमा पनि एक्टिभ केस फाइन्डिङले चाहिँ एकदमै रिड्युस गरेको छ कस्टहरू, जुन हामीले हेर्न सक्छौँ। डाइरेक्ट मेडिकल कस्टमा चाहिँ अब एक्टिभ केस फाइन्डिङको बिरामीमा $58 छ भने प्यासिभ केस फाइन्डिङको बिरामीमा $73 छ। र त्यसै गरी डाइरेक्ट नन मेडिकल कस्ट $14 एक्टिभ केस फाइन्डिङकोमा छ भने प्यासिभ केस फाइन्डिङमा चाहिँ $28 छ। त्यति सिग्निफिकेन्टली डिफरेन्स देखेको छैन, तर त्यो पनि एक्टिभ केस फाइन्डिङले चाहिँ ट्रिटमेन्ट पिरियडमा पनि बिरामीको चाहिँ एकदमै डाइरेक्ट मेडिकल कस्ट र डाइरेक्ट नन मेडिकल कस्ट चाहिँ रिड्युस भएको देखाएको छ। र कन्क्लुजन्समा आउनु पर्दा चाहिँ हाम्रो एक्टिभ केस फाइन्डिङ मोडल चाहिँ एकदमै भनरेबल पेसेन्टसम्म हामी रिच गर्न सक्यौँ। र अनि यसले चाहिँ सिग्निफिकेन्टली रिड्युस पेसेन्ट कस्ट इन द प्री ट्रिटमेन्ट फेज। र अनि पेसेन्ट्स बोथ द एक्टिभ केस फाइन्डिङ एन्ड प्यासिभ केस फाइन्डिङ ग्रुप्स रिपोर्टेड सिभियर एन्ड इन्ड्युरिङ सोसियो इकोनोमिक कन्सिक्वेन्सेस। यो दुइटैलाई एक्टिभ केस फाइन्डिङको बिरामीलाई पनि प्यासिभ केस फाइन्डिङको बिरामीलाई दुइटैलाई एकदमै आर्थिक भार देखाएको छ हाम्रो स्टडीले। अनि त्यसै गरी हाम्रो स्टडीले के भन्छ भन्दाखेरि पोलिसिज इन्क्लुडिङ सोसल प्रोटेक्सन मस्ट बी इम्प्लिमेन्टेड इन नेपाल टु रिच द इन टिबी स्ट्राटेजिक गोल्स। जस्तै अब बिरामीलाई चाहिँ टिबी मेडिसिन मात्रै फ्री भएर हुँदैन, उहाँहरूलाई चाहिँ न्युट्रिसनल सपोर्ट, त्यसरी उहाँहरूलाई चाहिँ अब हामीले चाहिँ केही पैसाहरू दिन सक्यौं भने उहाँहरूलाई चाहिँ अब ट्रान्सपोर्टेसनहरू एकोमोडेसनको बेला चाहिँ उनीलाई बियर गर्न सक्यौं भने चाहिँ हामीले इन्टिभी स्ट्र्याटेजी गोल पनि हामीले मिट गर्न सक्छौं र त्यस्ता पोलिसीहरू चाहिँ डेभलप गर्नुपर्छ भन्ने चाहिँ हाम्रो कन्क्लुजनबाट आयो र अनि we'd like to acknowledge all patients and their families, BNMT district program coordinators and national TV program authorities. हामी उहाँलाई चाहिँ एक्नोलेजमेन्ट्स गर्न चाहन्छौं र यति भन्दै मेरो प्रेजेन्टेसन चाहिँ मैले यही कन्क्लुड गर्न चाहे। हस्, थ्यांक यू।
हस्, धन्यवाद भोलाजी तपाईको प्रेजेन्टेसनको लागि। अब आजको सेसनको र आज दिनभरकै अन्तिम प्रस्तुति I would like to invite Noah Datta Subedi. Topic of presentation is minimally invasive tissue sampling technique, a useful tool for establishing cause of death. Noah Datta Subedi ji.
Namaste, greetings to all. On behalf of the research team Decode MON project, I am here to present the findings of minimally invasive tissue sampling technique for determination of cause of death among natural deaths in the Gandaki province of Nepal. In Nepal, only forensic autopsies are conducted and clinical autopsy is rarely conducted because it has several constraints, including the lack of facility, lack of trained manpower, and this is the reason why the cause of death remains undetermined in a high proportion of cases. Even after medical legal autopsies, the cause of death remain undetermined in quite good number of cases. Because the medical legal autopsies are also not backed up by ancillary laboratory tests, so this could be the result. To overcome the constraints of complete diagnostic autopsy, a new technique has been developed, that is the MITS technique, minimally invasive tissue sampling technique. It has been proven to be a useful tool to establish cause of death in low resource settings. So what is MITS? MITS is a simple procedure of sampling of fluid and key organs from the deceased using biopsy needles, and those specimens and the samples, they are undergone investigations like histopathological, microbiological and molecular investigations based on the availability and the needs, coming to the diagnosis and determining the cause of death. As complete diagnostic autopsies, they are associated with dissection and exploration of the body, so which could be one of the factor relatives. Minimally invasive tissue sampling, as it just uses the minimally invasive procedures of punctures of the different part of the body, so it doesn't leave any deformities and incision marks. So it has been accepted in most of the context. So on this background, this research was conducted with the objective to identify the causes of death incorporating MITS in the study population. The specific objective included the exploration of the etiological microorganisms by the microbiological test and to find out pathology by histopathology and serology. It is a quantitative cross-sectional observational study conducted at the three settings in the Gandaki province of Nepal: Gandaki Medical College, Pokhara Academy of Health Sciences, and Damoli Hospital. The duration of the case enrollment was from 14th November 2019 to 15th January 2021. However, because of the national lockdown in the first phase, the case enrollment was paused during the lockdown and later resumed. The inclusion criteria consisted of death due to natural disease, either broad death, sudden death, or death in the hospital also. And the deceased with age more than 18 years were taken. It was conducted in the adult population. Whereas the violent deaths like accidental, suicidal, and homicidal deaths, along with the decomposed bodies, were excluded from the study. So this shows the case enrollment flow chart. We included both the clinical and forensic cases. 257 deaths were reported in the study units of the sites in the study duration, where 200 were meeting the inclusion criteria. Among them, 70 were approached for consent, and 22 of them consented and enrolled. About 130 cases could not be approached, particularly because of the COVID-19 situation, and priority was given to patient care rather than the facilities to be used in the research. Whereas the 501 medical legal autopsy conducted at the study sites in the duration, among them 78 were meeting the inclusion criteria, and all of them consented and were enrolled into the study. So total 100 cases were enrolled. The samples collected from the body were CSF, 5 to 10 ml of CSF, which was subjected to microscopic examination and culture. 15 to 20 ml of blood was taken from subclavian veins, and it was subjected to serology, culture, and thick and thin smear to detect the malarial parasite. The mid sample for microbiology consisted of left and right lung tissue samples, which were taken for culture and gene expert. And the MITs for histology consisted of the samples from brain tissue taken from occipital and transnasal approach, and left and right lung tissue and liver tissue. They were subjected to hematoxylin and eosin sections, and if needed, the special stains like ZN and PAS were also used. The determination of cause of death consisted of an established protocol in our research project, where we collected the antemortem information, past medical history, family history, physical examination finding, and complete diagnostic autopsy findings if that was done. And it was collected into a special form prepared for our study, and the coordinator was responsible for collecting and analyzing those forms. Later, they were sent to histopathologists and microbiologists who were blinded till the case discussions were done, and they reported the cause of death. Both microbiology and pathology diagnosis were given in ICD-10 code, and the revised form was now handed over to the coordinator, who would send the report electronically to the decode members. And case discussions were done in scheduled meeting as well as asynchronous discussions, where the cause of death was determined based on consensus following the WHO format of death certification. And if any doubt, the cases were consulted with experts of related field, and then the inputs were taken to determine the cause of death. Now, coming to the results, total 100 cases were enrolled in the study with mean age of 50.8 years with standard deviation 15.9, and the age ranged from 18 to 84 years. Among the 100 cases, 76 were males and 24 were females. Most of them were homemakers, manual workers, and unemployed. 62 of them were chronic smokers, 46 used to consume smokeless tobacco, 73 consumed alcohol, and only 4 of them also consumed the other drugs of abuse. 76 of them had died in the community outside the hospital facility, whereas 24 had died in the hospital. This table shows the histopathological findings in clinical and forensic cases. Cryptococcosis was diagnosed from the brain tissue sample in 1, and it was unremarkable in rest of the cases. Whereas anthracosis was a very common finding. It was present in 81 cases, though it was not responsible for the cause of death in most instances. Whereas pneumonia was the most common finding in 33 cases. Whereas the liver histopathology showed steatosis in 33 cases. This shows the 10 most common etiological microorganisms. Klebsiella oxytoca and Klebsiella pneumonia were the commonest microorganisms involved. The serological diagnosis was done to detect brucellosis in 6 cases, dengue in 4, HIV and hepatitis each in 2, and malaria in 1 case. The immediate cause of death was classified to determine the category of death, where 77 of them were infectious, 10 were of cardiovascular origin, 8 central nervous system, 2 each gastrointestinal and malignancy, and in only 1 case the cause of death was not determined. The cause of death was further categorized based on the presence of cause of death in the causal chain of event, that is the part 1 of WHO death certificate, which shows that bacterial pneumonia was present in 68 of the cases. Among the cardiovascular causes, atherosclerotic heart disease was seen in 6 cases. Among the central nervous system causes, meningeal hemorrhages was diagnosed in 8 cases. And among the gastrointestinal and hepatobiliary causes, alcoholic cirrhosis of the liver was seen in 3 cases. Malignancy was diagnosed in 4 of the cases. We analyzed the contribution of myths to establish cause of death. As you can see here, myths contributed to diagnose the immediate cause of death in 79% of the cases, antecedent and underlying only in 45 cases, and contributory causes in 89 cases. So when it was taken in overall, in 95 cases, myths contributed something in the death certification. As infectious causes were the most common category, we analyzed the capacity of myths to diagnose cause of death in infectious and non-infectious causes, and it was shown that myths was successful to give the cause of death significantly more in infectious causes than the non-infectious causes. Coming to the discussion, myths implementation was very helpful to establish the cause of death in our setting, where many of the deaths would have gone undiagnosed. The incorporation of myths was really helpful to determine the cause of death. It was helpful to establish some conditions which were never diagnosed during the lifetime of the disease, like the 4 cases of tuberculosis, 2 cases of HIV and hepatitis B both, and in 1 case of malignancy, the cause of death was never diagnosed during the lifetime. So the information is very important to the family members of the deceased so that they can plan for the screening test or the preventive measures. And it is also helpful for planning for preventive measures. Concluding, myths technique was useful to establish cause of death in our settings. Most of the deaths were identified to have infectious causes, and pneumonia was the most common infectious disease, and Klebsiella was the most common etiological organism. So the recommendation from our study is myths technique is a reliable tool in determining the cause of death in low resource setting where there are several constraints to clinical autopsies. The limitations included the lack of antemortem clinical records and the COVID-19 crisis. This study is funded by Myth Surveillance Alliance.
Thank you. Thank you, Dr. Subedi, for your nice presentation. So, with this, we have completed the presentations. So, I would like to congratulate you all presenters with your full skills and knowledge of your complete presentations. Now we have short session of Q&A, question and answer session. I will request. We have few questions and most of them are comments. I would like to request to Dr. Suresh to address upon the comments and the questions.
So I have a few questions. Let me categorize, and thank you for the questions. One category is, why haven't we been able to practice the reduced out-of-pocket expenditure? It could be different. We really need to conduct the specific analysis which we call the public expenditure review. PER is a comprehensive analysis which will give us real answer, but However, there are different ways, right? It could mean to over medicalization, weak insurance scheme in the country, over prescribing, self prescribing, on regulatory pharmacy across the country, because the major contributor to the out-of-pocket expenditure is the medicine. So we need to really further dive down and disaggregate these information so that we can get the answer. Thank you for this beautiful question. And second is, why haven't we really been able to see the decline in maternal mortality? So when you look at the fourth slide, I was showing that who were benefiting, who were coming to the institutional delivery. The large chunk of urban and richer population are coming to the institutional delivery. Their socioeconomic and nutritional status in this country is better than those of poor people. And in technical terms, it could be, we call concentrated epidemic. Maybe it's a concentrated problem here, and it's not reducing. In a health economics term, we call is, we have already grabbed the low-hanging fruits, and the hard nuts are yet to be touched upon. So that's why maybe it's, the issue is now more concentrated in the rural area, hard to reach area, and or among the poor. That's why we are not being able to really see the decline in over 5-7 years of the time. Thank you, Deepak Karkiji, Sushil Lekhakji, for those questions, and Nijan, and again Sushilji, saying what would be the best study model that really tells us that whether our healthcare delivery system are equitable. So again, the methodology and study design called benefit incidence analysis, we call BIA, would help understand the level of disparity or equity in healthcare delivery system. We have conducted in 2010, I guess, which I can share, but I think we need to conduct another one to really understand the equity factor. And again, public expenditure review would also help in understanding the disparity. These are the major questions that I got, other than comments. Over to you, Dr. Lone.
Thank you, Dr. Saab, for clarification. I now request Dr. Krishnan, if you have some comments, just address them.
Thank you so much, Chair. There are not many questions for us for this presentation. There was one comment which we basically accept, and this is, I take this opportunity to reiterate the importance of risk factors by this comment. They have said that lifestyle modification would be required, and we need more studies for that. And thank you for commenting on that. And we all agree, risk factors, prevention and control of risk factors in the population level is very important to reduce the overall burden of disease. And that would ultimately reduce different, especially the rising burden of disease due to non-communicable diseases would be curbed down by acting on that. And for that, we have the country plan, the non-communicable disease multi-sectoral action plan, which is being, the new one is being formulated. And the previous one, which lasted for the period of 6 years from 2014 to 20, which Dr. Lohani himself took the lead of formulating that action plan. And the new one is coming up soon under the leadership of Epidemiology and Disease Control Division. And such plans and policies and strategies effectively implemented in the country would definitely help us reduce the overall risk factors level in the country. Thank you so much.
Thank you, Dr. Saab. I now request the rest of the presenters, if you have any questions, please respond them in chat box. So with this, I now request my colleague, Dr. Bhojraj, please put your comments and remarks. Dr. Bhojraj.
Very well, sir. I'm seeing you. Nice to see you there. Excellent power packed and eye opener presentation for 2 hours. The 3 invited talks and 6 presentation by speakers on their respective works. There are comments of happiness on their works on chat box from all the attendees. It itself proves that all the presentations were of high quality, and it will amplify our research areas. Dr. Suresh Tiwari's presentation on paradigm shift and need of policy reformation to find cause of gap and equity was excellent. Madam Dr. Sapkota highlighted on intervention RMNCS very nicely. Dr. Dhimal Krishna's work on was eye-opener, especially for modifiable risk factors. There are very interesting observation on modifiable risk factors, and the 6 presenters were all on their times with their respective due fields. Especially, I liked on the professionalism of nursing careers, how Manuka Madam has highlighted it. And we are already running short of time. I thank NHRC team, especially Professor Baral and Dr. Gauli, and thanks to NHRC again. And I request to conclude today's overall day's session to Dr. Luhani sir.
Thank you, Dr. Saab. So, I would, at the end, the importance of this summit of the sessions is to gather the evidence which would be translated to the policy makers, to policy making process. So it is a difficult process to translate. So I now request you all, we all, to facilitate, to remove that difficulty. With this, I would like to say thank you to all who are with us physically here and in virtually, to the keynote speakers, to the presenters, and I will now conclude this session with this saying. Thank you very much. Thank you.
Thank you, Dr. Gunaraj Lohani, Dr. Bhojraj Adhikari, and all the presenters for making this session vibrant. We hope that these scientific findings will provide evidence for decision making and policy formulation. Finally, to wrap up this session, I would like to request Dr. Gunaraj Lohani to present the token of love to our invited speakers, Dr. Suresh Tiwari and Dr. Krishna Kumar Aryal. Dr. Suresh Tiwari. Likewise, I would like to invite Professor Dr. Bhagwan Koirala, Chairman of Nepal Medical Council, and Dr. Pradeep Keoli, Executive Chief Member Secretary of Nepal Health Research Council jointly, to present the token of love to our respected Chair Dr. Gunaraj Lohani. Also, I would like to request all our members, participants for the group photo. With this, I would like to inform you that this session has been ended. However, our program has not been ended yet. We will resume at 8 a.m. tomorrow on 2nd July 2021 with next session. Thank you all.
I'm going to talk to you this evening on the subject of the spectrum of love. We know that from time to time there arise among human beings